A, ve- a very good morning, everyone. Welcome to Rehab Conclave, Bangkok 2024, on the theme of advancements and strategies in rehabilitation care. Before we move to the conference, I would like to welcome everyone and give a brief introduction about our Rehab Conclave, Bangkok 2024, which is being organized by BioLeaks, which focus restoring individuals to health and normal life through training and therapy following addiction or illness. As a crucial component of universe health coverage, rehabilitation complements health promotion, disease prevention, treatment, and palliative care. The conclave aims to unite leading academic scientists, students, researchers, and scholars to share their experience and research findings across various aspects of rehabilitation. Our organizers are BioLeaks, which is a non-profit professional association which prominently promotes research and development. We at BioLeaks have brought a revolution in field of worldwide conferences. BioLeaks connects events worldwide, which helps in enhancing the skill set of people from diverse industries and also forms a common platform for eminent personalities, physicians, researchers, doctors, and academicians, professional business figures, and much more. We work with our motto of creating better tomorrow by organizing conferences and creating a network which will help grow a better tomorrow with the help of advanced technology and achievement. Some of our academic partners is VSPM COP Nagpur. VSPM's College of Physiotherapy was established in year 1999 by VSPMAHE under the visionary guidance of Honorable Chairman Sri Ranjit Babu Deshmukh and founder Sri Bau Sahib Bhoge. Yearly, it takes of 60 undergraduates and 21 postgraduate students, and VSPM's College of Physiotherapy is only physiotherapy in College of Vidarbhada region, running the PhD courses under Maharashtra University of Health Sciences. And our other academic partner is INTI International University. INTI International University is one of the Malaysia's leading private universities, renowned for its commitment to providing quality higher education and producing globally competitive graduates. With a focus of innovative teaching methods, industry driven curriculum, and strong partnership with global institutions, INTI prepares students for success in the dynamic world of work. Sunanda Rajbat University was established in 1937 and elevated to status of leading university in Thailand by 2004. This higher educational institution focuses on providing education, conducting research, and preserving arts and culture. SSRU responds to the need of national development with dedicated vision, be a model university for society at large. And our other academic partner as Modern University for Information and Technology is committed to integrating advanced learning with cutting edge technology across various disciplines, including physiotherapy. The university's physiotherapy program emphasizes a combination of clinical expertise, modern therapeutic techniques, and innovative technology to help students become proficient healthcare. Now, I would like to welcome our welcome address by Professor Dr. Nagub Saheb, MD from MIT University, Egypt, and Professor Pallavi Yalarthi, Head of Department Community Physiotherapy, VSPM COP, Nagpur, India. Now, I would like to welcome our keynote speakers of our conference, Mr. Rajkumar Krishnan Vasanti, Head of Program and Senior Lecturer, Faculty of Health Sciences, Hindi International University, Malaysia. Mr. Kabib Abdullah, SST, MKS, Head of Physiotherapy Study Program, Faculty of Health Science, University of Muhammadiyah. Professor Dr. Priyanshu V. Rathod, Dean, Faculty of Medicine, Professor, School of Physiotherapy, Director of Internal Quality Assurance Cell, RK University, India. Dr. Y. Praveen Kumar, Professor and Head of Department, VSPMS College of Physiotherapy and Lata Mangeshkar Hospital, Nagpur, India. Dr. Alson Chong Wai Kwang, Vice Chairman of the Asian Federation of Sports Medicine Education and Scientific Commission, Malaysia. Assistant Professor Dr. Suryanand Sompong, Director of Director of Olympic Study Center, Faculty of Science and Technology, Sunanda Rajbat University, Bangkok, Thailand. Professor Dr. Nagub Saib, MD, Dean, Faculty of Physical Therapy, MTI University, Egypt. Professor Dr. Marwa Abdul El Rahman Mohammed, Vice Dean for Students Affairs, Faculty of Physical Therapy, Helwan National University, Egypt. Dr. Durga Pratap Ganeshan, MPT, CMP, OMT, MIAP, former Assistant Professor, Director, and Head Physiotherapist at Dr. GD Physiotherapy and Fitness India's first BFR Instruction, India. Ms. Maria Petromelidio, Head of Physiotherapy, Rayo Vallecano de Madrid, SED, Spain. Mr. Hernan C. Labaro, Dean, College of Physical and Respiratory Therapy, Our Lady of Fatima University, Philippines. Now I would like to welcome our session chairs. Mr. Tarun Amal Nerkar, Lecturer, Physiotherapy, University Tunku Abdul Rahman, Malaysia. Ms. Noor Husna Ismail, Lecturer, Sports and Exercise Psychology, Asia College of Exercise Medicine, ACEM, Malaysia. Ms. Pavitra Annamalai, Clinical Instructor, Physiotherapy, AIMST University, Malaysia. Ms. Shanmugavaidu, Clinical Instructor, Physiotherapy, AIMST University, Malaysia. Ajita Mishra, Associate Professor, LN Paramedical College, LNCT University, Bhopal, India. Now I would like to welcome Professor Dr. Nagub Saleh, MD from MIT University to address the gathering. Sir, over to you, please.
Hi, good morning, everyone.
Good morning.
Really, it's nice meeting that fantastic group of scientists in physical therapy and rehabilitation. And thank you for inviting me to this conference for the first time for me, really, but I liked it very much. I wanted to attend physically, but for some reasons I couldn't come to meet all the group. When I talk about my lecture or my point of view in vascular rehabilitation, I like it because most of the physiotherapists, they are not going for cardiopulmonary and vascular rehabilitation. Why? Because the risks or many risks happens during rehabilitation of cardiac and vascular system under pathological condition or surgical condition. So I said it's better for me to talk about something the people might need to know about vascular system. My position in Egypt as a professor for many years, being through vice dean and now a dean. Also, I've been routing in many universities in the Middle East. And my thinking way, or the way of thinking, is how to create protocols in clinical applications in physiotherapy, because our role in physiotherapy really is so important to everyone in hospitals. Many specialties, musculoskeletal, neuromuscular, even in gynecologies and pediatrics. So now I will start talking about the bit of information I have. Share. كده مش عايز يفتح لي. اه Mechanics of vascular traumas in physical therapy. Naguib Salim, Professor of Cardiovascular Physical Therapy Rehabilitation, Dean of Faculty of Physical Therapy. This is my university, MTI, Modern University for Technology and Information, which I've been taking place as a dean of this college. What's vascular trauma? Vascular trauma means that a blood vessel has sustained some kind of injuries. Sometimes these injuries involve a tear or puncture, causes blood loss. I will go through very fast to save time. The term vascular trauma refers to the injury of the vessels itself when the blood coming from the heart or returning to the heart. Vascular surgeons categorize these injuries by type of trauma that caused them that injury. I mean blunt or penetrating injury. Blunt injury occur when blood vessels is crushed or stretched. Penetrating injury, such which happens in vessels torn during action, during gaming or athletic performances. These types of trauma can cause blood vessels to clot, causing thrombosis and interrupt blood flow. What are the mechanics of these traumas? As we know, the laminar flow, which is the normal streamlined outermost layers moving slowest and center moving fast because of the blood, because that's normal as a blood friction between the walls and the bloodstream itself. If there is a turbulent flow happens, it will interrupt and the rate of flow exceeded critical velocities because of trauma. This critical velocity will take the law of fluid passes constriction and sharp turn through the rough surface. That's the example of the flow. The upper one drawing show if there is a penetration will interrupt the flow of the blood, which fastly will be circulated all around the trauma itself. That's, for example, the trauma. And then at that direction of the blood, it will be turbinated. As in this diagram, that is a normal flow. And here's the turbination. We know that the flow of the blood with moving from proximal to distal, the pressure increases by 4 folds between area and distal parts. That means the pressure is very high and the temperature be increased at the area being affected, which is turbinated. This turbination is the main problem of vascular traumas because the heat here will be changed. So when it will be changed, it will turn around itself after the trauma. So easily causing turbination, easily causing formation of clot, formation of thrombosis. So this turbulent flow is the main reason for the damage, because the thickness of the blood, the viscosity of the blood will be changed. Many draws just to explain the turbination itself. As we look at that part, that's the penetration, that's the turbination through the vena, veins or arteries. So vascular trauma causes because of arterial diseases, injury, accidental or falling or cutting, violence against the blood system. Anyone can experience vascular trauma, can get a vascular even without moving, without just disease, blood disease will cause vascular traumas. Vascular trauma can lead to a number of complications, loss of blood, sorry, will lead to loss of blood, sometimes large amounts because of penetration, for example, especially in the distal parts. As we said earlier, that the pressure is very high. 4 volts means around 320 millimeter mercury at the distal ends. Also, the vascular trauma causing bruising, swelling, sorry, I'm causing scarring. Scarring or incomplete healing can cause permanent weakness of the artery or the vein, which makes it more prone to future injury. For example, somebody gets vascular trauma. After sometimes he gets stroke, hemiplegia. This hemiplegia caused by the earlier vascular trauma. It is not because of hypertension or other factors. It's all the trauma caused by vascular system. Arterial injuries or trauma includes commonly 50% axillary because of subclavian artery damages, such in shoulder dislocation, or sometimes it causes aneurysms, which secondary to immobilization, 43% popliteal artery injury, 7% intimal hyperplasia, and stenosis involving in external iliac artery and subclavian vein. Sports also causes a variety of vascular problems. High performance athletes are susceptible to a variety of vascular injuries because of the tension over the wall causing laceration of endothelial layers. This laceration of endothelial layers will cause vascular trauma. Sports medicine literature rebuilt with the description of musculoskeletal abnormalities and injuries in active athletes. For example, popliteal artery problem, iliac artery in cycling, supraventricular artery from thoracic outlet syndrome with abduction and external rotation, upper extremity injuries. Upper extremity arterial injury also in athletes were reported in baseball pitchers because of hard throwing, overstretch, overstrain, because thoracic outlet causes thoracic outlets injury of subclavian artery, subclavian stenosis, all of that injuries, humeral aneurysms, all of that factors affecting the vascular anatomy of the extremities and predisposing for the damage happens in the vascular system. dislocated joint, fractured bone. For example, supracondylar humerus fracture. I have seen it myself, that a boy has fallen from a chair and fracture of supracondylar fracture and causes brachial artery stenosis. The surgeon quickly recovered the reduction because worry of the damage happens in the arms. Many accidents and activities can lead to vascular trauma. I don't want to go through the most important is the diagnosis. We as a physiotherapist must notice these changes after the traumas, the history of the trauma. For that reason, diagnosis by physical examination only not enough. We got to go through other diagnosis factors such as ultrasonic, CT scan, MRIs, angiography for sometimes is a must. Precaution in physical therapy, be careful in differential diagnosis, in taking history from the patient, assure medical diagnosis, caution in manipulation and mobilization to avoid strain or stretch the vascular system, caution in stretching, follow rules in warming up and cooling down. That's all. So I have a statement, really, I like to say it, especially with the organizer of the oops. Sometimes I forget to thank the people who make my life happy in so many ways. Sometimes I forget to tell them how much I really do appreciate the effort they do for being an important part of my life. So thank you all of you, just for being here for me. Thanks a lot.
Thank you, sir. Thank you so much for your informative talk also. We are happy to have you here with us today, sir.
Thank you. Thank you being with you. With you all.
Thank you, sir. Now I would like to welcome our Professor Pallavi LRT, Head of Department Community Physiotherapy, VSP MCOP, Nagpur, India, to address the gathering. Ma'am, over to you, please.
Thank you, Roshni. Ladies and gentlemen, esteemed guests, distinguished speakers, and our participants from the globe, on behalf of the organizing committee, BioLeague, and our academic partners, it's my honor to welcome you to Rehab Conclave, Bangkok 2024, being held this year in Bangkok. We are thrilled to bring together experts, practitioners, stakeholders in the field of rehabilitation to say we are here to come together, draw some conclusion how to grow our field, how to benefit our society in terms of best practices, in terms of innovations, and we have to share our knowledge irrespective of our geological boundaries. Over the next 2 days, we will dwell into cutting edge research, clinical applications, emerging trends in rehabilitation. Our platform ensures accessibility and inclusivity, allowing us to connect and learn from each other regardless of our geographical areas and our countries. The key highlight of our conference, we are having more than 10 prominent key speakers across the globe, and we are grateful to our speakers. We are grateful to our participants. And moreover, here I would like to tell so successfully along with our academic partners. Thank you for joining us. Let's make this conference a resounding success. Please feel free to interact, ask questions, engage with our speakers and fellow participants. Let's begin with the enriching experience. Thank you. Thank you all. Over to you, Roshni madam.
Thank you, ma'am. Thank you so much for your words. Now we'll start with a conference with our first keynote speaker of our day, Mr. Rajkumar Krishnan Vasanti, Head of Program and Senior Lecturer, Faculty of Health Science, INTI International University, Malaysia. So has shared us his pre-recorded video as a part of speech. Now we'll delve into that.
Right into our rehabilitation. Hi, very good morning to everyone. My name is Raj, and I'm from India International University from Malaysia. So today we are going to see something about an innovative tool which we need to incorporate into our rehabilitation practice. So today my title is Revolutionizing Rehabilitation Service with digital interventions, surpassing the traditional limits. So what I mean to say over here, it's very important for us to transformate ourselves or to shift in the way we approach rehabilitation. As technology is evolves, digital tools allow us to exceed the boundary of traditional rehabilitation. After innovative personalized solution that enhances recovery experience and also the better outcome for the patient. This revolution, the revolution, it's going to be a very much a promise tool to redefine patient care. So this is what we are going to see in next few slides, how to develop this kind of digital interventions. What are the barriers we may face? What are the benefits of utilizing digital tools? How the industry is in this society or globally, how the industry has grown and how it can impact or how it can be helpful for our rehabilitation um treatment, so which we will be seeing in next few slides. Okay, so if you look into a background, digital health, we all heard of the term digital health. So digital health, or we can say as a digital technology for health, is a salient field of practice. What we do there, it's basically we employing the routine and innovative form of technologies to address the health needs. So that is basically digital health. If you look into this digital health, we going to utilize various tools like mobile phones, laptops, desktops, or even we can use a cloud-based system, Internet of Things. So all this we are going to utilize to give the better interventions through this to the patient or an affordable intervention to the patient. So when you look into this word digital health, it's actually rooted from a word called e-health. Why they call it as e-health? It's because they use the information and the communication technology to or in supporting the health and health related field. So that's we called it e-health. When you look into this digital technologies, or we can say as a industrial revolution, because all the technologies are coming from the industry. So our industry has been revolutionized for many years. So when you look into 19 I mean 70s 1780s, Okay, so that's where the industry revolution start booming up, where we call it as industrial revolution 1.0. Currently, when we see now in 2020s, we are into an industrial revolution 5.0, where the systems are drastically changing from just a machine now to a robot or to an artificial intelligence. Many things are now into picture. So we are going to utilize this kind of technology that has revolutionized all this while. We're going to create this technology, and we're going to incorporate this technology into the medical and rehabilitation services to our patients, which is going to be a cutting edge of treatment to the actual delivery of specific interventions that has been revolutionized from 1 to 5 currently. What we are going to do over here, we are going to use this Internet of Things. We are going to use robotics with a human touch. That's where the Industrial Revolution 5.0, it's all about, with a human touch. Going to give the therapeutic interventions. We are going to monitor the patient remote, or we are going to monitor the patient progress remotely. It's not necessary the patient need to come to you. So where we can monitor the patient remotely on the progress, everything. And also we can educate them, like public health, preventive medicine, consultations to certain extent, trainings, and also other means of networking with peoples. It's not only just a patient or differently able people, even with the healthcare professions, they can communicate each other to come up with an idea to give a better treatment to the patient. So that's where this industrial revolution now it helps us. So we have to observe it and we have to utilize it into our treatment methods. Okay. So how to develop this treatment method? What is necessary to develop this treatment method? This digital interventions, or we call it as digital ecosystem. How to mold this ecosystem? If you look into the before, long time before, we are organization centered, or we call a hospital centered healthcare model. Currently, it has been moved. The healthcare model should be patient centered, whether the patient is affordable, patient is accessible, patient is feasible to get the service or not. So that's is very important, rather than organization centered, wherever you can start a hospital, something like that before. Now, whether patient can be accessible, it's feasible, affordable. So all has to be look into picture. So that's why we call it as the ecosystem health. So if you look into it, specifically the ecosystem for digital health, where it starts from, the basic thing is we need to start from the supportive devices. For what? For monitoring the patient, or to giving advice, or to educate, or to assess the patient. So very simple device, mobile phones, laptops, so some other devices, wireless devices, or even wired devices, which we use to monitor the patient's progress, or to give interventions, or to give advice, educate. Okay, so that's number one, the minimal resource. Okay, in terms of digital health. Second one, it's the digital health literacy. Every healthcare worker, and also every people, should have a set of skills and also knowledge and attitudes the person needs in order to develop how to functionally use this information technology into their treatment to benefit either the patient clients or the healthcare workers. And social networks, using the social networks, online systems, how to promote systems. So this is we need. Number four, which is a big data, the cloud storing systems, big data in order to decision making. Okay, so you have to collect the big data and we can come up with a decision easily and faster. Number three, e-health governance. E-health governance means it's all this, the things like health literacy, or social networks, or even the big data. Okay, all this doesn't going to come very easily. So we have to have a policymakers. Policymakers will come into this picture where it can be a national level, it can be a regional level, or it can be a global level. So that they have to have a proper coordination tools. That's why we call it as e-health governance kind of people will have to come into this picture to frame all this needs. And also we must have a telehealth or telemedicine services where we are going to use the information and communication technology. And also we must have a proper standard and interoperability uh, things. We have to look into that, like communication between the technologies and software application, using the standards for effective, accurate, and also a reliable exchange and use of data, whatever we are going to collect. Okay, and also we must have a proper electronic health record storage. Um, what to say? Recorded things, so which can help them in future to verify all these things. So this entire ecosystem we call a digital health ecosystem has to be formulated before we are really come up with any tools, okay, in order to implement the necessary things. Okay, so who is targeted? So who are the clients, or who is, it's not only the clients, it's even the healthcare workers. So we need to know who are the people who is targeted for this ecosystem. Number one, it's the clients. Clients is our patients. Okay, so the public who are potential or the current users of health services, including health promotions, activities, caregivers of the clients, caregivers of the clients receiving health services are also included in this group. Health workers like doctors, physiotherapists, nurses, social workers. So all these healthcare workers must be educated on this ecosystem. Then health system managers. Who is the health system managers? Where they are going to manage the resources. Okay, they are the managers who manage the resources, oversight of the system, supply chain management, health financing, human resource management. So all these people need to be known about this ecosystem. So in order to come with a fruitful, effective outcome. Okay, and last but not least, the data service, which is a cross-cutting functionality to support a wide range of activities related to data collection, management, use, and also exchange of data, whatever we are storing. So we need the network people. That's we call it as data services. So all these people are targeted, basically clients, health workers, data services people, health management system managers. So we have to educate them, and we have, because they are the targeted people, in order they, because they will be using this tools to enhance the patient intervention. Okay, so why targeted for this ecosystem? We know who is targeted, why we targeted this. Because if you look into the health system, WHO, World Health Organization, has said that we are facing many health system challenges. Like, for example, poor demand for services. Patient doesn't get a proper services at proper time, okay, to get a proper cure. Failure to follow up guidelines. Patient doesn't follow up sometimes. We also, the therapists or the rehabilitation physicians or the rehabilitation therapists cannot monitor them continuously. Okay, failure to follow the guidelines. Sometimes commodity stock up, insufficient workforce, inaccessibility of the facilities. So all this kind of limited challenges or health system challenges will going to affect the quality and coverage of health interventions. So what WHO has said, we have to move from these challenges very drastic. So how? The one and only way is digital health interventions. So this going to overcome the poor demand. This is going to overcome the failure to follow the guidelines. This will overcome to uh, follow the insufficient workforce and everything, which is going to help from traditional to digital interventions, which helps in many ways of the patient. So is this ecosystem is possible? We all have to think basic. Is this possible? Of course, we have many systems. We think like, oh, that's not possible. Oh, this area is internet is not accessible. I cannot communicate with them. So we have all this pros and cons in order to implement this. So we all will be pondering whether is this ecosystem is possible. Yes, it is possible. I give you some of the facts where you guys can understand based on these facts. First thing, internet penetration rate. We know in the worldwide there are over 4.6 billion active internet users are there. If you know about this, so this is basically like more than 6 out of every 10 or 65.6% of people in the entire world has internet access. Okay, so that's a very important thing. And mostly 40% of Internet of Things technologies are all health related matters. Okay, so that's what NCBI has reported recently. Okay, so based on the 65% internet users, so we can do wonders using this digital interventions. Okay, so this is how the technology has progressed now. So we have to progress as well. Okay, so 1990s, you see, telephones, pre-recorded videos, live videos in 1990s. Okay, from 80s, from 90s, web-based interactive software, text messaging. When come to now recent age smartphones, applications, Internet of Things, chatbots. So all this artificial intelligence, okay, cloud computing. So all this comes into picture recently, which is going to help our way of treatment, our way of delivering the treatment to the patient. Okay, so that's, and also there is a need in the need of rise for this digital interventions. You know what? This is the fact. So 22% of the world population by 2050 we will be elderly population. We call baby boomers elderly. Okay, which is about 7.8 billion. So with this projected number 22%, so you have to know is that everyone can come to the rehabilitation department physically. It's going to be challenge because they're already elder, and whether we are able to accommodate everyone at the same time, cannot. Is that easy for us to the affordability also it's going to get it's a matter. Okay, so there's a shift in the global demographic towards a increasing in elderly population, which is one of the main factor. We really need to move into this digital interventions where we need to take care of this baby boomers. Okay, 58% reduction in cost in comparison to inpatient rehabilitation, which is going to help them tremendously. Okay, in terms of using this digital interventions. So how to build this digital interventions? It's very simple. Of course, we are going to incorporate the digital ecosystem, digital health ecosystem people, and then we have to identify, the first thing is we have to identify the engagement drivers, understand the theory behind it, of engaging and developing the hypothesis, why we want to, whom is the targeted population, who you want to give. So you have to identify the engagement drivers, number one. Number two, step two, fine tune with the user testing. Okay, that's kind of a pilot study. Fine tune with the user testing and code design according to the need and engage for futuristic creations. Okay, so you have to do number two. Number three, measuring. Okay, use a quantitative or qualitative data to measure the success. If you really need to refine it again. Okay, so this is how we can able to build the digital interventions. So with that, yeah, of course, digital interventions, it's going to be recommended to many people. Either it can be a client to the provider, okay, client to the provider to telemedicines, or provider to provider, or targeted specific client communication where we can make it healthcare workers only, like healthcare workers decision support, or digital tracking of the clients can be done, and also digital other tools which we can utilize. So the recommended intervention should be easily accessible, at least by using a mobile phone at a minimum. However, this device you can use many other tools as well, like non-mobile devices, including like desktop laptops. So we should have at least a minimum tool so that we can easily communicate with the patient. Okay, so if you see this picture, yeah, you can understand. So this is where we are going to explore the technology in shaping of the future of physiotherapy. Let's remain thoughtful always, open-minded, and be optimized. Okay, so this is we called as a physio-futurist. So where we are going to use artificial intelligence, virtual reality, augmented reality, robotics, 3D printing, genomics, big data. You can see over there is telemonitoring, virtual care, regenerative therapy. So all this is going to be the futuristic physiotherapy model. So we have to start incorporating into our clinical practice. Okay, it's not only physiotherapy, any rehabilitation. Okay, so we have to start incorporating this futuristic model into our practice. And also you have to ask yourself a question based on the effectiveness, based on the accessibility, based on the feasibility, based on the resource used, based on the gender equity and also the rights. You have to ask all these questions in order for us to consolidate your evidence in order to develop a digital ecosystem. Okay, if you're okay with all this evidence consolidation, then yes, you have to go for a digital interventions. Okay, so yeah, we know already now what is digital intervention, how to create this ecosystem. And now we are going to see what is the benefit. So what you're going to get. Yeah, we are going to get a lot. Number one, extremely cost effective. Number two, increase access of users. Number three, infinite number of times new users can be used. Provide prompts, alerts, and based on specific to the protocols. Okay, practitioners to focus on more complex. I mean, the rehabilitation therapists or can focus on more specific complex tasks rather than the simple task where we can use that digital monitoring or chatbots kind of technological use, we can use it. Communication and performance feedback can be given through digital interventions. Lower the number of admissions and readmissions in the hospital. Provide checklist according to the protocol. So the patient itself can follow or adhere and we can monitor that, okay, through digitally. Schedule healthcare providers activities. So many things can be easily done using this digital intervention. My concluding remark for today is, of course, technology is going to be like we see from Industrial Revolution 1.0 to 5.0 now. So that's what technology is going to be ever enhancing,
Good morning.
technology. Evolving changes in technology to make physiotherapy and have to move from our mindset and we have to start utilizing technologies into our practice. New phase of physiotherapy applications can facilitate patients, like I said just now. Novel physiotherapy application and the effect of patient behavior change and the patient exercise capacity will be improved if you start utilizing this digital interventions. So with that, I would like to say a word from Simon Preston. So what he said is basically the biggest part of our digital transformation is changing behavior. So we start thinking and we start adapting things or adopting things. It's very important. So once we started doing that, we can change. So that's we have to change. Okay? We have to start incorporating digital interventions into our field of practice. So which can enhance uh, our field of practice and also which can enhance the treatment, it enhance the quality and accessibility and affordability of the patient, which is very important for a sustainable future. With that, thank you everyone and thank you Bioli for giving this opportunity for INTI as a co-organizer of this conference, and also I'm thanking all the organizing committee members for this conference. And from INTI, we would like to thank again the organizers. Thank you so much and have a nice day. Uh,
Oh, very thank you, sir, for that informative session. And now I would like to move on to our next keynote speaker of our day. Now I would like to welcome Dr. Y. Praveen Kumar, Professor and Head of Department, YSPMS College of Physiotherapy and Lata Mangeshkar Hospital, Nagpur, India. Sir, over to you, please.
A very good morning to one and all. Madam, can I share my screen?
Yes, sir, please.
Is my screen visible, ma'am?
Yes, sir, it's visible, sir.
Yeah. Thank you, the organizing team, for giving me this opportunity. I'm going to present the pitfalls in research. Research, while essential for generating new knowledge, can be fraught with challenges and potential pitfalls. So there are numerous pitfalls which usually we encounter. So recognizing these pitfalls early can help researchers avoid common mistakes and ensure the validity, reliability, and overall quality of their work. There are some major pitfalls which we have to be aware when we are conducting the research and some probable solutions which could be given. The first important component is the research design, which most of the time in most
So
of the
sorry to
researches,
interrupt
it
you,
is
sir.
poorly defined.
Excuse me, sir. So sorry
Yes.
to interrupt you. We couldn't see your slides at the moment. Could you reshare it, please?
Okay, ma'am. One.
Yeah.
Now is it visible, ma'am?
We could see in our slides format, sir. Now, if you could do the slideshow, it would be great.
Yeah, I'll do. Now is it visible?
Not yet, sir. Yeah.
I think your screen sharing is paused is coming, ma'am.
We could just see the black screen, sir. If it's okay, you could continue in the slides format itself, sir.
Yeah, in the slide format, I'll do it, ma'am.
Okay, thank you, sir.
Fine. Now is it visible now?
Yes, sir, it's visible now.
So research, while essential for generating new knowledge, can be fraught with challenges and potential pitfalls. Recognizing these pitfalls early can help researchers avoid common mistakes and ensure the validity, reliability, and overall quality of their work. So there are major pitfalls which we have to be aware when we are conducting the research, and there are the few probable solutions which I thought I could share with all of you. It is the research question which is usually the major concern, and a poorly defined research question is the one which we have to be very careful of. Starting with a vague and overbroad, unclear research question usually leads to unfocused research, which is having difficulty in data collection and unclear solutions. Therefore, when we formulate a research question, it has to be concise, specific research question or hypothesis that can be realistically addressed within the scope of the study. And it is better to use the PICO format where P stands for participant, I stands for intervention, C stands for comparator, and O stands for the outcome, and if possible, the time frame, which is the T. So you can use the PICO format. The second component is regarding the literature reviews, which is another pitfall. And usually when you're doing the research studies or research publications, failing to thoroughly review existing research or relying on an outdated sources. So this is again one of the important component, because this leads to duplication of work and there are missing gaps in the knowledge which is never bridged. Therefore, it is better to conduct a comprehensive and up-to-date literature review to understand the context of the research and identify where your work fits into the existing of the body of knowledge, along with plugging the research gaps. The third component is in regards to selection bias. So using an unrepresentative sample or improperly selecting participants may result in the skewed data and that finding which cannot be generalized to the larger population. So the better way to go about it is you can start using the random sampling methods so that your sample is representative of population what you are supposed to study. At the same time, be transparent about your limitations if your sample size is not fully representative, and you can put that in your limitations. The next is in regarding the data collections. The pitfall which we usually come across is collecting insufficient and irrelevant or low quality data. This limits the reliability and accuracy of your finding and may lead to incorrect conclusions. So therefore, it is better to develop a robust data collection strategies that ensures relevance, accuracy, and reliability. Even the tools and methods used, example, if you are using a survey or interview or experiment, all such things have to be validated and, and appropriate
ચાલુ
for the
ચાલુ થઈ
research
ગયો મેડમ
study.
આપણામાં.
Next is including the selection bias, interpreting data in the way that confirms pre-existing beliefs or
Professor
hypotheses
Pramuk
while
ચાલે છે.
ignoring the contradictory evidences. This leads to a biased result and undermining the objectivity of the research. So therefore, whatever your biases are there, that should not bias the overall results. Therefore, be open to data that may be contradicting your expectations. And whatever the contradictory findings are there, please put it along with that and use double blind method if possible and consider peer review to reduce bias in interpretations. Along with that, making a sweeping conclusion from the data is again one more important component. So this leads to invalid conclusions that may not hold true beyond the specific study context. Therefore, acknowledge the limitations of your research and avoid making general claims unless supported by the broad, diverse data. Along with that, the ethical component is equally important. Most of the researchers fail to mention sometimes the ethical component. Therefore, ignoring ethical guidelines such as getting the informed consent, engaging in data manipulations or misinterpretations or the findings can all lead to ethical misconduct, so which damages the credibility of the research. At the same time, the risk harm to the participants and may also result in legal consequences or retractions of the research. So it is always better to follow the established ethical guidance, get to approval from the ethics committee or the IRB, and be transparent about your methods and the data. Along with that, using incorrect or inappropriate statistical methods or misinterpreting statistical results can also result in flawed conclusions and reduce the credibility of research. Therefore, use appropriate and validated statistical methods. If at all, you can even, because it's an era of collaborations, you can collaborate with the best of the statisticians so that your data is validated and ensure you have the necessary expertise to analyze the data correctly and consistently, and you can employ the statistician where and when required. Along with that, failing to account for confounding variables may also affect the outcome of the research. Therefore, it is better to include all the components, and if there are any inaccurate findings and misleading interpretations may have an impact on the cause and effect relationship. Therefore, it is better to identify the potential confounding variables very early and either control them in your study design or address them in the data analysis phase. The next component is the reproducibility. This is the most important thing because when conducting the research that cannot be reproduced by others due to lack of transparency or detailed methodology may impact the further basis for evidence generation for the next generation. So therefore, if you have to do that, the impact of that will be undermining the reliability of your findings and credibility of the research. Therefore, provide a clear and detailed description of your methodology, including data collection and analysis procedures, so that others can easily replicate the study if at all it is required. Drawing incorrect or unsupported conclusions from your data may result in misleading findings and weaken the overall impact of the research. Therefore, it is better to interpret the result in the context of your research question and avoid exploiting the findings and consider alternative explanations and limitations. Ignoring or disregarding constructive criticism from peer reviews or experts may result in weaker research and miss opportunities to improve the quality of credibility of your work. Therefore, embrace feedback as a way of reference and improve your research. Always try to address the reviewers' comments thoughtfully and make revisions whenever necessary. Trying to complete research too quickly or skipping important steps in the design, data collection, or analysis may result in incomplete or low quality research, which may allocate sufficient time to each phase of the research process. Rushed research often leads to errors and poor quality outcomes. Not publishing or the research findings after completion is one of the major pitfalls. Suppose there are 100, research going on, hardly 1 to 2% is getting published. Therefore, because what is happening is it is limiting the visibility and the impact of the research, reducing its contribution to the field. So therefore, the aim is to publish your work in the peer-reviewed journal or present it in the relevant conferences and consider open access options for increased research. At the same time, plagiarism is one of the important components. Using others' ideas, data, or text without proper citation or acknowledgement may result in ethical violation, academic misconduct, and potential legal consequences. Therefore, always properly cite all sources of data, ideas, and text. Use plagiarism detection tools to ensure your work is original. And if at all, we can by being aware of these common pitfalls, researchers can take proactive steps to avoid them and enhance the quality, reliability, and impact of their research effort. And if at all, if you cannot you cannot publish your data, at least you can make a simple QR code which has been displayed, which can be displayed. This is the wall of my college where we have displayed some of the things. And thank you from the city of Oranges, Nagpur. And thank you, the organizing committee, for giving me the opportunity to present it. Thank you, madam.
Thank you, sir. Thank you so much for your informative session. The floor is open for question participants. If you have any further queries, you may drop your questions in the chat box. Thank you, sir. I guess there are no more questions from the participants.
Thank you, madam. Thank you once again. Namaskar.
Thank you, sir. Have a good day.
Have a good day.
Now I would like to welcome our next keynote speaker of our day, Mr. Kabib Abdullah S., Head of Physiotherapy Study Program, Faculty of Health Sciences, Universitas Muhammadiyah, Surabaya, Indonesia. Sir, over to you, please.
Okay, is it my voice clear?
Yes, sir, it's pretty audible, sir.
Okay, thank you very much. I start to share screen. Okay. What about my share screen? Is that?
Yes, sir, it's visible.
Okay. Okay, thank you very much for this time. Before I speak, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. First time we have to pray to our God that give us a lot of opportunity and miracle today, so we can meet together in here in Rehab Conclave 2024. I would say thanks to BioLeaks and all of university that support this event. So, ladies and gentlemen, all of you, everyone, allow me to introduce myself to all of you. My name is Habib Abdullah. You can call me Mr. Habib. I am Head of Physical Therapy Programs in Muhammadiyah University of Surabaya, Indonesia. If you have heard Bali, actually Surabaya is very near from Bali, approximately 40 minutes by flight from Surabaya. So next time if you visit Bali, please visit Surabaya too, and we can talk together. I'm very like to do that. So at this time, I want to share a little bit of my experience about pediatric physical therapies. So beside I am a teacher, I am a practitioner of pediatric physical therapies, especially in children with motor dysfunction, especially in cerebral palsy. So I want to share a little bit of my experience about mid-body stabilization as a theory concept for treating patients with cerebral palsy. So at this time, I want to share number one about mid-body stabilization, and then about introduction cerebral palsy, and then clinical practice, and the last is summary of my keynote speak. Okay, we start with mid-body stabilization. What is mid-body stabilization? If we look at this picture, we can look the position of the baby at the 4 months. This is midline or mid-body stabilization in supine. This is the first step of mid-body stabilization because there are several steps, supine and then sitting and then standing. So I just share about the supine position. So the definition is connection between head to our trunk and also all distal side or the extremity. And this connection not only connect our musculoskeletal system, but also connect our neuromuscular system. We can see at this picture that the baby with the supine position doing mid-body stabilization, he can doing this position very well at the midline of the body. So we can see the fine motor of the hand and the eyes contact to the toy. This is very important. And we have to move to the next slide. Yes, if we zoom in on this picture, this is midline or mid-body stabilization at the supine position. This connect a lot of things. The number one about the neuromuscular system, as we know at the brainstem, and the development of brainstem, we have three reflex, a vestibulo-ocular reflex, that is reflect on the stabilization of the eyes. And then a VCR vestibulo-occult reflex, that is reflect on the neck, on the muscle of the neck. And VSR vestibulospine reflex, reflect in all our spine. So the neuromuscular connection will make a connection to our muscle. That is eyes muscle, and then a deep neck flexor or core muscle in the neck, and then core muscle in our abdomen. So this connection will make the baby grow with the eye contact and then fine motor development. So this position very important, and we can see at the cerebral palsy or maybe children with gross motor impairment, this position was failed. We can see at the next slide. Okay, midline stabilization or mid-body stabilization, as I said before, not only in supine position, but in other next level position, sitting position, and then standing position. So if the children or child failed in this position, we can predict, we can say that he will fail on the next body stabilization position. So this is the first step. This is the first step. We have to assess of the children with cerebral palsy, and we have to teach how to do this position. Okay, we throw back to the pregnancy exactly in third trimester because this is the first time human or fetus will learn about mid-body stabilization at the first time. Why the fetus doing position like this, mid-body stabilization, all of the part of the body going to the midline?
Yes.
Sorry, can you mute? I'm sorry, can you mute the microphone? Okay, I will continue. Okay, so why the fetus learn about this position or doing this position? Because the size of the fetus day by day getting increased. Day by day they getting bigger. And then the uterus, the womb of the mother, cannot provide room or elasticity anymore. So this is the passive position. The fetus has to do this position. This position very important in all of development. The number one is about the movement or gross motor movement, because this position connection or connect head to the body to the extremity. So we can say that at this time the fetus can kick, can push, can touch the mother's womb. This is very important. And then not only in gross motor, this position is very important to oral function. We know that oral function is very important to sucking, to swallowing, where when they're breastfeeding, and then to reproduce the sound and to speak and to swallow and to bite and etc. So oral function will increase of the function while the position mid stabilization happened. And the last, this position very important to sensory information to the brain, especially in vestibular information and then some other sensory information from skin, from muscle, and from joint. So we can say that this position very important to development gross motor function and then oral function and then sensory information to the baby brain. And then the baby will born, and we can see the difference between baby or neonatus in 1 month and then 2 months until 6 months. We look at here at the first month of the baby. It's look like mid-body stabilization was gone or maybe not present. What happened? Because the baby at the first month, there's still adaptation. They still adapt to the gravity interaction. So the mid-body stabilization not really present at this time. But we can see at the 3 months and then 4, 5, and 6 months, we can see very clearly that mid-body stabilization in supine very perfect, like a third trimester in the womb of the mother. So at the picture number 4, 5, and 6 is very stabilized in supine position. We can see at the children. Yes, this is our patient in our hospital, children with GDD, global delay development. We can see that there is no stabilization in midline at all. This girl, little girl, and this girl, we can see that it's look like at this picture, and there is no stabilization at all in the midline. So they prove a position, wrong position in extension position, in rotation position. So the stabilization of the mid body was not present. That is very poor and dangerous if we're not giving exercise for these children. So what kind of exercise we can see at the next slide. And then I will show children with cerebral palsy. This is the severe cases of cerebral palsy. We can see cerebral palsy with several types in here. Spastic quadriplegia and then spastic diplegia. We can see very clear that these children have no mid-body stabilization at all. And the position of head, of trunk, of extremity is out of axis in the midline. Extension with combination of rotation. So these children need to giving exercise from physical therapists. So what kind of exercise we can see at the next slide. Okay, before we enter on the exercise of mid-body stabilization, I will introduce what is cerebral palsy at the next 2 slides. Cerebral palsy is a brain development disorder characterized by impaired movement and posture. This is both an underlying posture. Posture is very correlated with mid-body stabilization in the middle of our body posture. So at this children, as this child with cerebral palsy, we can see impaired in posture and movement, of course. And then about the epidemiology at the world, about the number of cerebral palsy children, 2 until 3 cerebral palsy children has birth, and every 1,000 of live birth. With high-risk infant born in prematurity and low birth weight, it can be a cerebral palsy baby or children. So this is the problem of impaired movement and posture in my patient. We can see that from head to the toe, a lot of problem in here. Number one, from the eyes, upward gaze. He always look at the upward position, and then it makes the extension of the neck. So the movement of all the body is extensor dominant. It's very difficult to move with the children or child with this pattern. And also the hand function and feet movement was very poor because a lot of spasticity in their extremity. So what should we do as a physical therapist? So I will present clinical practice, our practice in our hospital and clinic. Okay, there are 3 steps that usually we use to treat a patient with motor dysfunction, especially in cerebral palsy. Number one, we have to treat exercise in the eyes, and then neck, and then trunk. So this is the blueprint. Uh, we will do this exercise and copy this position to the children with a gross motor impairment. So this is the blueprint of position. We start with eyes and then neck and then trunk. So we copy this position to this patient. Okay, number one, we're doing some exercise in the eyes. So we will manipulate the muscle in this frontalis muscle. We doing this exercise to down, so the visual or the eyes will going to downward. The eyes is very strong connection to the neck and to the trunk. If the eyes in the right position, in access position, it will easy to make some movement. But if the eye is going everywhere, upward position or maybe rotation position, so we very difficult to make our children with cerebral palsy to move. Number one is eyes position, and then number two is neck position. What can we do with the neck? So we do some movement we call a capital flexion. A capital flexion is a small movement in the core of our neck. We facilitate the inner muscle in here. Yeah, so if we successful doing this capital flexion, or we can say chin down exercise, we can manage the trunk very well. So the step is from eyes and then neck, and then we move to the trunk. And the next step is trunk position. We are setting the neck and the trunk in the midline position very well, like this. So we're doing much more myofascial release, and then massage, and then a mobilization of the bone and articulation or joint in several places in here. And then the last, we're doing some we name cortical level activity. So the children or the patient must look to the toy. A lot of toy, we can do some toys, some books, or maybe phone with interest picture or maybe song. So the eyes and the neck of the children can doing or move to downward. This is very important. The last thing, because it's the copy position from stabilization in midline in a 4-month baby. Okay, this is several patients in our hospital. We're doing some midline stabilization exercise and position, and we're doing some cortical level activity with several toys in here. We can see that this is a good position in midline and the downward of the eye and this patient too. And this is our patient cerebral palsy with severe cerebral palsy, spastic quadriplegia. This is the first time I met this patient, and then several times I treat with this concept. Several months, and at the last time we can see this is very different. We can look at this picture. Yeah, this patient will very good in midline position, and then he start to move to make some noise with his mouth, and then the eye contact very good, and then hand function, he can touch the toys, and we can see the feet are very good. So this is the results of our patient. Okay, I have the video maybe. Okay, this is I try to play. Maybe it's okay. Yes, this is my patient at the first time. There is no movement at all because there is no midline stabilization. So after midline stabilization was good, okay, we can.
नहीं रहेंगे वो मेरे से इन्फ्लुएंस अरे
Yeah.
ये क्या है इस पे अगर
Yeah, it's very different development. So these are the patients, spastic diplegia with the impairment in eyes and then neck and then trunk. After we treat with this concept several times, several months, we can see that the midline stabilization in supine was very good, and then the midline stabilization in sitting is very good too. The other patients, spastic quadriplegia with the rotation complication, we can see at here. We're doing some exercise at the eyes and neck to watch toys at the abdomen. And then this is the severe cerebral palsy, spastic quadriplegia. We can see that a very severe spastic quadriplegia with a lot of complication and contracture in the distal or the extremity. So we can see at the end of the treatment, if we successful to bring this patient to the midline stabilization, we can see that very good in posture, but because this severe cerebral palsy with a contracture in hand and foot, we can do anything at all. Okay, so at the last, we have to teach the parents, because the parents must do what we call carryover. The parents must doing some positioning. Positioning in supine must be very perfect. Yeah, don't do positioning like this because it will lose mid body stabilization. So the parents is the key of the successful of this treatment method. Okay, for the last summary of my keynote speak, midline stabilization is the basis of movement in children, and especially in children with cerebral palsy or other gross motor impairment. This is very facilitate movement and the posture. So it can be a new approach or maybe new concept if we want to treat a patient with a gross motor impairment or maybe cerebral palsy. Okay, this is our references. And the last, thank you very much for the time, for this opportunity, for BioLeaks and all of university that support this event. So see you next time. You can contact me at the email or WhatsApp and Telegram. Thank you very much. Have a good day. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, sir. Thank you so much for your informative question. The floor is open for questions, participants. If any one of you having any queries regarding the talk, kindly drop your questions in the chat box, please. Okay, sir. I guess there are no more questions from the participants. Thank you, sir.
Yeah, thank you so much.
Now I would like to welcome our next keynote speaker of our day, Dr. Priyanshu V. Rathod, Dean Faculty of Medicine, Professor, School of Physiotherapy, Director of Internal Quality Assurance Cell, RK University, India. Sir, over to you, please.
I hope it is audible.
Yes, sir, it's audible.
Is it audible?
Yes, sir, yes, sir.
Hello?
Yes, sir, it's audible, sir.
Yeah. And I hope my screen is visible.
Yes, sir, it's visible, sir.
Okay, okay. I think very good morning from India. And I feel very delight to be a part of this entire conclave. And very nice theme connecting the evidence-based practice and new advances in rehabilitation. I'm a little far from the place where it conference getting organized, and this is where I am located at the eastern part of India. And thanks to this technology, where we are able to exchange so comfortably. Pardon me as I am in a airport lobby, so there will be some disturbance. This is my university having three different seasons. What you can see here, winter, summer, and monsoon. So I'll be happy to have further interaction. Even somebody want to come traveling through this in western part of region. Let's start with today's topic: the tech-driven rehabilitation, enhancing health restoration through innovation and interdisciplinary collaboration. Myself, Dr. Priyanshu Rathod. I am an inventor, mentor, and innovation facilitator. And that is where I'm trying to connect the how interdisciplinary collaboration can help to enhance health restoration with technology. I'm serving as a Dean Faculty of Medicine. I also take care of internal quality assurance cell at RK University, India. It was a time we used to study the A for apple and B for boat and C for cat. But today we have a technology with us, A for apple and B for Bluetooth. And the way the technology has fundamentally changing our way of thinking and way of living. And I'm sure everybody must be agree that the technology is driving somewhere also in rehabilitation. If you just observe the last 15 years of span, the ophthalmologists have expanded from a technology-derived practice, LASIK and phaco and refractory error correction. The dermatologist has went far beyond the cosmetic and hair transplant, orthopedic with robotic joint replacements, and even one of the major impact we observe from the technology in radiology, from the X-ray MRI to interventional radiology. So considering the tech-driven rehabilitation, definitely we have impact on the neuromuscular, musculoskeletal, sports, cardiovascular, pediatric, women's, electrodiagnostic, and geriatric and oncology. I think it covers all the area of rehabilitation where technology is a part of our real-time problem solution. Here, we know that artificial intelligence has taken a big impact, gamification, vision-based physical therapy, AR, virtual reality, and robotic assistant therapy. So they are the very key influencer in our area where we are practice. So one of the reason why we have this advancement because of sensor, fantastic sensors are developed, Wi-Fi cloud technology, and it is a mobile, what we have on our hand. So this is 4 areas which has given a boost to our practice in rehabilitation. And if you touch the movement science, we are again having the sensor-based derived technology, which helping wearable or scaling or biosensors are helping a lot. And that is what today I am going to discuss, that what I have invented, what I have added value from my last few years of technology-derived rehabilitation practice. Just before we start, we have understood that the impact of technology in modern rehabilitation, where AI has taken a lead in a prediction of accuracy in rehabilitation. So predicting, it is major span of rehabilitation, like disease development and early prediction, early detection. I want to have just one case study. One of the device what we have developed, it is a portable digital respiratory assessment device for predicting acute exacerbation of COPD. This is a device developed with help of my team, which is a collaborative efforts. What you can see on my left side to identify the few values, what we call end expiratory CO2, post expiratory vital capacity in 1 second, and peak expiratory flow rate. These 3 things we have been integrated with one device. And what you can see, the mobile based application which help us to early detection and predicting the COPD patient if they come across with a changing situation for accumulation of PaCO2 by end expiratory CO2. You can see this small video where the device is connected with a Wi-Fi, and what you can see that the connection with the mobile, basic detail we add in a mobile about person's details. Once you add all the details and you have your database, when you blow from this device, it records the end expiratory CO2, which is get recorded in the mobile, and it provides the feedback about the severity of CO2 in end expiration gas. Even with those values, we have a SIM card attached, so you get informed to the is consult nursing faculty or physiotherapists or medicine fellow about there is a increasing the value of CO2. So if it's such incident happening in a far area of rural communities, we can monitor throughout the week or month to observe that there is a chance of acute exacerbation. This is something at the level of TRL. So technology readiness level we have developed, and the help of the electronics communication department and experts from collaborative interdisciplinary research, it has come into the market. This was the first picture when it was developed, and later on what you can see with the help of the technology. And this is a simple mobile application which dispose the data to the everyone, which is a loop with the patient's record system. And that is where we have observed that there's a certain need for early prediction of CO2. Second thing, it is about AI enabled this mobile application. What you can see here, it help us to stroke recovery predictor. So the person who's having a stroke, and based on his hospitalization stay, type of the stroke, and Fugel-Meyer questionnaires, we have a strong correlation R square value where we can predict after even 6 months, 1 year, does the person is recovering as per the expectation or as per the provided therapeutic treatment. So patient himself can predict that how the recovery is faster and slow or stagnant. So this is one of the large data pool has been taken in retrospective data and tested with the prospective communities. It is already in a Google app. You can download and experience about how the recovery is expected or not. This is a few areas where algorithm has prepared. Algorithm is converted to the AI-enabled format in an application, and it is under the. There are the 20 different attributes was responsible in predictive model, but highest value we observe from the length of hospitalization, type of stroke, and post-stroke duration. Another AI-enabled device we have prepared, we had a problem that how we prescribe the walking aid. Walking aids we prescribe and how we can prevent the fall. So sometimes people get prescribed walking aid, but sometimes they could not withdraw from the prescription if even they are improved. They become dependent on the walking aid. So here there is another AI-enabled application where work balance based model was prepared and a formula was provided which is predicting that person is required to have a walking aids. So it will be walker, walking sticks, also it is a provide. So that is a point of the rehabilitation and a collaborative effort of the technology. AI enabled system, it is helping a lot, not only to prescribe the walker, prevention of fall, but even withdrawing from the prescription of the walker. This is another in-house device we have prepared to provide the biofeedback where person is lying on the device. This device helps us to strengthen the people having a spinal cord injury, people having a bed ridden situation, people having a post-surgical or long-term palliative care at geriatric center to strengthen their core musculature. We had observed that the people have a difficulty to strengthen their core musculature of spine. So this device is helping them to correctly strengthening the musculature of spine. Here, what you can see here, the device having a specifically prepared for a lordotic structure. It worked in a small device which was taken later on. This is a mechanical device, and then we transfer. This is a pressure what he gives on the bed and supine position, and then we can capture the. It gives the feedback, visual feedback, and we have taken this wireless system. What you can see here from to next generation for mobile-based technology. So now devices connected with mobile technology where person can see how much pressure they are generating, and because of the pressure generation, we actually give the feedback to sensitize the rectus abdominalis, transverse abdominalis, and even multifidus muscles of the core spinal structure. We have tested with this device with the EMG that how much amplitude has generated. Another mobile application, what you can see here for Align, it is available on Google Play Store. And what you can see here, it is this device can help to rehabilitate the people with having a neck and shoulder disabilities. Once you enter the data, it provides the tailor-made video based on the neck and shoulder disability index, and you can self-generated practice. It provides the feedback that how to use this mobile application. What you can see on a video that how the simple application, all this animated video is prepared based on the severity of neck disability index. Another walker we have prepared to help the climbing staircase up and down. Considering the development countries, sometimes it's difficult to have escalators and home situation. The walker, it is made to have a help the person to climb the staircase. It is also with the help of industrial association and mechanical department, this walker has come in action. This another device was to mobilize the spine. Specifically, a lot of time when you use the thumb, which you get subluxus injury for the physiotherapist. So this is a tailor-made device to mobilize the spine, and we have a evidence-based practice where this is earlier model of the thumb-like articulation, what you can see, and we have provided the rotational component for mobilizing the one vertebra above another vertebra. What you can see here? We have taken this several innovative products to the market and available in market where people can buy. So we don't want to be only the startup or innovators, but we take them these collaborative efforts to the technology transfer, including our business model. So we also extend our innovative models in a different conference that people experience and practice. Another balance sensing device. This device can help to the fall predictor, specifically for balance training or geriatric population to a wearable device, and it is also have a patent for practice. It is also have a mobile integration. So the person having a balance training, when he's training himself or under supervision, this will provide the audio-visual feedback. How displacement from the line of gravity fall outside the base of support. Another device we have developed for mobilizing the muscles. What you can see here, the ISTM device integrated with the electrical stimulation. So the large musculature can be well managed with trans-electrical stimulation to pain management, muscle spasm. Another device we have made, tailor-made, hardly in Indian rupees, it costs 1200 rupees. The person who is exercising and they want to set their 3D ECG, which help them to have a constant feedback. So most of time, recent era, we observed a lot of people undergo cardiac arrest. So this is where it's preventive. Even it helps to tailor-made exercise program for individual. So considering the opportunities in wearable market is expanding, and there is a certain this opportunity for virtual reality, also been fantastic opportunity for collaborative work. I would like to end up further with the impact of virtual reality, having in stroke rehabilitation, cognitive, it has a little lower evidence in practice compared to psychological rehabilitation, but mainly the motor function development has been well observed. Considering the Yes. Is it audible? Is it audible? I hope it is audible. Okay, this is one of the virtual reality has been observed efficient in a rehabilitation for Parkinson's in people. Even it has systematic review has observed that is a stroke also stroke rehabilitation is also there is a efficient practice with the VR system. And definitely the robotic assistant rehabilitation has also taken a rise in last 5 to 10 years, which observes the 30 to 40% of increase in recovery outcome as along it will practice with our complementary, our conventional physiotherapy or rehabilitation practice. However, it has robotic has could not proven his impact on balance. However, the gait speed, walking ability, and upper limb function and muscle strength has been shown a significant improvement with robotic assisted rehabilitation. Thank you so much for listening me in this very disturbing environment where I am in a transit, and I really apologize if I could not convince my topic with limited resource what I had here, and I'll be happy to have a further communication with email or mobile. Anyone delegates who are attending this conference regarding developing innovative device or problem solving for technology derived innovation, I'll be glad to have to be a part of incubation support. And thank you very much, the Bao League, for giving me these fantastic opportunities to share my knowledge and learning from fantastic speakers we have observed so far and upcoming. Thank you so much.
Thank you, sir. Thank you so much for your informative session. Participants, if you have any queries, you may drop your queries in the chat box.
I hope, ma'am, it was my voice was audible.
Yes, sir. Your voice is pretty audible, sir.
Okay. Thank you so much, everybody.
Thank you, sir. Thank you for joining us today. Now I would like to welcome our next keynote speaker of our day, Dr. Alson Chong Wai Kwang, Vice Chairman of Asian Federation of Sports Medicine's Education and Scientific Commission, Malaysia. Welcome you, sir.
Hello, good days, everyone. I will share my slide.
Yes.
Okay, can you see my slide?
Yes, sir.
Is it at the front view or are you seeing at the back view?
It's a front view, sir.
Front view, okay. Okay, good day to everyone. I'm Alston Chong. Am I audible? The sound?
Yes, sir, you're audible, sir.
Okay, thanks. Thank you for the organizer, BioLeaks, and also all the participants and also the partners for inviting me to deliver the topics of harnessing AI and emerging technologies in pioneering a new era of sport rehabilitations. Me myself is a consultant sport and also exercise physicians. I'm also a senior lecturer currently practicing in University of Malaya, Malaysia. Just some disclaimer, certain topic is actually there's some repetitions from the previous lecture, but I will go through very fast and I will show some of the examples. Okay, so this is me. I'm actually currently practicing in University of Malaya, and I'm also the vice chair of Asian Federation of Sport Medicine under Educational and Scientific Commissions. So my presentation will be covering from introductions of how AI and technologies emerge in sport rehabilitations and what are the current roles the AI is playing until then I will introduce certain existing technologies that already are being widely used. Example will be the wearables, technologies, the VR and also augmented reality. The previous lecture has mentioned robotic and automations, and also then we will look into the ethical applications of using AI and technologies when we come to meet patients and also data protections, and what are the challenges and limitations, and what are the future trends for the sport rehabilitations in terms of using AI and technologies. Okay, so we have to define what is AI. I'm sure everyone know AI pretty familiar, which is the stimulations of human intelligence. Okay, you have to be you still have the human component. Okay, so people always argue one day with the fast growing of the AI, now we have the chat all premiums, will actually AI take over human beings? The answer is actually controversial. We don't know, because the AI by definition is still a stimulation of a human intelligence, so it still requires human to actually operate. Okay, processed by machines, particular computer system, enabling them to perform tasks, which is learning, reasoning, and so problem solving. And this is very important in sport rehabilitations. And with the emerging technologies that we have, with using machine learning, wearable device, virtual and augmented reality, this actually can provide innovative solutions in terms of injury prevention, rehab programs, and very personalized treatments. Most of the rehab programs that we currently have is if you look into the textbook, is very generalized, very textbook or very protocol based, and most of the time it doesn't cater to, because not all the athletes will sustain the same kind of injuries. Okay, so with the use of AI, this will actually help to personalize the program, and the impact will be we hope to see the integration of AI with the emergence of the technologies. We actually embrace the efficacy in terms of healing, and also leading to more patient outcome improvements, and also improvement of recovery as well. So as we know, as I mentioned just now, sport rehab, the importance of using AI and also the emerging technologies is because this can actually accelerate the recoveries and help them to return to first is return to their activities, then return to training, returns to play, returns to sport, then returns to their performance prior to the injuries. Okay. And we also want to extend, okay, the player longevity. That means their career, so that they didn't give up, they didn't stop from their career from becoming a high performing athletes because of multiple injuries. Okay, and another things that with the emergence of the technology and AI, this actually have already come up with a lot of new technologies that can have a injury prevention strategy, and most of these data-driven strategy are very effective in terms of preventing a certain kind of injury. Example, ACL in a footballer, or ankle sprain in a basketball player. Okay, and with the integration of technologies, we hope this will actually become, like what I say, personalized rehab program with real-time feedback, and also adaptive feedback that ultimately will fasten the recovery and more efficient in terms of injury healing. Okay, so the current trend is most of the AI that driven tools that appear in the market do actually analyze what the athlete's data by create a personalized recovery program. Example is like when a patient is put on a certain device, okay, we will collect the data, and then from that data we analyze, and you see whether the patients are in the time frame of the recoveries, okay. And another one which is very widely used, I guess everyone have their, me also is wearing one of the wearable device which we call can be the smartwatch. Smartwatch is can actually give you a real time monitoring of the certain parameters like the heart rate. Okay, some of the more advanced one additions probably can give you the heart rhythms. Patients with certain heart rhythm disease or master athletes that are still competing, they probably don't want to have this arrhythmia and causing heart attack. So this wearable device play a very important roles. And we suddenly have players or athletes that suddenly collapse on the field without any contact injuries, then diagnosed to have sudden cardiac death. So this wearable device probably will be a lifesaver for them. Okay, and also the virtual and also augmented reality that I mentioned will improve the patient's interest in terms of rehabilitation. So the rehabilitation program, they don't feel so so plain and so boring, yeah, with the real world scenario that we integrated, we actually give them more stimulations, and this also proven to be more effective in terms of recovery. So we have to clarify the role, the transformative role of AI and emerging technology in enhancing sport rehabilitation practice. And I also highlighted the latest innovations in rehabilitation, I will show later, and also what are the future research that we actually see still a lot of rooms for improvement in terms of incorporating AI and emerging technologies into sport rehabilitations. Okay, so we know that with the data that we collected, we actually can generate AI algorithms. You can just type in, you wouldn't be actually surprised the whole presentations that I actually present today is generated by AI. Okay, so with the massive data that we collect, we often call it big data. Okay, we can actually key in and create a AI algorithm, and this AI algorithm can actually help to identify the patterns and predicts the recovery of the certain athletes. And we can also give a tailor rehab programs that can optimize the athlete's healing when the athlete is having certain injuries. And with the use of machine learning, that also give a real-time feedback, and also will enhance the rehabilitation program to be more effective. And through AI as well, we also can actually have a predictive algorithm that when with the incorporation of the biomechanics, we can actually predict the injury risk on certain sports. And I will skip. Okay, so the data analysis and the predictive models play important roles with the integration of AI technologies. So I want to show you some of the case study, which is very interesting. That this group of researchers actually use the AI algorithm to predict the basketball player biomechanics, and they found they're able to reduce 30% of the recovery time for player that sustained ankle injury. A group of researchers also, they did the predictive analysis but through injury prevention for footballer, and they also successful reduced 25% of the injury rate for the seasons for most of the football player. And also with the wearable device, the rugby player able to reduce able to reduce the player injury because they're able to have a better performance, and then they by monitoring their health parameters like the heart rates, whether the hydration, sometimes oxygen level, and also their sleeping patterns. Okay. So some of the wearable device are not just confined to a smartwatch. Okay, we also have some smart clothing. This is more in sport biomechanics, which we will track the athletes' muscle activity, posture during their while they are competing, and give a real-time feedback. And this will enhance, and we can directly with the integration with the coach, then we can actually prevent injury and also fix the athlete's wrong posture. And also the wearable ECG that I mentioned can actually give a real-time feedback if you for certain master athletes that still competing but have a high risk of heart attack. Okay, this I already mentioned just now. I want to show you some of the virtual and augmented reality that we are using currently, mostly already incorporate to actually enhance the rehab program. And one of the video I want to show here is this basketballer by the name of Jimmy. He actually see.
Yeah, but these don't count. Y'all picked the wrong one to record.
Okay, so you can see he's performing drilling, drilling, which is very common practice in basketball, but at the same time, he also training, solving the mathematics questions. So this actually will train the neurocognitive functions, at the same time also training the skills. So this is a very high level of training and have to do two different tasks at the same times. Okay, this is not part of the rehabilitations, but can be used as one of the gamifications in terms of recovery, and this is actually a very good example. Okay. So now I move into robotic device, which I think my colleague just now already mentioned, and robotic industry is a very large and also very advanced industry. We actually generate a very mass amount of income, but at the same time also require a lot of innovations to make the robotic or exoskeletons to be perfect and adapted to the athletes. Okay, so you can see the exoskeletons. When we talk about athletes, we are not just confined to able body. We also now we're not talking about gender equality. We also have to have able and disabled body equality. So we're also talking about para athletes as well. So the exoskeletons actually is very have shown that with the improvement of the technologies, exoskeleton actually do help in patient with sustained spinal cord injuries to have better recovery in terms of strength and coordinations. And then a robotic device as well. Okay, and also the telepresence of the robot, or sometimes we call tele-rehabilitations or telemedicines, can actually help patients that's staying or athletes that's staying far away from the rehab center to have a real-time feedback or monitoring to the use of the mobile phone, or the like what we have one now, the hybrid virtual conference. Okay. So I want to show you these are one of the founder of Neuromotions. They actually design the exoskeleton, which is very advanced in terms of helping spinal cord injuries and patients with lower limb injuries in terms of rehabilitations.
My name is Pauline Martin. I'm a physiotherapist and owner of Neuromotion Physiotherapy Clinics. Neuromotion is a group of physiotherapy clinics, and we specialize in.
Make it forward.
My name's Pauline Martin. My name's Pauline Martin.
Sorry.
I'm a physiotherapist and owner of Neuromotion Physiotherapy Clinics. Neuromotion is a group of physiotherapy clinics, and we specialize in providing excellent care for individuals with neurological conditions. I got involved with Human in Motion because I'm very excited to bring this advanced technology to clients, and I really wanted to make sure the clinicians' input and perspective was considered. I love the dynamic range that ExoMotion provides at all the joints. The ankle motion is fantastic. It inverts, everts, it flexes, it extends, it's amazing. ExoMotion provides independence and control for the clients, and they just love that. Some of the activities are things that clients thought they could never do again, and now they're able to do them. As a therapist, the ExoMotion reduces the strain on my body. It's going to make the therapist's job easier in that the client is not going to be required to be lifted into a standing position. The ExoMotion will do all that lifting and supporting so that I can focus on the therapy that I'm providing to the client. It's going to reduce the amount of equipment I need and going to provide a wide range of therapeutic benefit. I am so excited about this technology and utilizing it in the clinics, and the idea that in the future people are going to have them at home and use them in their communities.
Okay, so you can imagine if you have one of these exoskeletons, you can actually you still require humans to actually operate because you need to create a program, but at the same time you actually reduce the amount that you have to carry the patients if the patient is having still unable to weight bear or a spinal cord injury patient. So it's actually through the integrations of the exoskeleton, the robotic device into the rehab program that actually you actually facilitate and actually enhance the rehab programs for the athletes. Okay. So okay, now we want to come into some important aspect in when we talk about AI and technologies. It's very sensitive because when we collecting data, if you encounter most of the time when you sign in into a certain website, you have to give consents about the collecting cookies. Okay, consents whether you are providing them the informations. Okay, if you most of the time you reject, they will kick you out from accessing the website. Okay, and so when in most of the country, especially even in Malaysia, we have data protections, although it's not being enforced so much. But in most of the European countries, when talk to data, they are very sensitive because the big data that they collected do actually help in terms of collecting the AI algorithm that can actually give a more accurate kind of a protocol. But at the same time, if it's misused, it can actually cause some mismanagement or confidential issue regarding the patient's personal data. And we do have a lot of cybersecurity threat. And now one of the, I think the most, if you want to earn a lot, is the prop engineering and also cybersecurity engineering. Okay. Imagines that a few months ago we have this cyber hack that actually paralyzed most of the flight and most of the banking industry in the world. And I would not be surprised that if the cyber hack attack the rehabilitation program or the rehabilitation technology in a country or in a hospital center, that will actually cause a disaster. Okay, and always have an informed consent when you introduce certain very new things, okay, like the exoskeletons or AI into the patient rehab program. You always get their consents so that inform them the data will be shared and will be used so that this is to build the trust and the transparency in adoptions of AI and driven the rehabilitations program, and so that the patient feels safe and can be trusted. So some of the applications, if there's bias in AI algorithms, there's potentials that can lead to unequal treatment outcome in sport rehabilitations. And then the patient consent is very important, and we have to have the accountability when we use the AI system, that the system that we actually being used is being tested, being validated. It's not something that is still under clinical trial. And then this is actually to protect our patients, and at the same time to protect us as a healthcare providers. Okay, now I move to the challenges and the limitations currently, because even with ChatGPT, we have a cloud, we have so we have a lot of AI system that actually developed by different a huge giant tech company, and one of the big challenges is there is very difficult to integrate when you are not like a data science engineer or prompt engineer. So the diverse data source that come from different technologies actually have some inconsistency in terms of formatting the data. But I don't think this issue can be handled when the AI is more matured. And then and how do we actually incorporate this large amount of data that we actually collected to incorporate into our sport rehabilitation and come up with not to say perfect, but a near perfect or ideal, more optimal kind of rehab programs. And there is this limited accessibility, especially in country which is low to middle income. Malaysia is one of the country that actually has a huge impact. Most of our center, I don't see there is an exoskeleton. Even the video that I actually downloaded is actually from the state. And when I visit European country, they do actually has started using exoskeleton and integrate their AI into protocols. But there is still a low accessibility in terms of technologies when come to low to middle income countries. Okay, and we have to know, not everyone know the technologies well. Okay, there's still a huge numbers of literacy and that require trainings. Like the old generations of healthcare provider, probably they still are using they cannot adopt to using technologies. They're still using the old style of manipulations or pain modality. So when you start to implement the exoskeleton AI generated algorithm protocol, they might be very scary, and they might surprise them. And we also have to have this financial implication, because it's not cheap. Okay, when even with the sign up of Zoom, if you are not a profit, if you declare as not declare as an NGO, probably you have to pay somehow very high amount of this US dollar per month to use to have this Zoom webinar. Okay, so the financial implications do actually play very important roles. And again, the accessibility for low to middle income countries, I think these have to be shared, because the disparity will only pull and also widen the gaps between the country we don't have access at all, and with certain countries that have so advanced in technologies. And the long-term cost-benefit analysis, whether the amount of money that we actually throw into investment can actually have the real benefits when it comes to long-term in terms of patients and athlete rehabilitations. Okay, so the future trend of the sport rehabilitation technologies, I do predict that AI will be driven in terms of there will be more AI-driven rehabilitation tools that coming out by using AI-generated algorithms that actually through like even most of our programs now, we can actually incorporate the chat GPT to help us to actually leverage out most of our tasks. This will also be the future trend in incorporating the AI into most of the device of the physio or the rehabilitation device. And the integration of the biometrics wearables in terms of monitoring our health parameters and the athlete parameters. This is actually very important in terms of the heart rate, the oxygen level, the sleep pattern, the hydration level. All these little parameters will actually help in terms of improving the athlete's performance and also prevention of the injury. You can imagine if an athlete's not enough sleeps, probably they will go very easy go into exhaustions, then this is actually prone to increase the injury rates. And also with the use of the virtual and augmented reality, they actually enhance the patient engagement with the rehab program so that they don't feel very boring or they don't feel very painful and whenever they come for a physio sessions. Okay, so interdisciplinary collaborations is very important. This so I hope with this webinar we can actually look through not just talking about global south, global north, not just talking about high income and low income country. Whenever there is a technology, emerging technology, I hope we can actually share among our disciplines so that for the benefits of our patients. And then, so the sharing knowledge and resources is very important. That's why we have this webinar so that we can actually share and also have more collaborations. And we actually trying to overcome the challenges that we don't have enough financial support and then we cannot conduct research. No, there's always a way to conduct collaborative research to different institutions. So this can actually improve communication, coordination, and also improve the athlete's journey in terms of rehabilitations. Okay, so I just want to highlight the strategic technology adaptations is coming. So we have to prepare to adapt to tech-driven future. So I don't think there is a problems for the younger generations. You can see everyone is having smartphones, having their notepad. Okay, so but for the probably the older generations, they also have to have a more open-minded kind of mindsets to adopt the technologies. And training and education is very important. You can't just as the head of the department or as the leader or the persons that actually the director of an institution, you cannot just introduce without education. So you have to have a proper continuous educations and also trainings program for the staff in terms of adopting the AI driven tools or even the emerging technology that are being bought or being used in the center. And collaborations is very important, not just among our same fraternity, but also with other fraternity like the engineering, the tech engineering, the data scientists, in terms of developing tools that they really benefits to the athletes and also to the patients that actually sustain sport and muscle skeletal.
So sorry to interrupt you, sir.
Last. Okay.
Okay.
So the key take-home message is we have to take into account of these AI transformations. We shouldn't be left behind, and the emerging impact and the future direction is to actually have a multidisciplinary collaborations so that we have a shared knowledge and we move forward together, and always have this importance of protecting the patients through the data protections, and always have an informed consent when you introduce the AI incorporated protocols or the emerging technologies. Okay, that's from my presentation. Thank you so much, and have a nice day. Yep, I'm finished. That's my contact. Okay, when you think things are sometimes not always very smooth as you thought, when you think things are falling apart, sometimes you just need to hold on and don't give up. They may be falling into places without you noticing, and just keep on trying, and I'm sure you will be success when the times come. Okay, thank you so much, and I hope you enjoy the remaining of this conference. Thank you.
Thank you, sir. Thank you so much for your presentation and talk. Now, I would like to ask if any of the participants is having any queries, kindly drop your questions in the chat box. Before we take up the questions, I request everyone to turn on the cameras for the gallery image. I repeat myself, I request all the participants to turn on the camera for the gallery image. Hello all, I request everyone to turn on the cameras for the gallery image, please.
Hello, ma'am.
Yes.
Actually, I'm not able to start the video as it was blocked by the host.
Just a minute. If you could raise your hand, I will try to give you the access. Kindly raise your hand, please. May I know your good name, please, Ada? Okay. Your video is on. Yes, ma'am, your video is on.
Hello, ma'am. I am also not able to open my camera.
Okay, just give us a moment. May I know who all are facing an issue regarding turning on the camera? Kindly raise your hands, we'll give you the access. Thank you all. Now we'll move on to our Q&A session. If any of the participant is having queries, kindly drop your queries in the chat box. I guess there are no queries, sir. Thank you. Thank you so much. Now, before we move to our technical sessions, I request all the participants to stick on the rules and regulation that we have 10 minutes of presentation in which 8 minutes is for presentation and 2 minutes for Q&A. Our coordinator will be intimating you after 7 minutes so that you can have a time for 1 minute to wind up your session. I request everyone to be conscious about the time and all the best for your presentations.
Madam, what is first? So yeah, भैया मैं चार्जिंग मशीन में फिट किया मारा मैं देख कर नहीं एक एक हमारा कैसा बाजू में एरो
Now I would like to call upon our section chairs of our day, Mr. Tarun Amalenkar, lecturer, physiotherapy, University, Tunku Abdul Rahman, Malaysia. Ms. Nur Husna Ismail, lecturer, sports, exercise, psychology, Asian College of Exercise Medicine, ACEM, Malaysia. Ms. Pavitra Annamalai, clinical instructor, physiotherapy, AMSD University, Malaysia. Ms. Shanmugavaidu, clinical instructor, physiotherapy, AMSD University, Malaysia. And our last session chair is Ajita Mishra, Associate Professor, LN Paramedical College, LNCT University, Bhopal, India. I hope we have shared you the evaluation forms to all the session chairs. Ma'am and sirs, could we start our presentations, please?
Sure, ma'am.
Okay, thank you, ma'am. And if any of the participant is having any concerns regarding sharing the PPT, I request you to share the PPTs beforehand to our coordinator so that we will be sharing from our end. And we request every participant to be ready with the presentations. Only 10 minutes of time allocated for each of the participants, which is 8 minutes for presentation and 2 minutes for Q&A. Thank you. Now I would like to call upon our first participant of our day for the oral presentation, Dr. Rupa Rajendra Desai.
Good morning, ma'am. I'm Rupa here. I'll just share my PPT.
Yes, please.
My PPT is visible, ma'am?
Yes, please. Please start with your presentation.
I'm not able to visualize my PPT here.
Go to slideshow, ma'am.
Ma'am, is it visible?
Actually, we could see your first slide itself.
Just a minute.
Yes.
I think I've shared from here, but then I'm not able to see my slide.
Ma'am, your slide is visible. Please continue. Your slide is visible, Dr. Rupa.
Yeah, ma'am, but here it's not visible from my end.
Okay, ma'am. Once you can stop sharing your screen and you can continue.
Yeah.
Now reshare it, ma'am.
Yeah. Is it visible now?
Yes, ma'am. For us, it's visible. For you?
Yeah.
Okay, ma'am. Kindly go ahead, please.
Yeah. So I think I'll start now. Should I start now? Yeah. A very good morning to one and all. So my topic of presentation is effect of movement control and lumbar stabilization exercises on pain and core muscle activation in mechanical low back pain, a comparative study. So around 34% of patients, despite of becoming pain-free with interventions, experience episodes of recurrent low back pain that require further interventions. So some intervention protocols consider only stabilization exercises that recruit fast motor units, whereas exercises that are based on movement control concept are based on recruitment of core muscles that basically involve slow motor units that are responsible for dynamic control and stability function. So they help to change the movement behavior with combination of cognitive as well as physical learning processes. So now there's an extensive dearth in literature as to which form of above mentioned exercises are superior in improving the symptoms of chronic mechanical low back pain. Hence, this study aimed to compare the effects of movement control, lumbar stabilization exercises, and combined effects of movement control as well as lumbar stabilization exercises on pain and muscle activation in patients with chronic mechanical low back pain. So now the research question here is, do movement control and lumbar stabilization exercises affect pain and core muscle activation individually or in combination in patients with chronic mechanical low back pain? Now, it was an experimental study that was conducted at Tertiary Care Hospital in Pune, India. Now, the target population were subjects diagnosed with chronic mechanical low back pain, and it was a simple random sampling with a sample size of 75, which was based on a pilot study. So now the inclusion criteria were individuals with chronic mechanical low back pain aged 20 to 40 years and those subjects with mild to moderate pain on NPRS. Now exclusion criteria included history of spine surgery and lower extremity surgery, those diagnosed with pathological conditions that are related to low back pain, any diagnosed neurological diseases, history of cardiovascular disease, stroke, pregnancy, and those subjects taking any other form of treatment for low back pain. Now, overall, around 97 participants were assessed for eligibility, where 22 were excluded as they could not meet the inclusion criteria. Written informed consent was taken from all the participants and they were randomly allocated into 3 groups using computer-generated random allocation table. And then Group A received movement control, Group B received lumbar stabilization exercises, and Group C received combination of both these exercises, and hot packs was given to all 3 groups prior to the intervention. Now, pre-treatment assessment was done with the outcome measures. Intervention was given for 3 alternative days for a period of 8 weeks. Now, after a period of 8 weeks, Group B, there were 3 dropouts in Group B, and 2 in Group C. Now, post-treatment outcome assessment was taken at the end of 4th and 8th week. And regarding statistical analysis, Friedman test was used for within group analysis and Kruskal values for between group analysis. Now, the outcome measures that were used were NPRS to measure pain and surface EMG to measure muscle activation of transversus abdominis and multifidus, and movement control dissociation tests were used to identify movement control impairments. So these are the photographs of placement of electrodes and bridging activity for multifidus muscle. Now, movement control tests were used in terms of to identify flexion and control movements, extension and control movements, as well as close as well as open uncontrolled movements in all the participants. And regarding intervention, initially hot pack was placed over the lumbopelvic region for about 20 minutes before initiating the exercises in each group. Now, regarding movement control, Site and direction of uncontrolled movements were identified for each patient regarding in terms of lumbopelvic flexion, extension, and open as well as closed rotation control tests. So total of 28 tests were performed to assess uncontrolled movements. So the participants were considered eligible to pass the test if he or she had a potential to keep up the alignment at a desired site and direction, while the region below or above moved to achieve a preset benchmark. So movement control was given for a period of 8 weeks. It was a tailored program for all the tests that failed to achieve the preset benchmark. Now, exercises for identified uncontrolled movements were given similarly to the testing, but were performed for 2 minutes, and progression was given by challenging the positions cognitively. Now, regarding intervention to lumbar stabilization exercises, these were the few of the exercises that were given, and this was the training intensity for lumbar stabilization exercises. Group C received combination of movement control as well as lumbar stabilization exercises. Now, coming to results, within and between group analysis for comparison of pain, within group analysis showed a highly significant difference between pre and post 8 weeks of intervention, whereas between group analysis showed non-significant result for pain at NPRS at rest as well as on activity. Now, coming to within and between group comparison of differences in peak-to-peak amplitude of transversus abdominis in all 3 groups, within group showed highly significant improvement, whereas between group analysis showed significant difference in mean pre-post difference in right transversus abdominis among all the 3 groups, and whereas for within group analysis there was for multifidus muscle, there was highly significant improvement in all the 3 groups, whereas for between group analysis showed highly significant difference in pre-post mean difference in right as well as left
Ma'am, sorry to
multifidus.
interrupt. 1 more minute left to complete the session, ma'am. Thank you.
Yeah. So within group comparison was given for uncontrolled movements. So now coming to discussion, pain reduction could be because in movement control could be because of retraining of abdominal movement patterns as identified by movement control movement system impairment. Also, the feedback tools that were used to teach and facilitate the retraining movement that involve palpation feedback with own hands or adhesive tape could be one of the reasons for improvement. Now, pain relief in lumbar stabilization exercises could be because of decrease in the stimulus by decreasing load on the lumbar vertebrae as explained by Punjabi et al. And also there was activation of active subsystem. And the reason for improvement in both the groups could be that the combination of both the exercises could have led to improvement in pain. Now, between group analysis revealed that there was no significant difference on pain. So there are few studies who contradict the statement. And Jacobs et al. Explained that motor control exercises did not provide any exceptional results related to pain in terms of general strengthening exercises. Thus, it was interpreted that improvement in pain could be because of overall benefit of general exercises. So hence, for future scope, we can recommend that musculoskeletal ultrasonography can be used as an evidence-based tool to find the thickness of transversus abdominis muscle, and further studies can be conducted in movement laboratory with computerized video analysis along with EMG. So the clinical implication of this study would be that both these type of exercises should be used in clinical practice in order to reduce pain and improve activation of core muscles. Also, assessment of uncontrolled movements in all directions should be considered in regular practice when evaluating patients with low back pain. And so treatment protocol should include activation of core muscles along with strengthening of exercises in patients with low back pain. Thank you so much. Any questions?
Dr. Rupa, my first question is, how did you screen the patients for mechanical low back pain?
Ma'am, as per the screening criteria, also there are some patients were referred from orthopedic department.
Can the rest please mute themselves? Yes, Rupa. Yes, doctor.
Yes. Ma'am, the patients were referred from orthopedic department with the diagnosis of mechanical low back pain. And hello.
Okay, and you did not have any control group in this study?
Ma'am, there were 3 groups. No, control group I did not
Yes.
have. Yes.
Okay. Now, the patients that you included in your study, were they on some medication for low back pain?
No, ma'am. No.
None of them?
No. The medication.
And were they taking any other? Yes.
Those who were taking any kind of medications or different type of treatment apart from this were excluded from the study.
Fine, Dr. Rupa. It was
Thank you so
a
much.
nice presentation.
Thank you so much.
Thank you for the presentation, Dr. Rupa. Appreciate the methodology and explanation. I do only one question there.
Yes.
How did you control the trick movements when you're training the patient? Did you give any habituation? You give some days to understand the concept or maybe some session? What was that?
Is it about the movement control you're asking, sir?
Yes, yes.
Yeah. There were the trick movements. It was like initially I had demonstrated the movements to the patients, whereas the patients were allowed to do those movements in front of the mirror. Along with that, a kinesthetic, a tape, a micropore tape was applied on the spine so that it was a kind of kinesthetic, feedback for the patient, wherein patient would understand in case if there is any kind of trick movement. Also, some exercises were done in front of the mirror, so that has given a visual feedback.
Okay, fine. Thank you.
Yes, yes, sir. Any other questions, sir?
Not on my side. Thank you. Thank you for your presentation.
Yes, thank you.
I think we can move to the next presenter. Gopika ma'am, can we have the next candidate?
Yeah, I'll stop
Thank
sharing.
you, Dr. Rupa.
Thank you so much. Yes.
Thank you. Now, I would like to welcome our next presenter, Dr. Darshana Arya.
Yes, ma'am.
Yeah.
Am I audible, ma'am? I'm sharing my screen.
Yes, please.
Is it visible, ma'am?
Yes, it's visible.
Yes. Very good morning to one and all present here. My topic is high intensity interval training, a narrative review of physiological and psychological responses. This study reviews the physiological and psychological responses to high intensity interval training, that is HIIT. It explores the benefit of HIIT for improving the cardiovascular health, metabolic capacity, and aerobic performance. This study also examines the impact of HIIT on the affect, enjoyment, adherence, and provide the recommendations for the practitioners on how to prescribe and use the HIIT in varied client, member, and patient populations. So for this review, total 14 articles were reviewed, and on basis of that, I have prepared this review. I'm not able to change. Okay. So interval training, it involves the alternating periods of relatively intense work and recovery. And this approach to fitness and performance has gained popularity as a HIIT. There are two general categories of HIIT, aerobic HIIT and resistance HIIT. In aerobic HIIT, mostly the running and cycling workouts are used. And for the resistance HIIT, Tabata, CrossFit, bootcamp training, and similar activities can be used. Aerobic HIIT often uses the running, cycling, while resistance HIIT utilizes the loaded lifts. The intense work period may range from the 5 second to 8 minute long and perform at the 80 to 95% of person's estimated maximal heart rate. The maximum number of times the heart will beat the minute without overexerting yourself, and the recovery period is performed at the 40 to 50% of person's estimated maximal heart rate. There are three models for the HIIT training. First one is Wingate model that involves the 30 second of all-out cycling and 4 minute of recovery period. It also known as a low volume model, whereas Scandinavian model has a 4 minute of interval separated by 3 to 4 minutes of recovery period, and it is known as high volume model. In practical model, it involves the 10 intervals of near maximal cycling for 60 seconds, alternated with 60 seconds of recovery interval. And this model is known as a medium volume model. I'm not able to change this slide. It is not changing. Yes. So here the mechanism on which the HIIT is working, that is the epoch, that is the excessive post-exercise oxygen consumption. The HIIT workout will provide the similar benefit as continuous endurance workout, but in shorter period of time. So this is because this workout tend to burn more calories than the traditional workout, especially after the workout. So the generally about it is a 2 hour of period after an exercise bout where the body is restoring itself to pre-exercise level and thus using the more energy. So because of the vigorous nature of HIIT, the epoch generally tends to be modestly greater, adding about 6 to 15% more calories to overall workout energy expenditure. The physiological benefits include the aerobic fitness. It will increases the VO2 max to a greater extent and more quickly than the continuous moderate exercise. On metabolic health, it will improve the insulin sensitivity more effectively than the continuously moderate exercise, especially in the risk for the developing the diabetes mellitus. It is also improve the endothelial function more effectively than all forms of continuous exercise. Here some are psychological responses. First one is affective response. Affect means it is pleasure, displeasure, and tension or calmness. It indicates that the affect experience during the HIIT work interval is not different from the affect experience during the continuous moderate intensity exercise and is significantly more positive than the continuous vigorous intensity exercise. Another response is enjoyment response, and it is a psychological state that involves the cognitive evaluation. Research suggests that vigorous intensity exercise performed intermittently as in HIIT is very enjoyable, and participants report highest enjoyment for the HIIT condition compared to the continuous moderate intensity and vigorous intensity exercise. Another response is adherence. It indicates the positive affective responses and perceived enjoyment of the HIIT, and questions related to long-term exercise adherence remain. However, preliminary data suggests that HIIT may be equally more favorable during the exercise bout than the continuous moderate intensity or vigorous continuous intensity exercises. Here are some safety considerations. In that, exercise on the treadmill poses a greater risk of injury via falling than the cycle-based exercise. So, practitioners should remind the clients and patients to be cautious while performing the aerobic HIIT. Another is the treadmill grade. On specific recommendation might include the high intensity by adjusting the treadmill grade rather than the speed. So, it can be safer one. The HIIT recommendations include first step. Here is the basic HIIT recommendation. So first step is education. Provide the client and patient with information related to benefits of the HIIT. In the base prescription, walk can be 2 to 5 minutes and complete the 1 minute of high intensity work interval, about 90% of maximal effort, then 1 minute of the recovery interval, 10% of maximal effort, and can repeat the interval 10 times for total of 20 minutes and cool down at low to moderate intensity for 2 to 5 minutes. It can be start slowly and trial and error can be there as per the different individual, and we can change also. Try HIIT exercises indoor and outdoors with music, without music, alone and with workout partner, etc. Be careful as the intense exercises increases the risk, and to be cautious while trying a new HIIT routines, especially those that require the any unorthodox movement patterns. In conclusion, experienced health and fitness practitioners know that the fads come and go quickly. However, the current fascination with interval training is unlikely to fade away, given the growing scientific evidence in support of the HIIT. The many potential positive benefits described within this review make clear that aerobic HIIT programs provide a great benefit to the health. For the future research, more research is needed to assess the body weight and resistance versions of the HIIT. Furthermore, there is a work to be done to examine the impact of HIIT on acute psychological responses and exercise adherence. Here are my references. Thank you so much.
Thank you, Dr. Darshana. So,
Thank you,
Anand,
ma'am.
is there any questions for the participant?
Dr. Darshana, can you please go back to your methodology slide?
Yes, ma'am. These are the research model, ma'am, that I have reviewed from the article.
What was your methodology for selecting the articles? How
Yes,
did
I
you select
have,
the relevant
yes, ma'am.
articles?
Yes, I have reviewed on the Google Scholar, PubMed, and the Cochrane collaboration. And from that, I have selected the total 18 articles. And after reviewing that 18 articles, I have selected the 14 articles that is suitable for this review.
Okay, what I am trying to ask you is, was there a specific inclusion criteria for the articles? Like
No, ma'am,
in
there is
which
no
year they
specific.
have been published, their UGC, their Scopus Index, anything of that sort?
No, ma'am. I have prepared just brief narrative review on recently published article on basis of that, and I have prepared that this review on basis of that articles. So I didn't consider any specific inclusion criteria. I have included just the recent articles.
Yes, so how do you define that recent article? Like articles ranging from 2021 to 2024 or 2020?
After 2015, ma'am.
बघा हे इथून येतं तुम्हाला ते ऍडमिन बनवतील तुम्ही शेअर म्हणायचं ठीक आहे आता हे इथे सपोज आता यू कॅनॉट स्टार्ट स्क्रीन कारण की दुसऱ्यांचं आहे म्हणून होत नाहीये ठीक आहे जेव्हा तुमचं नाव अनाऊन्स करतील तेव्हा तुम्ही हे शेअर म्हणायचं शेअर हा व्हिडिओ ऑन करायचा आणि इथून पण डायरेक्ट केलं हा इथे होतं ऑडिओ बंदच आहे बंद आहे मी इथून म्यूट केलं आहे रेड लाईट ला नाही नाही इथून शेअर म्हणायचं ठीक आहे तिथे तुम्हाला मग तुमचं स्क्रीन दिसेल आणि मग हे स्क्रीनवर आपण इथे कॉपी करून ठेवूया फायनल 2 हे ओपन केलं की होऊन जाणार
इथून पण म्यूट करून टाकायला
Yes, essentials. Do you have any other questions for the participants?
Hi, thank you, Dr. Darshana. Just I do have only one question. Thank you for your presentation first. What is the adversity protocol in case patient collapse or something? Do you suggest something on that?
Ma'am, actually, the HIIT interval training program is prescribed and designed on basis of the exercise testing. So, in case of each and every patient, first thing to take for the safety consideration is to perform and put the patient on the exercise testing. So, there is a less chances of such event occurs during the training program.
In case of adversity, what is your suggestion?
immediately we can shift the patient to the emergency. And this training is always done with the supervision of the medical personnel also. Okay, so it can be handled if there is any medical emergency.
Okay, noted. Thank you. Thank you for your presentation.
Thank you, ma'am.
Thank you, Dr. Darshana. And the next presenter would be Dr. Ankita Shah. Dr. Ankita, are you
Yes, ma'am.
here?
Yes, ma'am. I'm here.
Yeah, please take over the session, please.
Thank you, ma'am. Is it visible, ma'am?
Yes, it is
Hello.
visible.
Okay. Good morning,
Yeah.
all. Yes,
Please put it on the presentation mode, ma'am.
Okay. Good morning, all. My presentation is on development and validation of menopause awareness questionnaire. I'm Dr. Ankita Shah. I'm assistant professor at KPG Baroda, Gujarat State from India. I'm a PhD scholar at Gujarat University, that is at Ahmedabad. So introduction, basically menopause, the WHO defines menopause as there is a permanent cessation of menstruation or loss of the ovarian follicle activity, and it is more than 12 months of more than 12 months or year. And according to the literature, the average age of menopause in Indian women is 46.2 years, which is much lesser than the Western countries. For a background, like menopause is having during menopause, women face so many symptoms like hot flushes, joint pains, dryness of vagina, mood swings, insomnia, and all that, which causes there is a lack of there is a bad quality of life. So what was the need of the studies? During our literature review, we discovered there is a limited number of studies focusing on menopause knowledge, and in many studies, it didn't specify the questionnaire, which questionnaires they use. Also, in some studies, they have said that they have used personal interviews to assess the knowledge of menopause among the women, and some studies had just to measure the menopause based on the definition of the menopause. So this highlights that there is a need of the development of the proper comprehensive menopause knowledge questionnaire. Aim of the study, the aim of my study was to create a reliable and valid tool that enhances the assessment of menopause knowledge and ultimately contributing to the better educational strategies and healthcare interventions. Methodology. For development of the questionnaires, I use these four strategies. Purpose and scope of the my study was identified. Then I do the literature review. Then I generate the items and I generate questions, and then I draft questionnaires. So this is the question I made after all the procedures. There are 10 questions, which includes the basic definition of the menopause, which also includes the age of the menopause, what is the like pathophysiology or physiology behind the menopause, also shows the symptoms of the menopause and the risk factors of the menopause and management of the menopause. So this 10 question includes all the basic things which women should know, which consist about the knowledge of the menopause. So these are the 10 questions which I have formed for the menopause knowledge questionnaire. And I have used 2-point Likert scale, that is I know and I don't know. So if I'll give her this questionnaire to any subject, the patient has to feel whether if she knows, then she has to tick mark I know, and if she doesn't know, then she has to tick mark I don't know. These are the 10 questions which have been made by me, or these are generated. Then comes the validation of the questionnaire. So validation of the questionnaire was done in the 5 steps according to the guideline. The first was preparing the content validation form. Second is selecting the review panel. Then conducting validation. Then reviewing the domains and providing the score of each items. And then finally calculating the content validity index. So this was the content validation form. So content validation form in which I gave this sheet to the expert, in which they have to mark 1, 2, 3, or 4. So 1 is equal to not relevant. 2 marks is equal to if the question was somewhat relevant. They have to give 3 if the question is quite relevant. They have to give 4 if they are highly relevant. This was the content validation form which was given to the expert for validation. So again, same when I give the experts this my questionnaire form, they have to give points like 1 is equal to item is not relevant, 2 is equal to the item which I mentioned in the questionnaire was somewhat relevant, 3 is equal to quite relevant, and 4 is equal to highly relevant. So content validation was done by providing all the expert online copy of the questionnaire, and they were explained about the assessment of the development of the questionnaire. So meet our expert team. I included 4 expert gynecologist doctors. Three of them were physiotherapists, like who are practicing more than 8 years to 10 years, and one was a bilingual expert. She, Dr. Aarti Kota, she is a PhD in English language. So this was our team of 8 people. Now comes the analysis part. So this was the score given by the experts, and the expert agreements. This is the expert agreement. So in question 1 there was a 7 expert agreement out of 8. In question 5, question 6, both in them also it was 7 out of 8. So item validity index for question 1 was this. This is the item validity index of each and every questions. Item validity index was 9.6. The content validity index was I found was 0.96. The scale content validity of universal number I found was 0.8. Result. So this is the reference. These are the reference articles in which I found that if there are 6 to 8 experts, then I must have a content validity index at least 0.083. But in my studies, I got it is 0.96, which shows that my scale is or the tool is highly validated. In summary, so there's a good validity, so we can use this question. There's a comprehensive coverage which includes all topics like symptoms, treatment options, lifestyle factors of the menopause, and women's knowledge. I have also included cultural sensitivity. There's also user friendly design. I have used that simple words, very simple keywords. Education implications, like this questions can be used for education purposes and research purposes also. These are my references. Thank you so much.
Thanks for your presentation, Dr. Ankita.
Thank you.
Dear session chairs, do you have any questions for the participant?
I guess I'll request sir to go first.
Thank you, Dr. Ajita. Okay, thank you for your presentation. Appreciate the work. May I know, like, can we see the questionnaire?
Sorry, ma'am.
Can you show the questionnaire, please? Dr.
Yes,
Ankita?
yes, sure, ma'am, sure, ma'am.
I'm Mr. Tarun,
this is the
actually.
question.
Okay, it's fine. Okay, so do you have any negative question here?
No, I have kept all the questions are very simple, whether they are known and they don't know.
Okay, so I don't see any negative question here, ma'am. Or any question redundant? You kept any question which is redundant?
Sorry,
You
which type
asked
of
2
question?
times the same question?
No, ma'am, no. There is no repetition of any question.
Okay, it's being done already. Like now you're gonna go with the pilot study, is it?
Yes, ma'am. Actually, the validity is done, and I am going for the reliability studies now.
Yeah, I can see that CVR ratio is quite good, 0.8, we got 0.9. But maybe just like to check the filial responsibility. If already process done, then maybe this is my suggestion. So maybe we can keep 1 or 2 negative question, or we can do something. We can ask the question redundantly in 2 format. Then you get 0.85, and then it'll be more reliable. That's something, just a suggestion. But you got already good ratio. Okay, and this you will be doing on whom? Who will be your participant? I mean, like, who are you focused?
Yes, ma'am. Perimenopausal women and menopausal women will be the most focused because this is menopause knowledge questionnaire. So women which are going to face menopause and which women which are going through the menopause. So we can target both the women.
Okay, fine. Thank you. That's all is on my side. Thank you for your presentation.
Thank you so much, ma'am.
Dr. Ankita, right?
Yes, ma'am.
Okay. Dr. Ankita, I can see this questionnaire is in English.
Yes, ma'am. Yes, ma'am.
Now, if I'm not wrong, have you like tried translating it into a local language or maybe making it bilingual or trilingual?
Yes, actually, this is a basic question that I have made. I will find out the validity. Now I'm in the process of finding out the reliability of the question. Once it is completely valid and reliable, then I am planning to translate it into a local language, which is Gujarati language.
But Dr. Ankita, finding the reliability would require you to share this questionnaire with certain number of females and getting their response, right?
Yes, ma'am. Yes, ma'am. Are known to English language, like who are working or who are doing job. And actually, I am working at a university, so I am giving a questionnaire to the like working women of our university only. So they are very well known to the English.
Dr. Ankita, that way I would say that your reliability is biased. Because see, whenever we prepare a questionnaire or we try to find out the utility of that, or we are trying to establish the utility of a questionnaire, we always try to target the population who is not very aware of it, or who doesn't have a free access to internet, or who are not very aware of how to browse the internet for their common health issues and all. You know, the housewives are a little less educated and all. Because see, if you are targeting the population in your university itself, you will never be able to establish the reliability of this questionnaire. It will anyhow be reliable, right? Because in your university, whoever is there, all the females, they're well educated. They have been browsing the internet and all. So definitely their answer to all these questions, most of the questions will be yes. I know. So how does that prove the reliability of the questionnaire?
But ma'am, I was thinking like once the validity and reliability of the questionnaire in English language is established, then only I can proceed for the translation. In my mind, it was that.
I'll try to explain this in another words. See, what is reliability? What do you mean by the reliability of the questionnaire?
Yes, consistency of the question answers given by the participants.
Yes, okay. Now understand this, that if you target females who are well educated, and, who have a very clear idea of what menopause is, because they are well educated. Okay. So the consistency will be there anyhow. No, you're sure there will be consistency in the answers because they're all
Yes,
well
ma'am. Yes,
educated?
no, ma'am. Yes, yes. I know they can search in Google engine.
Yes. Now, understand this. The reliability of the questionnaire will be proved when you have females coming from different cadres of the society. Some of them might be housewives, some of them might not be very educated, some of them will be good, well educated. Only then you will be able to see whether this questionnaire is reliable for the entire population of India or not. Otherwise, the population that you're targeting with an English questionnaire, that itself makes the reliability study biased. You're biased towards the female population of your own state. We are not talking about the entire country, only just your own state. Because I have worked in Gujarat. I was one of the founding faculties of BITS Institute, Vadodara. So
Ma'am, actually, I am working here only.
BITS?
Yes, ma'am. BITS, that's the old campus. Yes, ma'am.
Okay. So now, if I am not wrong, the students that come to you, the females who come to you, most of them are from Gujarati medium. You might have noticed that.
Yes.
Through Gutse also, the students that you get, female students, they're from Gujarati background. Now, once they come to the college and they start studying physiotherapy, they start learning English, how to write answers in English and all. So they might understand this questionnaire. They might give you a positive response. But then in your own state, there are so many females who might not be able to even read this questionnaire.
Yes, ma'am. Yes, ma'am.
So in order to set the reliability of this questionnaire, you will have to target all kinds of population and then get a reply to it.
Okay, so ma'am, after finding this validity study, I'll have to transfer it. Then I have to type the reliability.
The ethics says, research ethics says that if you have developed a questionnaire, that questionnaire should be in a local language. Otherwise, otherwise that questionnaire holds no value for the general population.
Yes, no, definitely.
It is only for a targeted population.
Yes, right? I'll do the same.
Your presentation is good. Your questionnaire is good. Sir has suggested certain things. You can try including that, as well as just use Google to translate your questionnaire into Hindi as well as Gujarati. Just do that. So you'll get a larger population in which you can actually distribute the questionnaire and get a reply. See how many of them actually know about menopause.
Yes, ma'am. Thank you. Sure, ma'am. I'll do this. Thank you for the suggestion, ma'am. Thank you so much.
Okay, doctor.
Thank you, ma'am.
Thank you for the presentation. It was a good presentation.
Thank you, ma'am. Thank you so much.
Thank you, Dr. Ankita, for your presentation. And the next presenter would be Dr. Kinjal S. Patel.
Yes, ma'am. Ma'am, actually, Dr. Kinja will be presenting from my laptop only. So she is on the line.
Okay, ma'am. Okay.
Good morning, ma'am.
Dr. Kinjal, can you please present your presentation?
Yes, ma'am. Good morning, ma'am.
Good morning, and please put it on the presentation board.
Myself, Dr. Kinjal Patel. I am assistant professor in KPGU, Vadodara, and I am also PhD scholar from Baikaka University, Karamsad Medical College. Today's my topic is effect of telerehabilitation in patient with ONE, a systemic review. In introduction, the osteoarthritis is degenerative painful chronic joint disease characterized by structural changes to whole joint including synovial inflammation, meniscal damage, cartilage degeneration, osteophyte bone formation, muscle weakness, ligamentous laxity, and it results from complex interplay of genetics, metabolic and biochemical factors. And at the knee, osteoarthritis is most commonly affect the medial tibiofemoral and patellofemoral joint compartments. There is substantial researches to demonstrate long-term rehabilitation important to the facilitatory recovery in muscle strength, range of motion, gait, proprioception, and also activity of daily living. And studies provided strong evidence for the efficient exercise to reduce pain and increase the function. And this exercise require most of the time to visit the specialized clinic for many sessions in order to yield the maximum effects. And there are many barriers to patient for face-to-face care. For example, distance, cost of travel, length of absence from the work, and limited access to healthcare providers in rural areas. So, in addition to this obstacle, it is necessary of social isolation due to circumstances such as recent 19 pandemic restrictions patients from receiving face-to-face treatment. However, this obstacle can be overcome with the internet-based treatment system or telerehabilitation system. So, the telerehabilitation involves use of information and communication technology to deliver service to people outside the rehab clinics, which is potentially associated with less transportation and consequently reduce the treatment expenses and also time saving. A number of studies have examined the efficacy of telerehabilitation services in OA, and there are many numbers of clinical trials are underway. Aim of my study is to evaluate effectiveness of telerehabilitation compared to traditional in-person and clinical-based rehabilitation intervention for patients with osteoarthritis of knee. Objectives are to assess the overall effectiveness of telerehabilitation intervention compared with in-person rehabilitation method for improving functional outcome, pain levels, and quality of life among the osteoarthritis of knee patients. Methodology is the present systemic review was conducted as per the PRISMA guidelines. Two researchers complete the process of reviewing articles, abstract, full text screening, checking inclusion, and differentiate the opinion were resolved through the discussion. Literature was searched through the PubMed, Pedro, Google Scholar, and ResearchGate by the keywords of osteoarthritis of knee, telerehabilitation, and exercise in ONE. After retrieving all the articles, primary screening was done through the inclusion and exclusion criteria. Total 220 articles were screened and 6 articles are matching the inclusion criteria for the review process. Inclusion criteria were set as prospective interventional study which include the female with ONE, studies in which the telerehabilitation was given as an intervention, and articles are in English language. The article which were not available as full text, conference paper and study other than intervention study were excluded from the study. These are the articles which is demonstrated in table 1. Article 1 represent between the telerehabilitation group and control group. Article 2 represent the intervention or treatment group including uh, telerehabilitation and the OBT group. Article 3 includes telerehabilitation and control group. Article 4 includes telerehab plus face-to-face group. Article 5 includes Blended web-based rehab plus control group, and Article 6 include telephysiotherapy group and usual care groups.
Dr. Kinjal,
Yes, ma'am.
we couldn't hear you, so that is.
Ma'am, I am unable to change the slide.
Oh, sure, sure.
Ma'am, I am unable to change the slide.
Okay. Ma'am, please try it out. Like, please come out of the presentation board.
Now in
Yes,
the
ma'am.
analysis, for analysis, I review the all articles and analyze the data, extract the data for each article and extract the relevant data including study characteristics, participant characteristics, intervention details and outcome measures with the conclusions. In my result, in the present systemic review, data from 6 articles, total 331 participants were included in these articles were analyzed using Windows 11 23H2 Microsoft Excel version, and PCOS female from age 18 to 14 years were included in the studies, and the effect of telerehabilitation were found significant in osteoarthritis of knee in the community people. In the discussion, telerehabilitation is new method of service delivery that has promises to revolutionizing the delivery of rehabilitation service. In the current systemic review, 6 articles are investigating the effect of telerehabilitation in people with ONE, which is more than 45 years of age, were analyzed, and the effect of telerehabilitation was found significant in ONE. In the first article, in the discussion, we seen the comparative efficacy of telerehabilitation versus conventional care through the WOMAC score improvements. In this study, it is compared with the telerehabilitation with conventional care by evaluating WOMAC score, and the telerehabilitation group shows improvement inferiorly through the 1.3 point in WOMAC scores. In second article, there is effectiveness of advantage of telerehabilitation compared to office-based physiotherapy. Office-based physical therapy with the commitment. Here it also shows that telerehabilitation is effective. In the third article, there is prevalence and demographics of knee osteoarthritis, insights from the study on telerehabilitation and control group, which shows most of patients with osteoarthritis of knee have lack support of physical activity and increase the physical activity. So through the telerehabilitation, we can improve the knee osteoarthritis physical activities. In the another article, there is effectiveness of telerehabilitation circuit training for early intervention in knee osteoarthritis. So the circuit training includes the strengthening endurance flexibility exercise through the circuit, and this approach is also low cost, non-pharmacological and non-invasive as a treatment option through the telerehabilitation exercises. In the conclusion, telerehabilitation offers several advantages, including increased accessibility, convenience, and the potential for ongoing patient engagement. And the flexibility of remote intervention can address barriers such as geographic location, transportation issues, and time constraints, thereby enhancing adherence to therapeutic protocols. So, here comes to conclusion. Telerehabilitation represent valuable and effective tool in management of knee osteoarthritis and offering promising alternative to conventional in-person rehabilitation, and its integration into the standard care practice and enhance accessibility and patient outcome, and ultimately it is contributing to more personalized and efficient management of ONE. This is my references. Thank you, ma'am.
Thank you, Dr. Kinjal. Sirs and ma'ams, do you have any question for this presenter? Dear session chair.
I think I'll take up first. Thank you, Dr. Ajit. I may be taking later. The question I do have, Dr. Kinjal, thank you for the presentation. I think is a important topic to address in the world across the board. Do you have any specific study in your criteria or all the references which was conducted on the village population or the people from the rural community?
Yes, sir. I have articles
Mhm.
which cover the rural population. For
How
example,
many were there? Like out of all the studies included?
I found 100 patients from the community.
I mean, like, no, if you compare how many studies were conducted on the rural population?
3 studies, sir.
330.
3 studies, sir.
3 studies. Okay. And what was the impact on those?
Among these 6 articles, I have found 3 studies from the rural population.
Okay. And what was the result of that?
In the result, I found that tele-rehabilitation is more effective compared to usual care or face-to-face group exercise in the community, because it is not possible for rural people to come at daily at the clinical based setup and for the clinical setup for the exercise. So they prefer more tele-rehabilitation for regular exercises, and also they have low income and also financial issues and transportation problems, so they more use the tele-rehabilitation.
Okay. So financial constraint and logistic issue, these 2 points.
Yes, sir. And they don't have clinics in rural areas also.
Okay, so any of the studies, just a quick one, any of the studies have suggested that in case these participants were provided with this facility and were provided free of cost treatment, then would have preferred tele-rehab or would have preferred the conventional traditional method? Did you get my question?
No, sir.
Okay, if these participants from rural population or even the people from urban population, participants from urban population were having a chance and the financial constraints were not there, would have preferred tele-rehab or would have preferred face-to-face?
Sir, actually, they have preferred tele-rehab because it is less time consuming, and there is no need to go out from the home or out from the office for the rehabilitation. And also, there is no need to take off from the job areas, and also they can utilize other things, and they can manage rehab plus other things at a one place. And also, seasonal uh, due to season.
Okay, the
Due
season.
to monsoon, yeah.
Okay,
Also
so,
because of
sorry to hinder you in
monsoon.
between those. The last one, I understood the season rainy and all right. Okay,
Yeah.
the concern, the last question, like how do you address the concern coming on the camera for the participant from the rural population? That's last suggestion. Any take on that from you?
Yes, sir. I have taken the consent with the video consultation via Zoom meeting. We can take consent from the video communication via Zoom meetings. So first we can explain the purpose of our study through the to the patient, and also if they are ready to participate in the study, then we can take consultation through the video consultation.
Okay, fine. Thank you. Thank you for your presentation.
Thank you, sir.
Thank you, Dr. Kinjal. And the next presenter would be Shriya Manoj Kumar Gupta. Shriya, are you there, ma'am?
Hello.
Hello.
Yeah, there's one problem. I cannot zoom the screen.
Okay.
Just a minute.
Sure. You can share your PPT so that we could share.
No, wait. Yeah, done. Okay. So I have to.
Please try now.
Yeah, I'm doing it. Wait a minute. Sorry for the delay. Actually, I was trying for so long, and now that my turn came. Yeah, I hope my screen is
Yes, it is visible. Please put it on the presentation mode, ma'am.
Yeah. So hello everyone. Good morning. My name is Shriya Gupta. I'm a PhD scholar from Gujarat University, working in Mumbai at present. My study is to develop and validate the questionnaire which I made myself. The name of the questionnaire is Awareness and Knowledge About Physical Activity Questionnaire. The background of the study says that there are not enough data available, and even though if the data is available, which I have studied personally, they were more regarded to the Western countries. So I've made a questionnaire which is simpler and easy to understand. Also, it goes along with the normal activity and a daily activity that is in the Indian population. Along with that, the physical activity guidelines have certain measures. So I put that also into consideration. The aim of the study is to develop and validate a questionnaire to evaluate the general population's awareness, knowledge of physical activity guidelines. Objectives were developing a reliable and valid tool for measuring knowledge and awareness of physical activity, testing the validity and reliability of the same using the pilot study. The questionnaire has three components, major three components. The general awareness has 5 questions. Knowledge of guidelines has 3 questions, and common misconceptions questions, which also includes barriers, has 5 questions. So total there are 13 questions. The questionnaire is close-ended, so it is yes and no type. The method of the study had 2 phases. The first phase was to develop the questionnaire, and the second phase was to validate it. First phase has 4 steps. First step, instrument design, expert review, pilot study for the usability, and then the validation, the final validation of the final form that was created. Instrument design included 2 steps. So what I did initially, I was not sure whether there were many questionnaire available or enough questions were available. So I'll tell you my experience when I went through research. There were already knowledge and perception based questionnaire to find out whether we are active enough or not. But that I was doing already using iPad. So International Physical Activity Questionnaire helps you to get the value of how active you are. So I wanted to make a questionnaire where we need to ask patient or the participants whether they are aware that they are doing something, and if they are doing something, is it enough to have a certain effect on them. So that was a literature review that I made. I created an initial draft. Initially, the draft had only 10 questions. Later on, that draft was given to the expert. So the expert committee had only 5 for now. I am doing into a extended version of this. I will not be going further without getting the enough responses. So at present, I have a data of 5 experts. So the experts had to measure it and rate it on the basis of 1, 2, 3, 1 denoting not necessary, 2 denoting useful but not very essential, and 3 denoting essential. The feedback was collected. Even the so I went to them in person. So the feedback was collected even in the open-ended answers also. That is how we made into 13 questions. So the final draft had 13 questions, which was now gone for the reliability testing. So the 13 question was given to 20 participants. At present, the 20 participants were only the people who were staying in my society. They had I selected different age group people. So so all of them were from Mumbai. So the questionnaire has already been converted into Gujarati and Marathi, but the validation and the expert review is left. So I've gone with the English questionnaire. I've given to 20 participants, and the feedback was taken. The final validation reliability testing was done after 1 week. So the questionnaire, after being given to the same participant, it was given after 1 week. So the error can be reduced. And then the finalizing of the tool was done. The feedback was also taken meanwhile. So the awareness questionnaire was, I just want to brief it. 5 experts from the exercise field. Consent method was used. Face and content validity was measured. Each item was reviewed for content, phrasing, and meaning. The rate was given, as I mentioned, was 1 and 2 and 3. Content validity ratio, and along with that, item content validity index was also found, ICVI. This was the result for ICVI, Item Content Validity Index. Here you can see only one expert, that is expert number 2. has rated the question number 2 as 2. So it was understandable because it was related to the sitting question. Then there was expert number 4 who has given the rating 2 for the question number 8. So 2 and 8 were related to sitting. So that is why they were little biased about that. Later on, the ICVI index found was more than 0.79, so suggesting all the items were appropriate. This was the CVR. It was again 0.88 for one question. Apart from that, all other were 1. So the suggestion, so the overall result came appropriate. Reliability, as I mentioned, it was given to 20 participants 2 times. So the questionnaire has yes and no type answers, and there are a predetermined answers also. So we can say whether the answer was correct or incorrect. So on that basis, when the patient has changed its answer on second time, that agreement is denoted as 0 on the right column, and that is how Cohen's kappa has come for 0.69 and shows the moderate agreement. The awareness and knowledge about physical activity questionnaire is a straightforward and reliable tool for assessing public understanding of physical activity guidelines. Expert validation and pilot testing confirm its clarity and relevance. While yes and no format simplifies the questionnaire, it may limit the depth of responses. This is one of the limitations of my study. Overall, this tool is effective for identifying knowledge gaps and can help guide intervention to promote physical activity. Moderate reliability can be explained as patient knowledge and attribute about physical activity might have changed between test and retest due to the exposure of, so they have already seen a questionnaire. They might have gone, this is my expectation that they might have gone and just recollected the information, the correct information, and that is how they filled the form second time correctly. And that's how the reliability came 0.69. Conclusion, the awareness and knowledge about physical activity questionnaire provides an effective means of evaluating the public understanding of physical activity guidelines. It is a valuable tool for researchers and public health professionals to identify knowledge gaps and implement intervention aimed at increasing physical activity level. This is my second half of the study, which I'll be doing after this one. So it is to measure the physical activity level using IPAC. Limitation, as I already mentioned, the response was yes and no, which might oversimplify the complex concept. Translation and adaptation of the other local Indian languages can be the future scope of the study. Use of scale to adherence, find adherence to measurement of awareness. So now the scale can be used for further population. This was just the pilot study. So that is the future scope of my study. These are the references. I would like to show you my questionnaire, but I need to change the screen for that. So thank you so much. I'll just switch to. I hope, can you see the questionnaire right now?
Yes, can see.
Yeah. So this is the Google form format. I can see I can show you the Word format too. Just a minute. Huh.
Maybe can you zoom out?
Yeah. Oh, wait. I think something is. I think after the. Okay, I'll just change the screen to Word format. Wait. I have. Yeah, this one. Okay, now it's better, I guess. So this was the questionnaire. So here it starts, basically it starts from the first question here. I guess the PDF format has changed it to number 4. Do you believe that regular physical activity is important for maintaining good health? So it is a generalized question. Then comes question number 2. Are you aware that the adults should aim at 150 minutes? So this is fact-based question again.
Shreya, sorry to interrupt.
Yeah.
Your session is actually exceeding the time frame. So can you
Okay.
please try
Yeah,
to
no
wind up
problem.
as soon as possible?
Yeah. So sorry, I was getting into the questionnaire. I just show you the questionnaire. This is how there section B, the parts are divided. The questionnaire is divided into 3 parts. So knowledge, awareness, and misconceptions. So these are the total 13 questionnaires. Okay, that's me. I hope you like the presentation. Thank you.
Thank you, Ms. Shreya. Dear session chairs, do you have any question for this presenter?
Shreya, can you please go back to your talk?
Oh, sorry. Shall I go back to the PPT?
Yes.
Yeah. Yes, ma'am.
The first slide, the topic slide. It hasn't changed on my screen.
Is it changing now? I am doing it on my screen. Sorry, where did you wanted it, ma'am?
First slide, where you have written your title.
Yeah. Yes.
It is still on procedure. Okay.
I have, yeah.
Yes, yes. Okay, actually, the sheet that I have received, on that, the topic was development and validation of menopause knowledge questionnaire again. No, it was the same topic was mentioned that is mentioned in Ankita Shah's presentation.
Yes. I've asked them to change. So I have
Yes, so
received the new PDF, but I guess there's some problem there. Yeah.
okay, Sri. Your presentation was really, very nice, and I'm looking forward to your further researches on this topic.
Yeah.
Because physical activity is an important part of menopause. Even not just menopause, even before the female reaches a menopause, there has to be certain amount of activity that the female needs to follow in order to prevent the consequences of menopause.
Yeah.
So yes, I have absolutely no question. Your topic was amazing. Your presentation was good.
Thank you, ma'am.
Okay, thank you for your presentation, Dr. Shreya. Appreciate the work. Just only one suggestion there. I just saw some item number 5 or item number 9 in the questionnaire. As you're doing and like you're going to extend the study, maybe just can flip the question, the last file you shown, the Word file.
Can I go for the questionnaire and show it to you?
Yeah,
Like
just
I'll
maybe
change
a
the
quick one.
PPT.
Only
Yeah.
no.
Yeah. Question number 9, you're saying, right?
I couldn't catch that because it was fast to hold.
I'll slowly scroll it down. So
There is a question in which you put 3 terms: running, jogging, and walking, I think.
yeah, that's question number 5. Yes, you're good with that.
Okay, so maybe like we have to avoid 2 terms in one question. This is my suggestion. Maybe you put standing, or you make 8 as 8.1, 8.2.
Actually, yeah, this was my confusion as well. I'm happy that you asked this. When I was writing a question, I wanted to make the whole form very small because we have done it with the 20 question also. So it was a trial and error. So I have to put light, moderate, and vigorous activity level questions. So when I kept light activity, I wanted to keep only only standing, but then I kept walking also, like normal walking is also light activity. So what do you suggest? Shall I just
Maybe
put
that's quite okay.
walking?
Maybe we can divide into 8.1, 8.2. If it's a question number 5, then 5.1, 5.2.
Right.
So you
Yes.
give option to them, to the participants, so that they can select which. And then there's one concern for me. Just maybe you put moderate intensity aerobic exercise. Somewhere you use that term.
Yeah, the first this one, moderate intensity
So
exercise.
this one I might not know if I'm not an educated person. So you
Yes,
have to put an asterisk there, and then like underwear down on the last part of the page, or maybe next page you can put definition of that in the simple term.
Or
that the person not feeling comfortable.
can I keep a few activities as an example in the bracket with the question?
But a little bit can be subjective. So you
Right.
can just
That's
put,
why. That's
is a
the
technical term. So just for you're going for a layman, common man. So you should put, you can consider that putting, because you're going to extend, then you're going to increase
Yeah,
the
I can put it as an asterisk and just below the page I can write it.
So it's simplified to the participant. That's all. That's all. Thank you. Good work, all
Totally.
guys.
Thank
From
you.
my side.
Thank you, Dr. Shreya, for your presentation. And the next presenter would be Punita Kishore Adajania. So let me present the screen for you, and please tell me whenever you need to change the slide, okay?
Yes.
Maybe for this study, the previous presentation, maybe can just send us the title. Thank you.
Yeah, my study, right, sir? Hello. Okay.
Maybe you can put in the chat box. Thank you.
Hello.
Ms. Punita, please go ahead.
Yes, am I audible, ma'am?
Yes, you
Hello.
are. Yes, you are, ma'am.
Good morning or good afternoon, all of you. Today, I'm going to present a study about comparison between core stability exercises and general back exercises in relieving chronic low back pain in adults. That is a randomized controlled trial. Please change the slide. Can I share my screen, please?
Sure, ma'am, you can do that.
Okay. Musculoskeletal disorders, of which back pain accounts for more than half the number of cases, are the most common cause of chronic incapacity in industrialized countries. Approximately 10 to 20% of patients with low back pain develop chronic pain, defined as low back pain persisting more than 3 months. LBP representing a particularly costly socio-medical problem, these patients use more than 80% of the healthcare resource. Thus, the development of effective intervention aimed at the management of chronic problems is urgently required. Chronic low back pain is a multifactorial phenomenon, and it is not surprisingly that many therapeutic approaches exist. The common causes of low back pain are congenital causes, traumatic causes, degenerative, neoplastic, metabolic, pain referred from the viscera, functional low back pain, postural back pain, occupational bad posture, and habitual bad posture. Aims and objectives of my study were: the main aim of this study is to compare the core stability exercises with general back exercises in relieving chronic low back pain in adults. Methodology. This was a randomized control trial with patients randomly assigned of one of two groups, that is Group A and Group B. The first Group A will be treated with core stability exercises and other Group B with general back exercises. The researcher who evaluated the pain and analyzed the data and participants were blinded to group assignment. A 21 individually supervised half-an-hour session exercise program, which lasted for 3 weeks, was performed for both the groups. Before and after intervention, at the end of 3 weeks, treatment outcome measures were measured for both the groups. 50 subjects with chronic low back pain from physiotherapy clinics were recruited. Eligible participants were screened for contraindications to exercise. Patients were selected based on the following criteria. The inclusion criteria of my study were non-specific low back pain without leg pain for at least 3 months duration, aged greater than 18 and less than 80 years, male and female, both gender patients were included, suitable for core stability exercises based on clinical assessment patients were included in my study, and patients who are willing to participate. The exclusion criteria: suspected or confirmed serious spinal pathology, any suspected or confirmed pregnancy, nerve root compromise, the strength, reflex, and sensation affected for the same nerve root were excluded, spinal nerve surgery, specific spinal pathologies such as any spina bifida, any vertebral fractures, TB, AS, ankylosing spondylitis, seronegative spondyloarthritis, malignant or benign tumors, osteoporosis, osteomalacia, any metabolic problems, or systemic diseases. These patients were excluded from my study. Researcher interviewed and examined all subjects to ensure that the inclusion and exclusion criteria were fulfilled. Subjects were questioned regarding the onset of the pain, current pain duration, and their age. The outcome measure used here was the pain measurement, that was VAS scale was used. The visual analog scale, it was used to assess each patient's pain perception. It is a responsive pain scale that yields reliable and valid data. VAS rated on an intensity scale of 0.0 to 100 mm with higher scores representing higher levels of pain. Intervention used in my study was for core stability exercises. The motor control program is based on the treatment approach reported by Kistner. Briefly, low load activation of the local stabilizing muscles was initially administered isometrically and in minimally loading positions. Patients were taught how to contract these muscles independently from the superficial trunk muscles. Progressively, the holding time was increased to the point where patients were able to perform 10 contractions with 10 seconds hold during normal respirations. Consequently, then dynamic exercises were contributed. The clinical measure used to ensure correct activation of transverse abdominis was to observe a slightly drawing and maneuver of the lower part of the abdominal wall before the umbilical level, consistent with the action of this muscle. In addition, a bulging action of multifidus should have been felt under the under the physical therapist's fingers when they were placed in either side of the spinous processes of L4 or L5 vertebrae directly over the belly of this muscle. The following exercises were taught to the patient. First was the drawing and maneuver in a crook lying position with ball kept on the abdomen, and then the drawing and maneuver was taught. Wall slides with ball. A person in a standing position with back supported with the physio ball on the wall, and then they have to come in a sitting position. Third was the kinesthetic training with wall. Initial position, a standing position against a wall with back touching the wall. The participant is then asked to place his or her hand below the lordosis of the back and the wall, such as he or she can feel the back with one side of the hand and the wall on the other side. The patient is able to slip between the wall, the hand is able to slip between the wall and the back. Participant is then asked to tilt the pelvis anteriorly and posteriorly. Next exercise is stabilization exercise for abdominal muscles. Initial position is supine lying position. The participant is asked to perform drawing and maneuver and maintaining that add first upper limb flexion and extension activity and then lower limb flexion and extension activity, and simultaneously of the opposite upper limb and lower limb. The next exercise is stabilization exercises for the back extensors. I have added bird dog exercise. In a quadruped position, a rod placed on the back. Procedure, the participant is asked to maintain the rod on the back and prevent it from falling while performing the upper and lower extremity motions. Stabilization exercise for activating the quadratus lumborum plank exercise is the participant is in a side lying position and performing side planks. Then curl up on gym ball exercises. Superman exercises, prone lying position and raising both upper limbs and lower limbs at the same time. Now moving towards the general back exercises. Here I made the patient perform dynamic curl-ups, bilateral leg raises, standing back flexion, standing back extension, prone on hands, standing side flexion, pelvic rotation and pelvic bridging.
Dr. Punita, sorry to interrupt, and you are exceeding your session timing. Please stick on to the timing.
Yeah. Statistical analysis and results. Here we can see a pair t-test was used to compare the data within the group. For group A, I got the p-value of 0.001. For table 2 is for analysis effectiveness of general back exercises, for which even I received the p-value of 0.001. Now I've used an unpaired t-test for comparison between group A and group 2. The post was between group A and group 2. Here I got the p-value that is 0.01. In fact, the mean difference was, there was a mean difference between two groups. The results of the study support the initial hypothesis that core stability exercises is more effective in decreasing pain in patients with chronic low back pain. There was no significant difference between two groups, but the core stability exercise decreased pain more than the general exercises. Conclusion, the findings support that the core stability exercises and general exercises are effective in reducing pain without any signs of instability. However, the core stability exercises are more effective in reducing pain than the general back exercises. These are my references, ma'am. Thank you.
Thank you, Dr. Punita. Dear session chairs, you have any questions for this participant? Dear session chairs?
Okay, and maybe in the meantime, Dr. Jita, I'll just take the first one only. Thank you for the presentation. Just asking one thing, how did you collect the data from various clinic? I think you mentioned that you have taken the data from different places.
Yes, sir. Sir, yes, I've taken it from different clinics. I use this SNOWS method. I made 50 envelopes, 25 of group A and 25 of group 2. So SNOWS envelope method was used for that.
And you reached to all these settings on your own, or they
Yes,
were
sir.
code searches?
Those were no. So I have done. They were nearby clinics.
Oh, nearby places. Okay, okay.
Yes,
That's
sir.
all is
Yes,
on my
sir.
side, Dr. Punita. Thank you.
Thank you, sir.
Thanks for the presentation, Dr. Punita. And the next presenter would be Dr. Divya Rathod.
Just a second, Dr. Punita.
Yes. Hello.
Did you use
Hello.
any kind of previous researches to develop your current exercise protocol, the general protocol and
Pardon,
the
ma'am.
specific
Pardon, ma'am.
one? The protocols that you
Pardon,
have
ma'am.
used. Hello.
Yes,
Am I
ma'am.
audible?
Yes, ma'am.
Yes.
Yes, ma'am.
So the protocols you have used, did you
Yes, ma'am.
use any previous researches to form that? Or was it just like
Uh,
how
no, ma'am.
how did you create that protocol?
For the control group except for general back, I just researched the exercises being used in the different clinics. What was the ongoing protocols for the low back pain patient, for chronic low back pain patient? For that, accordingly, I've designed this general back exercise program control group for the control. But, ma'am, for core stability exercises, the references were used. The articles, previous studies were used. Hello. Hello.
Yes, Punita. I'm sorry, there was a loss of connectivity in my system. Okay, so these were the exercise protocols that were used by different clinics around you, right?
Yes, yes, ma'am.
Okay.
Thank you for your questions, ma'am. And thank you, Dr. Punita.
Thank you, ma'am. Thank you, sir.
Yes, thank you. The next presenter would be Divya Rathod. Dr. Divya, are you here? Dr. Divya? Dr. Divya? Dear session chairs, Dr. Divya seems not to be present in here in this session. With your permission, can we move on to the next presenter?
Sure, ma'am.
The next presenter would be Dr. Bani Chanpura.
Yes, I'm here only. Hope I'm audible.
Yes, ma'am, you are audible. Please
Yes.
take over the session.
Yes. Thank you so much. I will just share my screen. Is it visible? I
Not
hope
yet, ma'am. Not yet, ma'am.
it's
Yes,
visible.
ma'am, it is visible now. Yes.
Yeah, thank you so much for the response. Very good afternoon to everybody who all are listening. So my today's topic for the presentation is assessment of preterm infants and their status of neurobehavioral at the term equivalent age. So the basic aim of my study is to assess the preterm babies who all are achieved the term equivalent age, means they have achieved the full term age and their status of the neurobehavioral while they are reaching to their equivalent age. Now, brief outline of my problem is an estimated 13.4 million babies were born preterm, that is before 37 weeks of gestation in the year 2020 in India. Preterm birth complications are the leading cause of death among children under 5 years of age, responsible for approximately 9 lakh deaths in 2019 in India. Third quarter of these deaths could be prevented with a current cost-effective interventions. So we'll go with that. Infants with the least amount of maturity are most vulnerable to neurodevelopmental defects in the later years. Nevertheless, we know the least about their early cognitive and behavioral development as newborns. Research indicates that biological and environmental variables affect the neurobehavioral development of the preterm infants. As we all know that the many researchers have done a same research to know that the biological as well as environmental variables are majorly affecting the development of a neurobehavior systems in the babies. So importantly, these variations in the neurobehavioral development of preterm infants as compared to the term-born babies are linked to subsequent challenges in their motor, cognitive, and behavioral domains. And they also contribute to the neurodevelopmental deficits of the school-age children. So if we compare the long-term development at the school-age level, there might be a deficit or lack in the development of nervous as well as the motor components of the bonds which have done in the which have been a preterm bonds as compared to the full term bond. So the need for this study is to whether the development of an extremely preterm infant is normal or abnormal, evaluate the impact of the interventions and exposure to perinatal variables, and to predict whether the infant may have long-term developmental problems or no. So with this aim, we have done a study in the NICU and in the outside of the discharged NICU patient to assess the neurobehavioral development in infants born at preterm, and we are assessing their for the early intervention purposes. So we can identify easily and we can start the early intervention treatment. So the objective of this study is to assess the neurobehavior at term equivalent age in preterm infants through the outcome measure, that is HNNE. The methodology, it was a cross-sectional study. The study population will be was the preterm infants in NICU who received the equivalent age between 37 to 44 weeks. The duration of my study was 12 years. That all the subjects will be sourced from the neonatal intensive care unit at the Dheeraj General Hospital in Sumandir Vidyapit, deemed to be university at Vadodara, Gujarat. The sampling was a convenient sampling method, and we have included sample size of 25. So with the inclusion of all 25, they are born at very preterm infants, but between 30 to 36 weeks of gestational age, and parents who are willing to participate for the study. Exclusion criteria were the infants born with a known congenital or any chromosomal disorders, infants who were clinically unaware and require any respiratory support beyond 72 hours of life. This exclusion we have kept in the keeping in the mind of the researchers, that they have come to a conclusion, the previous researches, that if the NICU baby who receives the any kind of either in the form of ventilator, oxygen supply, any of the other therapy beyond 72 hours, that is 3 days, then they'll have a long-term effect on their development. So to avoid those things, we have kept as an exclusion criteria those who have received less than 72 hours or not received any of the ventilatory or any other respiratory support, we have included them. Then infants born less than 30 weeks of gestation age. We have not included because another previous studies are telling ki if the child has born before 30 weeks, then there are other environmental factors and other problems are there which they have to cope up with during that weeks. So we want to exclude that also. So all the 25 preterm infants, while they are reaching to their term equivalent age, were assessed with the Hammersmith neonatal neurological examination outcome measures. So we have taken the ethical approval. After that, we have approached the NICU HOD, and then we have approached all the parents when their child is in the NICU, those who have medically stable without any complications and less than 72 hours, they have received any kind of ventilatory or respiratory support. Then we have followed it them when they are reaching to the term equivalent age, either at the time of discharge or in the follow-up clinics visit. We approach them and we have taken the assessment with the help of the HNNE score. So SPSS version 26, we have used it for the data analysis. And we have screened the 33 for the eligibility, but due to some issues, we can include only 25. We have followed them also, but due to some issues, they are not able to reach us or we have not reached through them. So we have included with this study is 25 participants were included. Among them, if we go with we have divided all the bachus into the two groups, like for the better judgment key, which age gestational is having more issues as compared to the term babies. So group 1 is included as 30 to 30 weeks, 33 weeks of gestation, and beyond 32 to 36 weeks. So there is a ratio of 3 weeks for the group 1 and group 2. So out of 25, 13 were in the group 1 and 2 in the group 2, 12 were there. Their discharged age pay, that is 11 days. Total will be 11, 13 and 8 according to the group 1 and group 2. The mean gestational age for the group 1 is 31.92 and 35.08 for the group 2. And birth weight, if we look out, the all 25 average mean is 1.84, and if we go with the group wise, then it is 1.61 and 2.08 respectively for both the groups. So if we go with the division of group 1 and group 2, they're almost equally. And as this suggests, if we can look for the table number 2, which
Dr.
suggests
Dhwani,
HNNE.
sorry to interrupt. You are exceeding your presentation time. Please try to wind up as
Just
soon
2
as
minutes. Just 2 minutes. Okay. So as we can see, there is a difference we can found out with the HNNE score with the reference value of the term equivalent age. So the HNNE is a 34 item score which requires to assess at the considerable gestational age. And we found that an increased gestational age lead to significant improvement in the posture, tone pattern, reflexes, abnormal signs, and the overall score of HNNE, which is again into the support of the previously published studies. So the study showed that the preterm infant differ significantly across their functional neuromotor domains at the term equivalent age. But if we taken proper efforts, and that there will be a minimized effect of the preterm born. So with this, the conclusion of our study is the very preterm infants are more immature than the term counterparts, even when they are reaching to the term compatible age. The pattern of abnormality varied with the various exposures of the perinatal neurobehavioral examination at the term equivalent age. It is useful to evaluate in the NICU for the early identification and for the early treatment to be started right from the NICU. With this, I'm concluding my sessions. Thank you so much for giving me the opportunity to present my study.
Thank you, Dr. Dhwani. Dear session chairs, do you have any questions for this presenter? Dear session chairs.
Hi, Dr. Dhani. Just thank you for the presentation. Just one question, the quick one. What was how you convinced the participants, the parents on this to participate in the study?
We just came, we are actually regularly going and treating those preterm infants for their early interventions therapies. So it is easy for us to communicate with the parents, and we just wanted them to know the growth of their child. When they are reaching to the term equivalent age, we are convinced them only that we just want to go and have a thing that your child has developed properly when they are reaching to the equivalent age while they are discharging or in the follow-up clinics, because we have a regular follow-ups. We are meeting the parents as well during our sessions and everything. So it is easy for us to communicate with the parents.
And the participant, those who have declined, that don't want to participate, the reason was?
No parent has declined because the loss of follow-up. There are, suppose they are 200 kilometers away. For the follow-up clinics, they are coming for the vaccination and all. Then and there we are gonna assess them. So for the vaccination, it is difficult some patients to come 200 kilometers for the vaccination and for the follow-up. So those are the 5-6 patients which we missed because of their inconvenience to reach to our place.
Yeah, thank you, Dr. Dhavani. Just last question for my inquisitiveness. This is third already. I understand. Just, do you think any cohort on this, like long term, do you suggest something for another researcher if they want to do this for next 3
I
years?
am only doing that. We are following it up till 1 year of life.
If possible, can go for more. I know
Yeah,
it's the financial issues and
that
difficult to
is what my
control.
again project of my one of the PGs.
Okay,
So
good.
every 2 months till the 12 months of the age, we are regularly assessing and looking for there any change in their.
Are you checking the neurodevelopmental model? I mean, like you're checking the.
Yes. All domains we are checking. We have so a psychologist also with us, so they are also assessing their part also.
Okay, good. Okay, thank you. That's all on my side.
Thank you so
Dr.
much.
Dhwani,
Yes,
I just wanted to ask you one thing. Can you please go back to this slide where you have your inclusion and exclusion criteria, like you're excluding children who have been intubated. So can you please go back to that slide once?
Inclusion, yes, ma'am, definitely. Yes. I hope it's visible.
Yes, it's visible.
Yeah.
Okay, and you said something regarding the incubation as well, that if the child has been intubated.
Incubated, yes. There are various children which requires their ventilatory or any oxygen therapy support, but we have excluded them if they have either on the CPAP or any of the mode of ventilator beyond 72 hours. Because previous research are there which is telling ki if they receive any kind of a respiratory or oxygen therapy beyond 72 hours, then they are automatically affecting their development. So to avoid those factor also, we have excluded that factor. Okay, those who are received beyond 3 days, any kind of a ventilatory or oxygen therapy or high flow nasal cannula, then we have avoided them.
Thank you, Dr. Dhani. Thank you.
Thank you so much.
Thank you, Dr. Dhwani. I hope there is no more questions for Dr. Dhwani. And the next presenter would be Dr. Nafisa Siti.
Yes, ma'am. Good afternoon, ma'am. Good afternoon,
Hi, ma'am.
everyone.
Hi,
I will
ma'am.
be sharing my screen.
Yes, ma'am.
Is it visible?
Yes, ma'am. Please go ahead, ma'am.
Good afternoon, everyone. Myself, Dr. Nafisa Siti. I'm a master's student from SPM College of Physiotherapy. My title is The Effect of Resistance Training on Quality of Life and 6-minute walk test in breast cancer patients, a randomized controlled trial. Breast cancer is on rise. It is a major concern in all the developing countries. Health sector is facing big challenge for various cancers. Physical activity performed by cancer patients may improve their biomarkers and lowers the risk of cardiovascular diseases. Resistance exercises prove to be better than other forms. It improves functional capacity, skeletal muscle loading, and quality of life and functional well-being for the patients. Resistance training has also shown to enhance muscular function, body composition, and to some extent fatigue. The study intends to investigate the impact of resistance training in breast cancer patients to improve functional status by performing 6-minute walk test. The aim of the study was to determine the effect of resistance training in breast cancer patients using physical parameters and quality of life by measuring 6-minute walk test by distance in meters, heart rate beat per minute, and FACB questionnaire score. Resistance training may have better effect in increasing functional capacity and quality of life in breast cancer patients was the hypothesis. Randomized control trial was done on the study setting of VSPM COP physiotherapy OPD in collaboration with oncology OPD. Protocol duration was 12 weeks. Study population was females with breast cancer aged between 20 to 60 years of age. Sample size was n is equal to 20 per group. Inclusion criteria was 20 to 60 years of breast cancer females receiving chemotherapy or completed chemotherapy in the span of 3 years. Exclusion criteria was stage 3 cancer, bilateral mastectomy, patients receiving radiotherapy, metastasis. The study sample randomization was appropriately allocated into two groups. Therefore, the mean age for resistance training group was 44.66 plus minus 7.08 and conventional group was 47.23 plus minus 4.56. The mean distance in meters in 6 minutes at baseline in 12th week was significant for both the groups. The mean heart rate remained unchanged and was not significant for both the groups. Quality of life parameters significantly improved post 12 weeks of exercise prescription for both the groups, resistance and conventional group. Significant increase was seen in the 6-minute walk distance post 12 weeks with pre-intervention mean of 306.05 meter to post mean 424.33 meters for resistance training group and 385.76 meters to 399.88 meters for conventional group, which was significant, whereas heart rate remained stable. Quality of life indicators significantly improved post 12 weeks of exercise prescription. The result of the study was in favor of regular exercise prescription. The exercise intervention was more effective for improving functional capacity in terms of 6-minute walk distance in meters and quality of life parameters. Therefore, the study concluded that the exercise intervention significantly improved emotional well-being, functional capacity, as well as physical functions of breast cancer patients and breast cancer survivors, and it can be stated that exercises in any form are beneficial to obtain positive effects on functional capacity and quality of life. These are the references. Thank you so much. Any questions?
Messenger, any questions?
Dr. Ajita, may I request you to ask first? I do have some, but maybe you can take the lead first. Thank you.
All right. So my first question, Akanksha, can you go back to your topic slide once, please? Vishal, right?
Pardon, ma'am?
Can you please go back to your title slide?
Okay. Yeah.
Okay. Akanksha, my first question is, can you describe the
Ma'am,
methodology? Am I audible? Hello.
Yes, ma'am.
Okay. Am I audible?
Yes, ma'am.
And I'm pronouncing
Yes,
your
ma'am.
name
Yes,
right?
ma'am. You're
It's
audible.
Natasha.
I'm Nafisa.
Right. Nafisa, I'm so sorry. Okay. Nafisa, so the effect of resistance training on quality of life and
Quality of
6-minute walk test. Now, Yes. So in this, how many groups do you have? It's an RCT, right?
Two
So how
groups.
many
One,
groups do you have?
yes, two groups, one resistance training group and one control group.
Okay. And in the resistance training group and in control group, what are you giving to the control group?
The exercises which are conducted in the setup. Basic exercises for
And what
shoulder
are
range of
those?
motion, like shoulder wheel, pulley ladder, and the range of motion exercises, gripping exercises, and the bed mobility exercises.
Okay. And the resistance group, what are
Yes.
the exercises that are being administered to the resistance group?
The
Are
resistance
there any
group,
cardio exercises involved in it?
no cardio exercises are involved. The resistance training group, we are gradually progressing, like 20 to 30% of 1 RM will be the starting intensity, and then will be increasing to 60 to 80% of 1 RM, and the frequency will be 2 to 3 times per week, and the exercises will be shoulder strengthening, elbow strengthening
Then
exercises. Yes,
Nafisa, then why are we checking the 6-minute walk test? Why are you taking the 6-minute walk test for these patients?
In breast cancer patients, there is actually, I'm taking the assessment scale also, cancer fatigue scale. So they get very restless. So I'm checking the distance in meters and heart rate.
This one? Divyani, 8 minutes. So Divyani in attendance is there. Okay. Yes, Nafisa. Sorry. Can you please come again?
Yes,
I'm
ma'am.
so sorry. I was doing something. Yeah.
Yes, in assessment purpose, I am taking cancer fatigue scale. So in that, I have found out that there is in breast cancer patient there is more fatigue. The study suggests that there is more fatigue. So I have taken the 6-minute walk test to see whether there is a decrease in fatigue also as an assessment tool. It is not an outcome measure, but for progression purpose and as an assessment tool, I have taken the cancer fatigue scale.
Okay, I got your point, Nafisa. Again, my question remains the same, that if you are not training the patient to increase the cardiopulmonary efficacy of the patient, how do you expect to get any kind of change in the 6-minute walk test just by some upper limb strengthening exercises?
I have taken lower limb strengthening exercises as well, full body strengthening exercises. So after lower limb strengthening exercises, I have seen improvement in the 6-minute walk distance, and the heart rate remains unchanged. Therefore, it is concluded that the heart rate was stable. So the resistance exercises was proper. That there was no change in the heart rate. It was stable from 72 to 90 for all the patient pre and post intervention.
Okay. Yes. Thank you, Nafisa.
Yes, ma'am.
Okay, thank you, Nafisa, for your presentation. Just asking the same thing. Which resistance training, like which muscles you focused? How did you conduct that?
Sir,
Same
I
question
have
I'm asking. Yeah.
referred previous article, that is our 2021 article is there on resistance exercises for breast cancer patient. So I have taken the exercise protocol from that particular study, and
Okay, so if I'm a participant, what exercise I will be doing?
the shoulder strengthening exercises, elbow strengthening exercises, and hip strengthening, knee strengthening, and ankle strengthening exercises.
So it's like throughout the body, upper limb and lower limb all involved.
Yes, throughout the body, and we are progressing. I have first and second week we have different like we are using TheraBands dumbbells, and for fourth and sixth week we are increasing the intensity in terms of 1 RM.
Okay, fine. So because the outcome measure you used is about I mean, this is about 6-minute walk, right? And this is a different capacity. So you're telling your postulate is that increasing the strength of the muscles will increase the capacity. Okay.
Yes.
Did you include references for that? That's like, was a rationale behind it? Why it is happening?
Yeah, that is exactly what I was actually trying to ask her, that how would she rationalize the fact that just upper limb and lower limb strengthening exercises are giving a change in the 6-minute walk test?
This is yeah, the same, Dr. Ajita. Same thing. I was like, just maybe I didn't understand. So is it like generalized effect of testosterone increase, or what was the biochemical, or like some part of the rationale behind it?
I've not looked into that, sir. I'll surely see that.
Fine, because it is not easy to get the participant to do
Yes,
exercise
sir.
after mastectomy. Is very difficult. I don't know how you did it. Something good. That is something appreciable.
See
Then
that.
one more thing. I just
Yes.
have one concern because
Yes.
this is something like how do you handle the psychological terrain of the patient? How the patient will like motivated to do exercise? It's quite difficult and challenging. So what did you use? What method you used to get the participant after going through this ordeal and participants are doing exercise? How did you convince them to do exercise? Maybe some input for every one of us to listen.
So mostly I've tried to talk out into it. I've tried to talk
Okay.
them into it because after I have seen the number of patients that after mastectomy the shoulder upper range is very much restricted, upper limb range is very much restricted. So I've tried to convince them कि अगर आप ये नहीं करोगे तो आपका बहुत सारे एक्टिविटीज जो है जो आप कर पा रहे हो, फीमेल ज्यादा है उनको हाउस होल्ड एक्टिविटीज में बहुत डिफिकल्टीज होती है, तो इसीलिए मैंने उनको ऐसे कन्विंस किया कि आप ये नहीं करोगे तो आपको बेसिक एक्टिविटीज करने में भी डिफिकल्टीज आएगी, आप बहुत जल्दी थक जाओगे, तो इसीलिए अगर आप ये पूरा करोगे तो आपको बहुत सारे चेंजेस दिखेंगे इसमें.
Yeah. Okay, so that's
I've
why
tried to
you came
convince
with the
them
concept of
according
quality
to
of
the
life.
ADLs
Okay,
for
ADLs.
quality of life. Yes.
Okay, I understand some rationale of that. Okay, fine. Thank you
Nafis,
for your presentation. Yeah.
okay.
That's what is on. Dr. Ajita, you can go ahead. Thank you. Thank you, Dr. Nafisa.
Thank you, sir.
Nafisa, your inclusion criteria says that you have included females from the age of 20 years to 60 years.
Yes, sir. Yes, ma'am.
Right?
Yes, ma'am.
20 to 60 years?
Yes, ma'am.
Do you think it is a very wide range of age that you have included? I mean, of physical fitness or the recovery rate of a 20-year-old female and a 60-year-old female, and the 6-minute walk test in a 20-year-old female and a 60-year-old
Yes,
female
ma'am.
would be very different.
Yes, ma'am. That
So
that would
how can you
that would
compare
be
a 20-year-old female with a 60-year-old female?
I've taken this reference from an article for the age group, but most between the age group of 30 to 35 to 60 years of age group. So there was changes, but most of the females were quite physically active.
Okay. And what was your outcome measure? Can you please go back to that outcome measure once?
6-minute walk distance, RP questionnaire score.
But you said 6-minute walk test wasn't an outcome measure. You said no, like it was just you're taking it, but it's not an
No,
outcome
cancer
measure.
fatigue scale. I told about cancer fatigue scale. Cancer fatigue scale.
Beta, I'm really sorry, but 6-minute walk test itself states that it is gonna be different for such an age. I mean, it's just not possible to have a similar kind of result. There is.
Okay.
Anyways, thank you.
Thank you, Dr. Nafisa, for your presentation.
Thank you so much. Thank you.
And the next presenter would be Dr. Priyanka K. Deshmukh. Dr. Priyanka, are you here? Ma'am, we couldn't hear you. Can you please check your audio, ma'am? You are in unmute, but we couldn't hear you, ma'am.
Now am I audible, ma'am?
Yes, ma'am. Now it is audible, ma'am.
Okay, fine.
Please take over the session.
Yeah. Okay. Good afternoon, one and all. Myself, Dr. Priyanka Deshmukh. I'm working as an assistant professor with BSPM College of Physiotherapy, Nagpur. The topic for my presentation today is patient satisfaction with physiotherapy services in Nagpur city. So coming on to the introduction, a physiotherapist profession requires, in addition to an excellent technical background, knowledge of the condition of the patient, as well as the ability to contact the patient and understand what the patient expects from a physiotherapist. In a physiotherapy clinic, a physiotherapist informs the patient about the plan of therapy in the context of the possibilities, explaining him the role of specific task exercises. Patient satisfaction is an important indicator of the quality of care provided to recipients of health services. Patient satisfaction is considered to be an essential skill that physiotherapists need to master in clinical practice to improve the quality and efficiency of care. It is known that satisfaction does not only rely on what is the treatment to be given to the patient, but also on the manner and style in which it is to be expressed, incorporating interplay between the verbal and the non-verbal factors. Coming on to the need for study.
Ma'am, your
Yeah.
slide is not moving. Can you
Yeah,
please put it
slide
on
is
the...
not moving. Just
Yeah.
a second. Yeah, just a second. Yeah. Ma'am, now is it visible?
Slide is visible, ma'am, but it is not moving. Can you please go forward and backward so that I would know?
Okay, okay. Yes, I will. Yes. Yeah. The need for the study for the study is the patient satisfaction with physiotherapy care has not been closely monitored. Some limited literature exists. The measurement of such satisfaction is essential for improving services and would add to the scarce literature which is already present. The factors such
Ma'am,
as...
sorry to interrupt again, and your slide is not changing. Can you please move on to the next slide by clicking on to one and one so that it will move?
हाँ वहाँ से बंद करके शेयर हो रहा है. Stop the screenshot. हाँ हाँ इसका screenshot बंद करना है. हाँ. And now, is it visible now?
Now it is visible, ma'am. Please change the slide so that I could check.
Yeah, maybe it was, you know,
Yeah,
sharing
technical
other
glitch, yes. Yes, ma'am, please go ahead.
Yeah. So now the aim of the study is to investigate the patient satisfaction with physiotherapy services in Nagpur city. And the objective was to investigate the patient satisfaction with physiotherapy services in Nagpur city using a questionnaire named MEDRIC's instrument for measuring the patient satisfaction. The inclusion and exclusion criteria for my study were the patients who were willing to participate were included, patient age between 18 to 65 years, literate patients, and the patients who have completed at least one physiotherapy session, It was a questionnaire-based survey in the private physiotherapy clinics. The sample size was 36. And the exclusion criteria was patients who were not willing to participate and patients having some neurological disorders or with some visual and hearing impairments. The metrics instrument for measuring the patient satisfaction, this questionnaire consists of 20 questions. 13 to 20 items were related to the patient satisfaction with the treatment, what they received. And the other 7 items focused on the external factors such as the infrastructure and everything. The results of the study. Now, the questionnaire consists of questions wherein the physiotherapist communication skills were checked, the inclination to give advice to the patient, answering the patient's questions, listening to their concerns, increased contact time, ability to give clear instructions on the home exercise program to the patients, professional conduct, and a conducive environment, the treating environment, they were all significantly closely related with the patient satisfaction. These are the results. The therapist did not spend enough. These are some of the graphs which I have shown out of the 20. So my therapist did not spend enough time with me, of which strongly disagree were 26.5% and disagree was 64.7%. My therapist thoroughly explained me the treatment, in which strongly agreed questions were 48.5% and agreed were 45.5%. My therapist answered all my questions, in which 42.5% strongly agreed to it and 54.3% agreed to it. I'm completely satisfied with the services I received from my therapist, in which 54.33% agreed and 40% strongly agreed. My therapist advised me on ways to avoid future problems. 45.7% strongly agreed and 48.6% agreed to this question. My therapist assistant was respectful. So 60% agreed and 37.1% strongly agreed to this question. The results were, the study indicated that 60% of the patients were highly satisfied with the physiotherapy services, wherein 29.3% were moderately satisfied with the physiotherapy services. Such a high level of satisfaction means that the physiotherapy services are of a good standard and the patient expectations of care were low. In relation to the professional dynamics, all patients stated that they had not noticed any interpersonal issues between the therapist and the other staff members. It was observed that physiotherapists listening to the patient's concern and satisfaction with the services needed. So being listened to the patient concern was an acknowledgement which the patient gave to the therapist, demonstrating concern. The patients who completed the whole treatment under the same physiotherapist were mostly satisfied with the behavior, the treatment protocols, the staff interactions, and other contributing factors. Professionalism was measured in the study as respect towards the patient, consistency by the physiotherapist, and maintaining the privacy of the patients. The majority of patients felt that the physiotherapist respected them. In the summary and conclusion, the study measured the level of patient satisfaction, which was a high level of satisfaction, which was reported. And this high satisfaction are more, the patients who receive this are more likely to continue with the physiotherapist treatment by seeking additional care and adhering to the recommended treatment plans. Such an assessment of patient satisfaction should be an ongoing process, as this may help the clinic administration to help with their services, to improvise their services. Yeah, so these are the references which were used. Thank you. Any questions?
Thank you, Dr. Priyanka. Dear session chairs, if you have any questions for this participant?
Ma'am, pardon? Okay.
Sir, can you please take it first?
Okay, thank you, Dr. Ajita. Okay, thank you, Dr. Priyanka. I just have one question, like who is the one who conducted the study, who asked the question to the participants, and the participants were like, the questionnaire was in English?
Yeah, the questionnaire was in English.
And our participants, I mean, like your participants all were like literate enough to understand?
Yeah, they were literate enough, but then the questionnaire was also translated, so since the patient could not understand, all the patients could not understand English, so it was translated in Hindi version also. So then it was given to them, and still the therapist asked the questions to them. Even if it was given to them, it was verbally asked by the therapist.
Oh, okay. So they were given explanation in the kind of.
They were given explanation, yeah.
Okay, fine. And what was the you feel like where you, because you couldn't show all graph and what I say, so where was lag back? What is the area of improvement you found, and what was the reason of that?
Yeah, the area of improvement was, some patients said that the time spent with the physiotherapist was a bit, the therapist would have spent more time with the patient. So that was one question wherein, that was something which should be worked on. So properly timing of the patient should be given, okay, so that the half an hour slot given to one patient. So that was something which needs to be improvised.
So this is one of the area you found like a weakness and then need to improve. And the questionnaire you adopted, maybe I couldn't get that. Sometimes slide was not moving. The questionnaire you used is adopted or you made?
No, it was an adopted one, sir, not the made one.
Okay, so adopted from which country? Like from India?
It was adopted from a study which was carried out in India itself.
Okay. So just was asking for reliability and validity. So if you have adopted and different part of India, so then maybe you can do a pilot before doing the main study. That's all on my side. Good. We need to explore this area also. Thank you for your presentation.
Dr. Pooja, I just have one question. As you said that the therapist should have invested more time in the patient. Last two bench. Sorry for the interruption. Okay, as you said that the therapist should have invested a little more time, that is an area of concern.
Yeah.
Have you thought about the thing that probably the condition of the patient did not require more investment of the time? Like, every patient is different.
Yeah.
And you might not require to invest the same amount of time with every patient.
Yeah, that's so true.
So how do you how does your questionnaire solve that issue? How does your questionnaire differentiate the patients based on their conditions?
Yeah, no, it actually, the questionnaire did not had a question, relating to the condition of the patient, right? So it was a generalized one, right? So it was not specific to the, this patient was, so it was not specific, ma'am. So we need to, to work on, I can have a self-structured questionnaire, a validated one, right? Which can be, some questions can be edited in that so that it becomes more specific to the, considering the condition of the patient.
Yeah, and there is one more thing, Dr. Pooja, that I was concerned about. Like, for example, there are different types of treatment that take different amount of time.
Correct.
Yeah, if you use a lot of machines and a lot of equipment for the treatment, every machine, every equipment might take 10 minutes, 15 minutes of treatment, and then the exercises and all.
Yeah.
Now, quite possible that somebody is using a manual technique, which requires only 20 minutes of treatment, and we cannot exceed the treatment more than 20 minutes. For example, just imagine dry needling.
Correct.
Though it is not really physiotherapy, but nowadays a lot of physiotherapists are using it. So the patient was given dry needling, the patient was treated with cupping, or the patient was just treated by mobilization, manipulation. Now, all these techniques require lesser time as compared to modalities, but they give you very good results.
Yeah.
So again, the result that the patient is receiving after the treatment is, I think, more important as compared to how much time was invested or how much, the patient and doctor interaction was, the physio interaction. So can you add something in your questionnaire that can actually solve this problem as well?
Correct. Because it needs to be added because suppose if I'm a patient, I feel my therapist should give me 20 minutes, for example. The other patient feels he should spend 1 hour with me, right? But then, so that needs to be added. Also, the electro and the manual therapy, that also needs to be very specific, the questionnaire. Yeah. So I'll work on it, ma'am, definitely. So that.
Just try adding something for that aspect. Otherwise, the presentation is good again. Oh, sorry.
Okay.
It was good, Dr. Future. Thank you.
Thank you.
Thank you, Dr. Priyanka, for your presentation. And the next presenter would be Dr. Apurva Gaikawar. Dr. Apurva? Yeah.
Yes,
Ma'am, please present your presentation and take over the session.
yes. Okay, ma'am. Am I visible?
Yes, ma'am, the slide is visible. Please go ahead, ma'am.
Good afternoon, everyone. The title of the presentation is Effect of Lower Extremity Strengthening on Balance by Timed Up and Go Test, a randomized controlled trial. Aging is an inevitable process of human life cycle. Due to aging, there are decline in various body systems. Neuromuscular component affect balance. With aging, there is loss of motor units and deceleration in the neuromuscular system. Lower limb muscle weakness can contribute to alteration in balance. Strength training increases the lower limb strength as well as improve balance ability in the elderly. Timed up and go test is a valid and simple method. Timed up and go test is a valid and simple method to screen the level of functional mobility as well as risk of fall. Those who take more than 14 seconds to complete the timed up and go test are at risk of fall. Need for the study. To carry out the activities of daily living independently and to reduce the risk of fall, strengthening is an important aspect. Aim and objective of the study to determine the effect of 12-week lower extremity strengthening program on timed up and go test among older adults aged 60 to 80 years. Hypothesis was strength training is effective to improve balance ability among older adults. Methodology. Study setting was VSPM's College of Physiotherapists, Geriatric OPD. Duration of protocol was 12 weeks. The sample size was 40. Sampling technique was convenient sampling. 60 to 80 years older adults of both gender were included in this study. They were walking independently with or without aids. Recent traumas to lower extremity, visual impairment, any movement disorder, participants were excluded from the study. The result of the study, age was distributed among two groups, 60 to 70 and 71 to 80 years. The mean age was 66 years. Gender distribution, 10 males were included in the experimental group and 8 males were included in the control group. Age-wise comparison of 1 RM for knee extensor predict the overall lower limb strength. So I have assessed 1 RM for all the participants. The 1 RM value for 60 to 70 age group in the experimental group was 2.94 and for the control group it was 2.62. Overall, the timed up and go score was improved during the strengthening protocol. The experimental group showed better results as compared to the control group. Strengthening improved the overall lower extremity strength and improved balance ability among the older adults. It also increased sarcopenic contractions and number of sarcomeres. Mitochondrial activity has improved. So the conclusion of study was strengthening was significantly effective to improve the timed up and go test for the older adults aged 60 to 80 years. These are the references. Thank you.
Dr. Ajita, you may start first, or maybe in the meantime, you can share the slide, please. Thank you for your presentation.
Dr. Apurva.
Yes.
Dr. Apurva, can you brief me with the exercises that you have administered to the patient?
I have given the lower extremity strengthening protocol to all the muscles with weight or own body weight. Squats are given. Heel rises, toe rises, as well as prone knee bending exercises are given.
कलर आहे सेम त्याच्याकडे. Where did you adopt this questionnaire form? I mean, this exercise protocol form.
From Dina Gardiner and Kisna.
And do you think there are no other researches on it? No one has ever researched it before?
Actually, researches are done, but not particularly with timed up and go test and strengthening to the lower extremities.
Frankly speaking, Dr. Apurva, I don't think so. Time up and go test is a very common test used for checking the balance, and Dina Gardner exercises are the commonest exercises. Are you sure there are no other researches on the same?
Ma'am, other researches have included other training programs as well as other outcome measures.
Okay. Like, what are your outcome measures?
Timed up and go test.
And what are the other researchers have used outcome measure? There's just one outcome measure for you?
Yes, ma'am. Other researches have included like sit to stand chair test, Berg balance scales, functional reach test.
This is your second, right? Okay, fine. Sir, I really feel that this research is something that I've read before, but anyways, it's up to you. Like, you can continue with your questions. This is all that I have got to ask.
Okay, ma'am. I'll look after it.
Okay, thank you, Dr. Apurva, for your presentation. May I know like the age group criteria you kept?
60 to 80 years older adults.
So the 80-year-old people were able to participate, all the respected elderlies?
Actually, I have included, but
how many of your
after
participants
screen,
were above the age of 75 or maybe above 70?
only one.
Only one.
76 was the maximum limit.
Okay, and that respected gentleman or the female or lady was able to do the exercises?
Yes, sir.
Oh, it must
Under
be quite fit.
observation, they were able to do all the exercises.
So what's your implication in case I'm also taking the lead from Dr. Ajita's question. May I know like what you imply with this? What you want to do further to this? Like, you say all the people with 70, 80, 60 should do this exercise, and what you want to
Sir, for
conclude?
fall prevention, lower extremity strengthening is a must-do thing, and we should include lower extremity strengthening for all the older adults as a preventive measure for fall.
So my last question, done. No worries after this. Which component of exercise has improved? You told all the close kinematic, right? Squatting exercise, isn't it?
Yes, sir.
So is it eccentric component has helped or concentric component has helped, or like something, the rationale behind improvement? They have improved. Yes, you can say that you have shown the improvement. What may be the reason they have improved?
Improved strength overall.
Improved strength overall. Okay, fine. Okay, thank you for your.
Thank you, Session Chair. Yes,
Rachita, I'll have to take a break for 2 minutes. I'll join again. Thank you.
Oh, sure, sir. Thank you. So thank you, Dr. Apurva, for your presentation. And the next presenter would be Dr. Sushmita Sapkar.
Good afternoon, one and all. Am I audible?
Yes, ma'am, you are audible. Can you please take over the session?
Yes, thank you so much. I'll share my screen. Ma'am, is the screen visible?
Yes, ma'am, it is visible. Please go ahead, ma'am.
Okay. Okay. Good afternoon to one and all present here. I'm Sushmita, and I'm a master's student at VSPM College of Physiotherapy. I welcome you all to this paper presentation. My topic for today's presentation is effect of Otago exercise program on, sorry, uh, wait a minute. My topic for today's presentation is the effect of Otago exercise program on gait speed in older adults, a randomized control study. Aging is a universal process. I, as a postgraduate student, have as a postgraduate student, have been working with many geriatric patients in the geriatric OPD at our institute. So the major cause of their health decline has to be the fall and injuries related to the fall. We have assessed them about the cause of it, and that we came that the reduced gait speed contributed to the fall and in this elderly population. So, to say the least, we have uh, searching for the uh, ways to deal with this problem. So we came across Otago exercise program and its effectiveness in reducing fall in elderly patients. The Otago exercise program has found to be effective for people of 80 years and above, uh, for up to 46% of reduction in fall and injuries related to it. So this study explores the concept whether the Otago exercise program can also improve gait speed in older adults. The need for study is more people are experiencing slower gait and reduced physical ability as they grow old. This encourages to evaluate the effect of Otago exercise program in improving gait speed in older adults. Aim and objective for the study to evaluate the impact of Otago exercise program on gait speed and improvement in distance covered in 6-minute walk test in older adults. The study hypothesized that the Otago exercise program will significantly improve the gait speed in older adults compared to the control group receiving traditional physiotherapy exercises. So let's jump to the methodology. This randomized control trial was done on total 120 older adults, which were distributed into two groups, each consisting of 60 individuals. The sample were collected by convenient sampling method, and the uh, the inclusion criteria consisted of older adults aged between 60 to 70 years and who can walk independently without walking aids. The exclusion criteria was the patient the individuals who had recent trauma to lower extremity, who had history of neurological deficit, and any cardiological condition. So let's jump to the results. Here we can see the table. The mean pre-assessment distance covered in both the group was same. It was 47 meters. Mean post-assessment distance covered in control group, whereas was 85.5 meters. And mean post-assessment distance covered by Otago exercise program group was 497 meters. The difference between pre and post assessment distance covered by control group was 138.5 meters, and distance difference between pre and post assessment distance covered by Otago exercise program group was 150 meters. You can see the graphs here. The first graph shows how the two groups have different readings, while the other graph shows difference between their distance covered in 6-minute walk test. So the conclusion for the study, the Otago exercise program significantly improved gait speed in older adults. This study can help us to support the use of Otago exercise program to improve gait speed and mobility
in older adults as a part of regular healthcare practices. These are my references, and thank you so much. This was my presentation. Hello, am I audible?
Yes, you're audible. Yes, maybe Dr. Jita can take the question first, then I'll take up.
Yes.
Okay. So, Sushmita, right?
Yes, ma'am.
Okay. Sushmita, can you please come back to the protocol that you have used? Otago
Yes.
exercise program. Can you
Ma'am,
explain it?
Okay, ma'am. The PPT cannot do not share the protocol. I'll
Yes.
just share it with the 1 minute, ma'am. Can you see the screen, ma'am?
Yes, I can, but I can still see your PPT.
Okay, ma'am.
You have used the protocol, huh? Maybe you can just explain it.
Okay, ma'am. That will be fine.
Yes, just explain it.
Yes. The protocol consists of a circuit training. First, it
Ma'am, sheet
starts with
close हो
the.
गई है. Last 15 minutes में sheet नहीं मिली.
Hello,
Yes.
am I audible?
Yes.
Actually, the protocol consists of a circuit training which starts with head movement. Then it comes to neck movements and back extension exercise. Then trunk movements, which consist of rotation and lateral flexion. Then ankle movements, and then the strength training comes across, which consists of knee strengthening exercises, hip strengthening exercises, then calf strengthening exercises also, then balance training, which consists of a tandem walk, then tandem stand, also walking and turning at the same time. As it progress, we can also keep the support, and the patient's balance progresses, we can remove the support. Uh, then heel walk, toe walk. The protocol consists of many things like one single leg stance also, heel walk. Um, yes, that's it, ma'am. Sit to stand also. Yes, ma'am. Hello.
Ma'am, is there any other questions?
I'm sorry, I was on mute. Okay, so I was asking you that how did you include or exclude the older adults? Like there must be other health issues as well in these elderly people, maybe osteoarthritis, or they are overweight and they cannot walk on their toes or their heels, or they cannot stand on one leg. There are different issues with the elderly people. So how did you
Yes, ma'am.
include or exclude these people?
Ma'am, first of all, the individuals who were willing to do the protocol were included. Then the conditions which were
Is there a network?
severe.
Yeah.
Yes, the conditions such as osteoarthritis and the rheumatoid arthritis, these conditions also, the patient with these conditions were selected as their uh, as they can do the exercise. जैसे कि the range of motion is restricted in some of them, so they were excluded from the protocol.
Can you please go back to this slide where you have the inclusion and exclusion criteria?
Yes, ma'am. Wait. Sorry, ma'am. Here's the slide.
in your exclusion criteria, it is nowhere mentioned that you will be including the patients or excluding the patients with osteoarthritis, rheumatoid arthritis, or anything of that sort. It has only been mentioned that recent trauma of lower extremity, history of neurological deficits, and
Yes,
any
ma'am.
cardiac conditions. Only these
Yes, ma'am.
people have been excluded. So how about the patient with rheumatoid or osteoarthritis?
Ma'am, I haven't mentioned it. Actually, I should have mentioned the condition.
Okay, and one more thing. Is there a
Yes, ma'am.
specific BMI for these patients, or you're comparing all kinds of all BMIs? Did you
No,
already
ma'am.
done so? Jama.
There was no criteria about the BMI. We took in all the BMIs and we also noted the BMI.
What was your outcome measure? Can you please go back to that?
Yes, ma'am. Actually, I haven't. Hello. Ma'am, it was 6-minute walk test. Hello.
Yes, ma'am, you are audible. Yes. So your outcome measure was 6-minute walk test,
6-minute
and
walk test.
that's all.
Just 6-minute walk test. Yes, ma'am.
Okay, so have you thought about this, Beta, that if a person has been checked with a 6-minute walk test and the patient is obese, the BMI is high, the patient might
Yes.
not give you the same amount of improvement as compared to someone who is lean and thin, who has a lesser BMI?
Yes, ma'am. That is a restriction about 6-minute walk test, I would say.
Just try improving this research by using some other outcome measure that can be more
Okay, ma'am.
generalized, or maybe just try and see if you can include similar BMI people for this research.
Okay, ma'am. I will
Just try doing
definitely
that,
look after it. Yes, yes.
and improve your inclusion and exclusion criteria. That is what I would say. Be more specific about what you're including in your research.
Okay, ma'am.
Thank you for the presentation.
Thank you so much, ma'am. Yeah.
Thank you for your presentation. No specific question. Thank you.
Thank you so much, sir. Thank you.
Thank you, Dr. Sushmita, for your presentation. And the next presenter would be Dr. Nikita Patekar. Dr. Nikita?
Yes, ma'am.
Yes, ma'am. Please
Yes,
go
ma'am.
ahead with your.
Okay. Is it visible?
Yes, ma'am. It is visible. Please go ahead, ma'am.
Good afternoon to everybody. My title is Effects of Aerobic Exercise on Anxiety and Depression in Polycystic Ovary Syndrome. Polycystic ovary syndrome is one of the most common endocrine and metabolic disorder. In premenopausal women, polycystic means many cysts in the, this refers to many partially formed follicles on the ovaries. Basically, it consists of combination of signs and symptoms of androgen excess and ovarian dysfunction with clinical manifestation of oligomenorrhea. Subfertility, we can also see hirsutism and acne. Research study states that 5 to 10% of the females aged between 18 to 24 years of age are affected mainly in PCOS. Need for study. It is observed that due to poor lifestyle and dietary habits, polycystic ovary syndrome patients are prone to develop anxiety and depression. Studies have shown that aerobic exercises helps to alleviate the PCOS symptoms by improving hormone level. As a result, the need to conduct a study on the effect of aerobic exercise on anxiety and depression in polycystic ovary syndrome was felt. Aims and objective to study the effectiveness of aerobic exercise on anxiety and depression in polycystic ovary syndrome according to depression, anxiety, stress scale. Methodology. Materials and method. Sample size 60. Study design, interventional study, sampling method, convenient sampling method, study setting, NYSS campus, duration 3 weeks. Total 60 PCOS females are included in the study, aged between 18 to 24 years, who are diagnosed with PCOS since 6 months. The whole procedure was the whole protocol of the study was explained to them, and the depression, anxiety, stress scale was filled from them initially. Those individual who has depression, anxiety, or both was given aerobic exercise for 3 weeks for 30 minutes, which consists of 10 minutes of warm up, 20 minutes of conditioning, and 10 minutes of cool down exercise. After 3 weeks of intervention, the individual again filled the depression, anxiety, stress scale on the basis of their pre and post results of the individual. The results was compared. This is the graph which illustrates the age group of PCOS students, which is mainly more students, that is 17 students found in the age group of 22 years. Based on their score, they were categorized into normal, mild, moderate, severe, extremely severe, in pre and post. This is the comparisons of prevalence of anxiety in number of individual at pre and post treatment is different subgroups. This is of anxiety. This bar graph shows the depression score in different state, that is normal, mild, moderate, severe, extremely severe of depression. Result: most of the participants presenting anxiety and depression lies in moderate categories. The number of individuals from mild and moderate anxiety subgroup were reduced from moderate and increased to normal anxiety subgroup post-intervention, that is by 33%. The number of participants from mild and moderate depression subgroups were shifted and increased to normal depression subgroup post-intervention by 10%. Based on the results of the study, aerobic exercise shows significant effect on anxiety in individuals having polycystic ovary syndrome. It also shows positive effect on depression, but those are not significant. Summary. Suppressing the symptoms of anxiety and depression. Aerobic exercise has various effects on body, as it increases the endurance to muscles and increasing the lean body fat mass, and also improve quality of sleep. Conclusion of the study is based on the result of the study. Aerobic exercise shows significant effect on anxiety, but it also has positive effect on depression, but those are not significant. Thank you.
Session chairs, any questions?
Just 1 second. Just Nikita, right?
Yes, ma'am.
Nikita, what was the duration of the aerobic exercises?
Ma'am, it was 3 weeks.
It was?
3 weeks.
No, it was for 3 weeks, but how long is the patient being involved in one session? What was the duration of a single session?
Ma'am, 30 minutes. 10 minutes of warm-up, 20 minutes of conditioning, and 10 minutes of cool down.
10 minutes of cool down.
Cool down.
Okay. And were all the patients given same kind of aerobic exercises?
Yes, ma'am. Same protocol to all the patients.
So how did you manage doing this? Your sample size was 60, right?
Yes.
So it was a group therapy kind of a thing?
Yes, ma'am. It was a group therapy.
How many groups do you have, Nikita? Just one?
Ma'am. Yes, ma'am.
How
Just
many
one.
groups do you have?
But
Just
I
one. There
have
is no
divided
control group?
into 30 groups. One group,
Okay,
in one
so there
group,
were
30 students. Yes.
Okay, so for one group you have given them aerobic exercises. What about the second?
Ma'am, I followed the same protocol for second group as well.
Then what was the point of comparison?
Ma'am, there wasn't any comparison, just for the sake. It was a large population. I've divided into two groups.
Acha, okay. For the sake of treatment, you have divided them into
Yes,
two
ma'am, for the
groups.
sake of
Okay. So you did not have a control group or any other group where you are just treating them with,
No, ma'am.
meditation or something else, or you're not comparing your group with anything.
No, ma'am.
Okay. And how did you get patients with anxiety and depression? Like, how did you diagnose that these patients were suffering from anxiety and depression?
I have given them depression, anxiety, stress scale, which they have to fill prior before the starting the protocol. On the basis of those questions, they have filled up the questionnaire. On the basis of that questionnaire, we have categorized them on the that is severe. Is it severe anxiety, mild, moderate, or severe? On the basis of this.
And hello, Nikita.
Yes, ma'am.
Am I audible? Yeah. So will you be including only the mild or mild, moderate, and severe, all three?
Ma'am, all three groups. That is a normal, mild, moderate, severe, extremely severe.
Okay. Can you go back to inclusion once again?
Yes, ma'am.
Okay, now again, I would come to the same thing. If you are taking anxiety and depression cases and all three,
Ma'am?
are you analyzing the result for all three separately? Or are you comparing them in one go? Like you're comparing all the three severe, mild, moderate, all three in one group, or you're like comparing them separately?
Ma'am, I'm not comparing them separately.
You're not comparing them separately. Okay. Oh, Nikita, this is a little difficult for me to understand. See, if a person has mild anxiety or mild depression, and pre and post values, whatever you take, that you have given them aerobic exercise, and then you take the post exercise or post protocol readings. Now, for a mild person, the results might be very good. On the other hand, somebody who is having moderate or severe anxiety and depression might require treatment from a psychiatrist or a psychologist as well.
Yes.
So how will you like compare all of them in one group? Is it really possible comparing all of them in one go? जैसे काम नहीं है, बस काम कर ले। है।
Dr. Nikita, we couldn't hear you talking.
Am
Hello,
I
Dr.
audible?
Nikita.
Am
Yes,
I
now you're
audible?
audible.
Hello. Hello.
Yes, Dr. Nikita, you're audible. Please go ahead.
Yes, ma'am.
Yeah, so I was just asking you that is it possible to compare all these patients with like mild, moderate, and severe anxiety?
Ma'am, we mainly found students with mild and moderate anxiety and depression only. There were no students with severe and extremely severe anxiety or depression.
Now, please come again. I did not hear you.
Hello.
Yes, you had moderate ones, right?
Yes,
Pre-test,
ma'am.
post-test, and mild ones, post-test, pre-test, right?
Yes, ma'am.
Yeah, so is it possible to like compare mild and moderate both together?
No, ma'am.
And were they or any other kind of medicine or any other kind of psychological counseling sessions or something of that sort?
No, ma'am. Other psychological condition was not given.
Okay, fine. So, maybe what you can do is you can improve this research by just segregating these patients into groups. People with mild separately and people with moderate separately.
Okay.
That would give you a better idea about how your aerobic exercise is helping. Because when it comes to things like psychological disorders or anxiety and depression, even mild and moderate makes a big difference. A person with mild anxiety, mild depression might not really require anything, just probably talking to their family members, having good medication and good symptom control can be helping them out with their anxiety and depression. But a person with moderate anxiety and depression, they will require much more rigorous treatment. Get my point? And in them, the improvement might not be as good and as quick as compared to the mild ones. So just try repeating the study in a more modified and more refined manner, where you can divide them into groups depending on the
Yes, definitely.
severity. And also you can have another group where you can compare something else, maybe meditation or anything, breathing exercise, a walk, something like that, or a slow walk in the nature, or maybe a counseling session or a group session where they can talk to each other.
Okay. Yes.
So just try doing.
Yes,
Just
ma'am.
refine it. This is a good research. Just refine it.
Okay.
Sir, that's all from our end. I mean, my end. Maybe sir would like to ask something in case.
No, that's fine, I think. Okay, thank you. Thank you for your presentation.
Thank you, ma'am. Thank you, sir.
Thank you, Dr. Nikita, for your presentation. And the next presenter would be Dr. Aneka Sangal. Dr. Aneka?
Yes, ma'am. Am I audible?
Yes, ma'am, you are audible. Can you please take over the session? Okay.
Yes, ma'am.
Please present your presentation, ma'am.
Good afternoon, everyone. My thesis topic is examining static and dynamic balance in single and dual task conditions among patients with chronic non-specific low back pain in age group 30 to 50 years, an observational study. So, introduction is non-specific low back pain is defined as a low back pain not attributable to a recognizable known example, infection, tumor, osteoporosis, fracture, structural deformity, inflammatory disorders, radiculopathy, Kodai-Kanai syndrome. Balance is an important term describing the dynamics of body posture to prevent falling. Static balance is the body's ability to maintain body balance in a still position and for a prolonged period of time. For example, standing. Dynamic balance is the body's ability to maintain balance when moving, such as walking, running, getting up from a sitting position, and agility movements. It has been proposed that the balance impairments in low back pain patients may correlate with deficits in the musculoskeletal and neural systems, such as compromised lumbar proprioception and delayed muscular response, which finally decrease lumbar stabilization. Need for the studies, most of the literature reviews suggest of postural stability among sports professional and elderly population, but no study focuses on population with low back pain due to prolonged working or sitting hours. Hence, the need of the study was to assess static and dynamic balance in subjects with chronic non-specific low back pain. Also, to increase awareness of fall risk and progressing disability among them, prediction of injury, advice about proper ergonomics, and design proper assistive devices for the same. Aim of the study was to assess the static and dynamic balance in single and dual task conditions among patients with chronic non-specific low back pain. Objectives were to evaluate static and dynamic balance in single and dual task conditions in patients with chronic non-specific low back pain and also among healthy individuals. Hypothesis was there was a significant difference in static and dynamic balance in single and dual manual tasks among chronic non-specific low back pain patients. Methodology used was the study design was an observational study setting Dr. Ullas Patil College of Physiotherapy, Jalgaon. Sampling method was convenient sampling, sample size were 32, calculated by using GPower software and then equally divided into two groups, group A, which includes 16 participants and group 2, including 16 participants. The inclusion criteria was age group between 30 to 50 years, both male and females, NPRS score ranging from 3 to 5 out of 10 for group B, that is chronic non-specific low back pain group, and non-specific chronic low back pain from at least 3 months for group B and normal BMI. The exclusion criteria was history of spinal surgery for at least 3 months, lower extremity musculoskeletal dysfunctions, vestibular dysfunctions, trunk or spinal deformity, presence of nerve root compression resulting with neurological symptoms and spinal pathology conditions and auditory deficits. Materials used were a stopwatch, a cup of water, pen, paper, 3 strips of sellotape and measuring tape. The procedure was the one leg stance. One leg stance test was done by static balance was assessed by one leg stance in single and dual task. To evaluate one leg stance, for single task, the patients were instructed to stand on one leg with eyes open. For one leg stance dual task, the patients were instructed to stand on one leg with eyes open. One leg stance duration was measured on the leg by using stopwatch. Procedure for Y balance test was Y balance test, which measures the muscular strength, flexibility, and proprioceptive sense of the lower limbs in 3 directions, that is anterior, posteromedial, and posterolateral, with supporting leg, with one leg supporting and the other right leg stretched. For right leg, the distance from the center footrest to the tip of the stretch leg was measured in centimeter units. An attempt was regarded as a failure and measured again if the supporting foot left was removed from the ground. If the body was supported with the stretch leg in order to keep balance, or if the patient did not return to the starting position. All the tests were carried out in 2 conditions, that is single task and dual manual task. Dual manual task, that is performance of the test while carrying a cup of water with the surface of water 3 cm from the edge. The whole procedure was demonstrated to the individuals. The individuals with shoe off stood on one leg at the mark tape with both hands on the hips. While maintaining the single leg stance, the subject was asked to reach to the free leg in the anterior, posteromedial, and posterolateral directions. The distance from the center of footrest to the tip of stretch leg was measured by using tape in centimeter units. The testing order was reaching in the direction anterior, posteromedial, and then followed by posterolateral. The leg length was measured from the ASIS to the medial malleolus with measuring tape in centimeter units to normalize leg length in an analysis of Y balance test. 3 practice trials were done for each direction and the maximum value was taken for the final analysis. The results of this study was statistical analysis. The data and measurements of subjects was entered in MS Excel before it was statistically analyzed. Means and standard deviations were calculated, and the unpaired t-test was used for between group statistical analysis to compare healthy group and chronic non-specific low back pain patients group. Total 32 individuals were taken, divided into 2 groups, healthy and chronic non-specific low back pain group. Mean age of the individuals in group A was 36.50 and group B was 44.94. Mean values were taken for both legs, one leg stance test and Y balance test in both single and dual tasks, and then compared within group A and B. So this was the baseline data. Intergroup comparison of mean and standard deviation of one leg stand, single task and dual task. Single task group, that is group A, healthy group, the mean standard deviation was 44.06 and for group B was 8.875. The p-value was set at 0.001, which is extremely significant. In dual task, the group A, which consists of healthy group, the mean standard deviation was 40.18 and the group B was 6.125. The significance was very significant. Table 3 depicts group comparison of mean of OLS, one leg stance duration in single task. Analysis using unpaired t-test shows that comparison of both group A and group B was statistically significant with p-value of 0.001. It shows one leg stance duration was significantly reduced in group B, chronic non-specific low back pain, than healthy. Also, these groups suggest that comparison of mean of OLS duration in dual manual task. Analysis using unpaired t-test shows comparison of group A and group B was statistically very significant with p-value of 0.0013. It shows one leg stance duration in dual task was significantly reduced in group B than group A. Intergroup comparison of mean and standard deviation of Y balance, that is single and dual task. Group A, healthy, and Group B, chronic non-specific low back pain. In both these groups, the Y balance test was done and the p-value was 0.001, which is extremely significant. And dual task group, Group A and Group B, the mean standard deviation was 81.87 and 54.25 respectively. The significant 0.001 was extremely significant. Table 4 depicts group comparison of mean of Y balance test in single task. Analysis using unpaired t-test shows that comparison of group A and group B was statistically significant with p-value of 0.001. It shows that Y balance test single task distance was significantly reduced in group B than group A. Also, this study suggests that comparison of mean of Y balance test distance in dual task.
Dr. Anaga, sorry to interrupt. You are exceeding your session timing. Can you please stick on to your
Yes, ma'am. Yes, ma'am.
Yes, please.
So the discussion is one leg standing was difficult for the back pain patients as there since increased body sway. The findings of the current study shows that single leg stance test could be incorporated as a part of screening protocol to identify women at increased risk in their 40s and 50s who experience fall risk without effective management. In summary, chronic non-specific low back pain disorders can be associated with neuromuscular alterations and decreased physiological functions, which in turn can lead to problems such as trunk fatigue, weakness, loss of mobility, sensory motor deficits, and consequently affects the balance. Hence, concluding to one leg standing durations in single and dual tasks were significantly reduced in group B compared with healthy group A. Hence, static balance was impaired in chronic non-specific low back pain group. Anterior, posteromedial, and posterolateral cumulative reach distances in single and dual tasks were significantly reduced in group B compared with group A. Hence, dynamic balance was impaired in chronic non-specific low back pain group. Ma'am, these are the references which I used for my thesis. Thank you so much.
Dr. Anaga, can you, am I pronouncing your name right?
Yes, ma'am.
Yes. So, Dr. Anaga, can you please go back to your inclusion exclusion slide?
Yes, ma'am. Yes, ma'am. Is it visible, ma'am?
Yes. This is your methodology, right? Just give me 1 second. Huh?
Yes, ma'am.
Males and females. Dr. Anaga, the females that you have included in this,
yes, ma'am.
Are they married?
Yes, ma'am. Mostly I have
And,
done
do
this.
they have kids? Do they have children?
Yes, ma'am.
Okay. Yeah. Okay, so they're married, they have kids. Fine. C-sections or normal delivery? With epidural, without epidural? Any history on that?
Ma'am, actually, there was no history of any kind of surgical traumas, like all were most normal deliveries.
Why I'm asking you this question, Dr. Anaga? Because there are females who give birth to, like, say, 1 or 2 kids. There might be flabbiness in their abdominal muscles, and even that can lead to low back pain. Now, again, in that case, the low back pain will be a non-specific mechanical low back pain.
Yes.
Right. But then, you cannot generalize these females with your counter male patient with the same condition. The condition here is different for the males and the females. Either you divide them on the basis of gender into 2 groups, or you exclude out any other condition that can lead to low back pain, non-specific low back pain in long duration, in like a a future health issue. For example, a female who is married, who has got kids, and maybe not so strong abdominal muscles, having low back pain, or because of epidural having a low back pain, is different from a male patient with low back pain.
Okay.
I don't know. I'm not really from the ortho background, but this is something that I feel that it separates your male and female population. So no doubt, what you have done is good, but your what should I say? Your sample is not really a very homogeneous kind of sample. Maybe sir would be able to throw some more light on this. I don't know whether he agrees with me or not, but sir, would you like to say something about it?
Yeah, kind of I agree on that. Just only the respective time I'm also feeling maybe she can think over about it. So I agree kind of that. Because implications are difficult to derive, like if you are not keeping it very specific.
Yes, exactly. The population that she has opted for is it's not a homogeneous kind of sample. It's a very vague kind of description. There can be so many factors leading to this low back pain in patients between the ages of 30 and 50. And those factors, the modifiable factors, even if we leave the factors that are like surgery and injury and maybe childbirth and all, even if we leave all of it, female body structure and the structure of a male body, that too at between the ages of 30 and 50, some of those females might have achieved their menopause, and some are still in the process of menstruation. They're still having their menstruation cycle running. So for such kind of male female categories, you cannot have one single group. You need to like either divide them or maybe reduce the age range that you have opted for, because this population is too big to justify your inclusion.
Yes.
And maybe just go through your inclusion once again. Where did you take this inclusion from? Where did you opted this inclusion from? You
Ma'am,
had
actually,
some
yes, ma'am,
literature supporting this?
Yes, ma'am, there is an article which shows they are taken the age between 25 to 50 years, 31
Okay.
females and
Male, female
30
both?
males. Yes, ma'am.
Okay, so male, female both in the same group?
Yes, ma'am.
Okay. Fine, Dr. Naga. This was my opinion. Now, maybe you can just work over it. Maybe you can have a further research which is more refined than this, where your sample is more specific as compared to this. And this is a good start, actually. So just go through it once more, see if you can refine it more.
Okay, ma'am. Sure.
And that is all from my end. Thank you.
Yes.
Okay, from my side also same, no questions specifically. Only thing, the implications can be more objective because dual tasking and is more implied for the neuro, but you're using it like for the musculoskeletal purpose. Okay, something new. So that's all. All the best, and thank you for the presentation.
Thank you so much.
Thank you, Dr. Anaha, for your presentation. And the next presenter would be Bhagyashree Sonekar.
Am I audible, ma'am?
Yes, ma'am, you are audible. Please go on with your presentation, ma'am.
Yes, ma'am. Sharing my PPT. Ma'am, my PPT is visible.
Yes, ma'am, it is visible. Please go ahead, ma'am.
Good afternoon, one and all. Myself, Bhagyashree. I'm from VSPM College of Physiotherapy from Neurophysiotherapy Department. So my topic is correlation between self-efficacy, disability and pain in individuals with chronic low back pain, a correlational study. Introduction. Chronic low back pain patients have discomfort in performing their daily activities which can interfere with their quality of life. Self-efficacy described as an individual confidence in their own ability to perform daily activities while in pain. Poor self-efficacy may hinder recovery and predict disability. Previous researchers stated that self-efficacy is one of the psychological factors that can affect disability and pain perception in people with chronic low back pain. Therefore, there is a need to correlate all different factors with chronic low back pain. Hence, the present study has been undertaken to establish correlation between self-efficacy, pain intensity, and disability with chronic low back pain in Indian population. Need for study. Self-efficacy is an important psychological factor in patients with chronic low back pain, which may hinder rehabilitation and delay the recovery. So it is important to treat psychological factors to faster the recovery. The relationship between self-efficacy, disability, and pain with chronic low back pain have been studied before, but very less literature to our knowledge is available of this correlation in Indian population. Hence, the need of the study is to establish correlation between self-efficacy, pain intensity, and disability with chronic low back pain. Aim and objective: to find out the correlation between self-efficacy, pain, and disability by pain self-efficacy questionnaire, numerical pain rating scale, and Roland Morris disability questionnaire in chronic low back pain patients. Hypothesis: there is statistically significant correlation between self-efficacy, pain, and disability in individuals with chronic low back pain. Method. Study design: it is a correlational study, study setting, VSPM College of Physiotherapy. Study population: patient attending OPD having low back pain since more than 3 months. Study duration was 6 months. Inclusion criteria: individual complaining of chronic low back pain with or without referred pain, pain for duration of more than 3 months. Both gender were included. Pregnant women and low back pain associated with psychiatric disorders were excluded. Sample size was 96. Materials. Pain self-efficacy questionnaire is a 10-item questionnaire developed to assess the confidence in people while performing activities in pain. They answer by circling a number on a 7-point Likert scale under each item, where 0 is equal to not at all confident and 6 is equal to completely confident. A total score ranging from 0 to 60. Higher score reflects stronger self-efficacy. NPRS scale ranges from 0 to 10, where 0 denotes no pain and 10 denotes extreme pain. The Roland Morris Disability Questionnaire has 24 statements, is calculated by adding up the number of items checked. The score therefore ranges from 0, which is no disability, to 24, which is no maximum disability. Higher score, higher the disability. This is a pain self-efficacy questionnaire. This is Roland Morris Disability Questionnaire. Result. Graph 1 shows statistically significant and negative correlation was found between self-efficacy and disability. As the disability increases, the self-efficacy of the patient decreases. Graph number 2 shows there was statistically significant negative correlation was found between self-efficacy and pain intensity. As pain increases, the patient's self-efficacy decreases. This is graph number 3, which shows statistically significant and positive correlation found between pain and disability. As pain increases, the disability of the patient also increases. Discussion. Individuals with low self-efficacy attempt to limit the activities that are painful for them. As a result, restricting one's activity for a long time causes physical impairment and disability. When self-efficacy is high, individuals believe that they can perform activity in pain and therefore decrease in disability. High self-efficacy leads to a person's perception that they are capable of dealing with pain and the situation arises from it, resulting in less avoidance of movement, less pain related fear,
and thus less intense pain is experienced by the patient. Thus, it is important to assess the self-efficacy in chronic low back pain patients for successful recovery. Conclusion: negative correlation was observed between self-efficacy, disability, and pain, with positive correlation between pain and disability among patients with chronic low back pain. These are the references which I have used. Thank you.
Sir, can you please go first? I mean,
Thank you,
again,
Dr.
I have a problem. I again have a problem with her inclusion criteria. So can you please go first?
Yeah, so just want to ask, like, why you haven't just like include any objective measure?
Sorry, sir, I did not understand.
Okay, you have used one disability questionnaire, right?
Yes, sir.
Like pain self-efficacy. So it's all
Yes,
about
sir.
like subjective concepts, right?
Yes, sir.
Okay, it's just asking one thing, inquisitive. Why you have not included? Because it's low back pain. Any objective measures such as range of motion, muscle strength, or sitting capacity, dynamic balance, or something. Why you
No,
haven't
sir.
taken any objective measure? It's only one question. I'm not saying it's not right. I'm just asking you why you haven't taken any objective measure which can quantify in the number. Because it's more on the psychosocial or psychological
Yeah,
component.
sir. Yes, sir.
Okay. Maybe you can consider that if you have time and like it's done, then it's okay. Maybe for the future studies.
Yes,
Can
sir. I will definitely add that, sir.
Yeah, it's more objective. That's only one thing. There's nothing wrong to do that. One more thing, if you are including the psychosocial component like Nagy model, any model specific, and you are going on those findings, then maybe include someone from psychology background or as a co-researcher so that they can guide you on those components. So it's more
Yes, sir.
justified. As a physiotherapist, we are intervening, going in that, that's okay. But we can have more scientific knowledge from a person working in that or have got
Yes, sir.
education in that. That's all. Thank you for your presentation.
Thank you, sir.
Okay, Dr. Bhagyashree
Yes,
Sonkar.
ma'am.
Okay, this particular suggestion is not only for Bhagyashree. This is for everybody who has opted low back pain, mechanical non-specific low back pain as their topic for research. You know, it is a topic which has been researched a lot about. You know, you'll get hundreds of researches, thousands of researches on non-specific low back pain, mechanical low back pain. So whenever you take such subjects as your sample, please be very specific with your inclusion criteria. You know, you cannot have a vague inclusion criteria. You cannot have a very big population. I mean, so the age gap, like for example, we are taking patients right from 30 years to 50 or 60 years. There is a normal physiology of the body, the normal, even the muscle strength, everything changes with age. So you need to be more specific what you're including in your research. Otherwise, you're not going to have a very homogeneous population, homogeneous sample. If the sample is not homogeneous, it is going to be, the results are going to be biased. So either you divide them into multiple groups depending upon their age, divide them on the basis of gender, but be very specific about the inclusion criteria and make sure that the comparison happens with a homogeneous sample, within a homogeneous sample. You cannot compare a 30-year-old male with a 50-year-old male. You cannot compare say 30-year-old female with a 30-year-old male. Even that will give you different results. So low back pain is very specific, and mechanical non-specific low back pain, you can have multiple reasons to it. You'll have to be more precise with your inclusion criteria. It cannot be a two-line inclusion, right? And just be sure that what you need to exclude. Same goes for the adult population. When you're taking older adults, be very specific कि आप क्या exclude करेंगे और आप क्या include करेंगे.
Yes, ma'am.
Because और भी बहुत सारे health issues हैं. And that is all. Otherwise, the researches are really good. Thank you so much, Bhagyashree. Thank you.
Thank you, ma'am.
Thank you, Dr. Bhagyashree, for your presentation. And the next presenter would be Dr. Anjali Batad. Dr. Anjali?
Yes, ma'am.
Yes, ma'am. Please go ahead with your presentation, ma'am.
Is my screen visible?
Yes, ma'am, it is visible, ma'am.
Good afternoon, everyone. My topic for today's presentation. My topic for today's presentation is impact of core stability exercises on menstrual pain intensity and kinesiophobia among teenage girls, a randomized control trial. Introduction. Primary dysmenorrhea is marked by lower abdominal pain during menstruation without pelvic disease, can significantly impair daily activities and lead to kinesiophobia, a fear of movement due to pain. It starts prior to or at the same time as the onset of monthly flow and progressively goes away after 12 to 72 hours. The quantity of prostaglandin secreted in endometrial secretions is closely correlated with the severity of menstrual cramps and the symptoms of dysmenorrhea that accompany them. The symptoms of dysmenorrhea include nausea, diarrhea, constipation, fever, irritability, myalgia, headache, and dizziness. These symptoms stem from elevated levels of endometrial prostaglandins and their metabolites. So core stability exercises strengthen the lumbar, pelvic, and abdominal muscles. Core stability exercises may elevate menstrual pain and reduce kinesiophobia by enhancing blood flow to the lumbosacral region. So the need for study is dysmenorrhea is a common gynecological disorder that is experienced by 60% of women during menstruation period. So the purpose of the study is to evaluate impact of core stability exercises on menstrual pain intensity and kinesiophobia among teenage girls, a randomized control trial. Aims and objective. This study aimed to assess the effect of core stability exercises on menstrual pain intensity measured using visual analog scale, and kinesiophobia is assessed with the Tampa scale of kinesiophobia in teenage girls. Hypothesis. There is statistically significant effect of core stability exercises on menstrual pain intensity and kinesiophobia among teenage girls. Methodology, study setting, tertiary healthcare center, gynecological OPD, physiotherapy OPD, medicine OPD, schools and colleges. Duration of protocol is 8 weeks. Sample size is 66. Sampling technique, convenient sampling method with inclusion criteria, girls suffering with menstrual pain of greater than or equal to 4 on the VAS during the first 3 days of menstruation. Exclusion criteria, juvenile diabetes type 1, pelvic floor or diaphragm injuries, pelvic dysfunction, PCOS and PCOD. These are the results. Core group stability group results. Menstrual pain intensity was the measurement tool was visual analog scale. The core stability group before the intervention it was a VAS on scale 4, and after the intervention it was 1. So there is decrease of 3 points. Kinesiophobia reduction measurement tool was Tampa scale of kinesiophobia. So before the intervention, the score was 50, and after the intervention, it was 25. So there is decrease of 25 points. Control group results, the menstrual pain intensity was on VAS 4 and after it was 2. So there is decrease of 2 points, and kinesiophobia reduction before intervention it was 50 and after the intervention it was 35. So there is decrease of 15 points. So the comparison between group A and group B, the core stability group showed a noticeable reduction in both menstrual pain intensity and kinesiophobia compared to the control group. Mean VAS scores for menstrual pain decreased from VAS 4 to VAS 1, and the TSK 17 scores reduced from 50 to 25 in core group. Mean VAS scores for menstrual pain decreased from VAS 4 to VAS 2, and TSK 17 scores reduced from 50 to 35 in the control group. Discussion. The core stability group's intervention significantly reduced menstrual pain and kinesiophobia compared to the control group. These findings suggest that enhancing core stability may elevate menstrual discomfort and improve confidence in movement, potentially promoting better physical activity and pain management. Further research should investigate the underlying mechanisms and long-term effects as well as individual response variation to tailor interventions. Conclusion. Core stability exercises appear to be an effective strategy for managing menstrual discomfort and improving physical confidence in teenage girls, potentially leading to better academic performance and overall well-being. So these are my references. Thank you.
Okay, Dr. Anjali.
Yes, ma'am.
How did you check for menstrual pain intensity, Anjali?
By asking to the participants, ma'am.
What? So it was on a vast scale.
Yes, ma'am.
Okay, so it was more like subjective assessment of pain. Okay, fine.
Yes.
And kinesiophobia among teen. What else do you have as your outcome measure apart from VAS? VAS is an outcome measure, right?
Yes.
Yes. What else is the outcome measure?
Kinesiophobia. Tampa scale.
How did you check?
By using
Again,
the
that is a subjective
questionnaire.
That is again a
Yes.
subjective scale.
Yes, ma'am. Yes.
Okay, fine. Teenage girls, what was your inclusion? Like from what age to what age?
Like ma'am, 13 years to 17. 13 to 17 years.
13 to 17 years. And
Yes, ma'am.
where did you get the sample from? It was OPD, schools, colleges, physiotherapy OPD.
Yes, ma'am. In our physiotherapy OPD also, then gynec OPD, and I also visited some Jilla Parichar schools near Hingna.
Okay. It's a good research actually.
Yes.
Fine, Dr. Anjali, I don't have any questions. I just wanted to be a little more clear, so I asked you to go back to inclusion
Yes,
exclusion.
ma'am. Yes, ma'am.
This is good enough.
Okay.
In case sir would like to ask something on this.
No, nothing. I don't have any specific question. Thank you. Thank you for your presentation.
Thank you.
Thank you, Dr. Anjali. Next, we would like to call Sanjana.
Good afternoon. Am I audible?
Yes, ma'am, you are audible. Dr. Sanjana. Yeah.
Let me share the screen. Today I will discuss effect of yoga and aerobic exercise in overweight and obese adults using sit and reach test. Introduction. Obesity and overweight are complex disorders in modern world.
Ma'am, your PPT is not visible. Ma'am, can you enter into the presentation mode again?
Let me check once. There may be some network issue.
Dr. Sanjana?
I don't know, there is some time.
These session chairs, Dr. Sanjana might be like having some network issues and all. So with your permission, can we move on to the next presenter and come back to Dr. Sanjana?
Yes, please go ahead.
Sure, ma'am.
Yes.
Yes, ma'am.
So the next presented would be Dr. Shrutika Vakanti.
Yes, ma'am.
Ma'am, please go ahead with your presentation, ma'am. Dr. Sanjana, please
Yes.
rectify your issues and we'll be coming back to you. Thank you.
Yes, ma'am.
Ma'am, is my screen visible? Is my screen visible?
Not yet, ma'am.
Now, ma'am, is it visible?
No, ma'am, not yet. Dr. Shrutika?
Yes, ma'am. Yes, ma'am.
Yes.
I'm just sharing.
Yes, ma'am. Please try again. Dr. Shrutika?
Yes, ma'am. Yes, ma'am.
Okay. Since you are also having the technical issues, session chairs, with your permission, can we move on to the next presenter and come back to the previous two?
Yes, fine, it's fine.
Yes.
Ma'am, is it visible now?
No, ma'am.
Okay, ma'am.
Okay, ma'am, no problem. So we'll be coming back to you, ma'am. So the next presenter would be Dr. Ankita Shah. Dr. Ankita? Ma'am, dear session chairs, we have got the information that Dr. Ankita's presentation is rescheduled to tomorrow. So the next presenter would be Dr. Rashi Sainath.
Yes, ma'am.
Ma'am, please go ahead with your presentation, ma'am. Since the time is running out, please make it quick.
Yes, ma'am. Is it visible, ma'am?
Yes, ma'am, it is visible. Please go ahead.
Okay, I'm
Maybe you can put
presenting
in
on
horizontal
prevalence
mode.
of.
We can see, but you can put in the horizontal.
Okay.
Okay, layout to horizontal. You're using mobile, right?
Yeah.
Then it's okay. Otherwise, it will be difficult. Yes, thank you.
Okay. So today's topic is prevalence of musculoskeletal discomfort in postmenopausal women. It is a cross-sectional study. Introduction. Musculoskeletal discomfort, mainly pain, has higher prevalence in women, among which it is higher in postmenopausal women as compared to premenopausal women, suggesting that the decline in reproductive hormone is associated with increased pain perception. It has been well known that musculoskeletal pain can be multifactorial in origin. At menopause, women are known to experience a number of physiological and psychological changes. It is associated with osteoporosis, osteoarthritis, and sarcopenia. Estrogen deficiency leads to increased cartilage wear and tear and joint surface erosion, reduction in bone mineral density, loss of muscle mass and strength, decrease in collagen content of connective tissue, which further leads to impairment in muscle performance and functional capacity. All these changes lead to early degeneration in postmenopausal women, may leading to musculoskeletal pain. The need for study. Musculoskeletal discomfort, mainly pain, are most common problem affecting day-to-day life. Postmenopausal symptoms are generally ignored in rural, suburban, as well as urban India, even if they suffer from symptoms silently. There is underreporting of symptoms due to socio-cultural factors as well as due to lack of awareness and knowledge about this condition. There are very few studies done, especially in India, to evaluate the prevalence of various musculoskeletal symptoms using standardized questionnaire in postmenopausal women. Therefore, there is a need to study the prevalence of musculoskeletal discomfort in postmenopausal women. Therefore, the current study will be conducted. The aim of the study is to study the prevalence of musculoskeletal discomfort in postmenopausal women. Study setting are hospital-based survey, study type and cross-sectional study. Target population are postmenopausal women, menopause for more than 1 year. Sample size are 100.
Inclusion criteria includes all postmenopausal women, women willing to participate in the study. Exclusion criteria includes women who have surgical menopause, women diagnosed with malignancy, women diagnosed with any medical condition of neurological, metabolic, musculoskeletal origin before menopause. Questionnaire use was standard Nordic questionnaire. Includes, have you at any time during the last 12 months had trouble? The result says that 79% of women have musculoskeletal discomfort and 21% of women have no musculoskeletal discomfort. This research aimed to find out the prevalence of musculoskeletal discomfort in postmenopausal women. According to the study, the prevalence of musculoskeletal discomfort in postmenopausal women is 79%. Similar prevalence of musculoskeletal discomfort in Karnataka, India was 53.3% and Nigeria was 60.79%, which states that maximum postmenopausal women are affected with musculoskeletal discomfort in India and abroad. During postmenopausal period, women is challenged to undergo various changes related to physical and psychological factors. Few factors are muscle weakness, muscle atrophy, and osteoporosis. There is reduction of estrogen hormone, which has important role in maintenance of musculoskeletal system. Osteoporosis can be one of the cause for women to have increased discomfort in back, knee region during postmenopausal period. These changes may lead to musculoskeletal pain in postmenopausal women and should not be neglected for treatment. Thus, the conclusion is prevalence of musculoskeletal discomfort in postmenopausal women by using standardized question concludes that 79% of the postmenopausal women have musculoskeletal discomfort, which signifies that there is high prevalence among this region. Summary. To study the prevalence of musculoskeletal discomfort in postmenopausal women. Method. All postmenopausal women as per the inclusion criteria were targeted for the study purpose. 100 women were included in the study and provided with questionnaire. Results obtained were 79% of the women reported postmenopausal musculoskeletal discomfort. Conclusion. The current study of prevalence of musculoskeletal discomfort in postmenopausal women by using Nordic musculoskeletal questionnaire concludes that 79% of the postmenopausal women have musculoskeletal discomfort, which signifies that there is high prevalence among postmenopausal women. These are the reference.
May I know like the parts of your questionnaire, like only one of the question you analyze it, like or like conclusion? I couldn't get that. Maybe.
Yeah.
Dr. Ajita, did you see? Maybe I missed it. Is it? I mean, like subsections, all the questions of Nordic, I couldn't read.
Yeah. The first question is, have you at any time during the last 12 months had trouble, ache, pain, discomfort, and numbness? Second question was to be answered by those who answered have trouble. Have you at any time during the last 12 months have prevented from doing...
Oh, yes. I mean to say your analysis of the questions from the participant.
I have not included in this study. Actually, this is only for postmenopausal women. Prevalence of postmenopausal symptoms, musculoskeletal pain.
Then what did you ask to the participant that I didn't understand? Maybe can explain that.
Do you have any pain since 12 months? Musculoskeletal pain, any type of musculoskeletal pain?
Only one question, is it?
Yeah, only one question.
Oh, okay. Only
It was
one
only
question.
it was only overall prevalence of musculoskeletal pain.
Okay, so on the basis of the questionnaire, you told that the pain is there. So then why did you include Nordic questionnaire?
Actually, I only included the part of Nordic questionnaire as it was standard standard questionnaire.
Okay, so you've taken a part of it and then you have just taken one question of it.
Yeah.
Okay. Thank you. Thank you for your presentation.
Okay.
Thank you, Dr. Rashi, for your presentation. And the next presenter would be Dr. Sanjana. Are you online? Dr. Sanjana?
Yes, ma'am.
Ma'am, you can go ahead with your presentation, ma'am.
Is it visible, ma'am?
Yes, ma'am, it is visible. You can go ahead, please.
Okay. Good afternoon, everyone. Um, Today I will discuss effects of yoga and aerobic exercise in overweight and obese adults using sit and reach test. Introduction: obesity and overweight are complex disorders in modern world. It is emerged as most prevalent sedentary lifestyle disorder in urban society. Excessive body weight is associated with various diseases, particularly cardiovascular disease, type 2 diabetes mellitus, obstructive sleep apnea, and certain types of cancers and osteoarthritis. Flexibility is crucial. Flexibility is crucial uh, for overall fitness, mobility, and injury prevention. Yoga is practice originated in ancient India. It includes physical postures that are asanas, voluntarily regulated breathing exercises, pranayamas, meditation, and certain philosophical principles. Aerobic activity is a rhythmic and repetitive and causes the muscles to work at level where they require oxygen for release of energy. It is an effective exercise in improving cardiovascular and metabolic risk factors among adults with obesity. As obesity epidemic rises, there is growing concerns about efficient obesity management. Obesity comes with certain causes which makes obesity management more complex. Need for study. Obesity is considered as a principal public health concern and ranked as fifth foremost reason for death globally. Yoga and aerobic exercises have shown promising result individually as they both are cost effective, improve overall fitness, can be performed and adapted easily by patients. Thus, yoga and aerobic exercises are implemented to determine which produces a superior effect in improving flexibility. Aim and objectives: to compare and to study and compare the effect of aerobic exercise and yoga on overweight and obese adults. Hypothesis: null hypothesis: there is statistically no significant effect of yoga versus aerobic exercise on overweight and obese adults using sit and reach test. Alternate hypothesis: there is statistically significant effect of yoga versus aerobic exercise on overweight and obese adults using sit and reach test. Methodology: study design is comparative study. Study setting is community. Study population obese and overweight with age group between 20 to 55 years, as the prevalence of obesity and overweight increased with the age from 20 years old onwards and reached their peak between 50 to 65 years almost, and declined slightly thereafter. Duration of study is 6 months. Sample size is 40. Materials used were measuring tape, yoga mat, weighing machine, and ruler. Inclusion criteria: age group between 20 and 55 years, both males and females, with BMI more than or equal to 25 kg per meter square. They were able to perform mild to moderate physical activity. Exclusion criteria: patients with comorbidities like cardiac disorders, hypertension, type 2 diabetes mellitus, dyslipidemia, metabolic syndrome, liver disease, and drug-induced changes with fat distribution, example following the chronic intake of corticosteroids. Results: with sit and reach test, the pre mean score was 50 in the yoga group was 15.85, and in aerobic exercise pre mean score was 14.95. Whereas in the yoga group, post mean score was 17.85, and post mean score in aerobic exercise group was 16. And this both are statistically significant individually with p-value of less than 0.001. This pair t-test is performed between and yoga group pre and post, and aerobic exercise pre and post, where both showed significant results statistically, but mean difference intergroup comparison, that is unpaired t-test, was not significant. Discussion:
This research aimed to find out the effect of yoga and aerobic exercise on overweight and obese adults on age group of 20 to 55 years. According to findings of the study, yoga and aerobic exercise are equally effective in improving flexibility in overweight and obese adults. Elevated body mass index (BMI) and central obesity has shown an association with number of diseases and metabolic abnormalities that have high morbidity and mortality. Yoga is a slow mode of exercise which stimulates muscle contraction and stretching at the same time. Uh, Previous studies suggested that by doing yoga asanas, it is possible to burn fat and boost metabolism. Previous study in 2012 suggested that aerobic exercise brings a significant reduction in body weight, BMI, and fat percentage in sedentary females brought by aerobic exercise intervention. The study concluded that both yoga and aerobic exercise are equally effective in improving flexibility using sit and reach test in overweight and obese adults. Thank you. These are references.
Thank you, Dr. Sanjana. And dear session chairs, you have any question for Dr. Sanjana?
Maybe just can show the methodology. Dr. Ajita, if you want to take up first, okay, otherwise can just show the methodology in the meantime.
Methodology.
Okay, so how the obese means, how did you define that overweight criteria?
Using BMI as in
So anyone who
more
has
than
got BMI
25.
more than 25.
More than 25 were overweight, more than 25 and or equal to 25, and more than 30 were obese.
Sorry?
More than 30 were obese, were included obesity.
So what is the difference between obese and overweight here then? Hello? Yeah, obese and overweight, what's the difference? How did you define that?
If BMI is more than 25, we call it overweight, and BMI more than 30 is obese.
Maybe I have reservations. 25 above is all is like how you define that? Maybe this is not so clear to me, this part only. What exercises they do? Aerobic means what? Can you show again that part? Which exercise they did?
Sorry?
Aerobic exercise. Can you show that exercise protocol, aerobic exercise protocol? What exercises they did? The participants. Yeah, you told that
Aerobic exercise were according to level of patient. Complexity was made and then
so it was
gradually
low
increased.
intensity.
According to ACSM, that 45 minutes of session was done.
So where is that slide? Yes, that's when I asked the guidelines. ACSM guidelines. Where are they? Did you include that? No.
No, I didn't include here.
Okay, and the period of habituation was given. Like, how did you like? So the day one, somebody come with 28, 29 BMI, or maybe it's overweight according to what you just now said. Then they will start doing exercise with high intensity, or like moderate intensity. They did habituation, or the how did you define that? How many times in a week, month they did exercise?
45 minutes twice a day for 8 weeks.
45 minutes twice a day.
Twice a day.
Twice
Including
a
warm up
week.
and twice a day. Twice a
Twice a
day
day.
for 8 weeks. Like three days a week.
Beta, you're saying that the patient was 2 times a day. The patient was doing aerobic exercise for 45 minutes. Am I right?
Yes, ma'am.
Okay. The guideline says so.
The
guideline that you have
as
used
ACSM guidelines for obesity.
So does that guideline states that an obese patient should be doing an exercise of 45 minutes twice daily?
They didn't mention about twice daily, but 45 minutes of exercise was mentioned there.
And were your patients able to exercise twice daily for 45 minutes?
Were they able to do it? Like, were they able to
Yes, ma'am,
do
with
aerobic exercise
breaks.
without rest with breaks?
With
Okay.
breaks, and
So
there that was mild, like started with mild exercises, and then gradually the complexity was made.
yes, so beta, that is what sir is
Like
asking you.
walking
How do you
45
decide that?
minutes.
How do you decide that this is mild exercise and then you are slowly, gradually you're increasing the intensity? How do you decide that? There has to be some guideline on based on which you will be increasing the or progressing the exercise.
Did you use anything like carbon formula or like the 220 minus age into 50-70%, something like that?
Yes, I use that. 50 to 60% of maximum.
So maybe
Of
not in the
maximum what?
slide, is it?
Ma'am, I'll look after it.
That's okay. So thank you for the presentation. Maybe you can include that thing also. It's more clear the
Yes,
methodology. Only thing that 45 minutes doing 2 time, like that's something like it's very
And
starting
maybe you should
45.
consider the patient's diet as well. You know, because
Okay,
whenever
ma'am.
you make the patient work aerobic, the patient is already obese, you are asking the patient to work out 45 minutes every day, twice. I'm absolutely sure that is going to increase. And exercise, not only exercise, will not help in improving the condition of the patient, whether it is obesity or overweight, just by exercising. You know, you need to take care of their diet aspect as well. And 45 minutes twice daily, frankly
Yes,
speaking, it is too much even for me. Leave aside an obese patient. I'm not obese, but still, even for me,
ma'am,
it is too much. I don't know whether your patient will be able to keep up with it or not.
ma'am, I initially included brisk walking, that kind of exercises that were so mild. And then, okay, ma'am, I'll look after it.
Okay.
Yeah, sure. Okay. Thank you.
Thank you.
Thank you, ma'am.
Thank you, Dr. Sanjana, for your presentation. And the next presenter would be Dr. Shrutika. Ma'am, are you available?
Yes, ma'am. Yes, ma'am.
Yes, ma'am. Please go ahead with your presentation, ma'am.
Yes, ma'am. Is the screen visible?
No, ma'am, not yet.
Now?
Yeah, it is visible now. Please go ahead now.
Yeah. Good afternoon, everyone. Myself, Shrutika. I'm presenting the paper on topic effects of oculus guided physical therapy in adjunct to conventional physical therapy in frozen shoulder patients. As you all know, what is frozen shoulder? That is also known as adhesive capsulitis, which causes discomfort, limited mobility, and joint stiffness. Various conservative physiotherapy managements are used in frozen shoulder patients. Previously, patients were mostly treated with various heating modalities, mobilizations, and exercises of shoulder. Virtual reality, on the other hand, may now utilize as a current treatment protocol. In this study, traditional therapy, which includes Maitland mobilization, is compared with virtual reality-based headsets guided physical therapy in addition to Maitland's mobilization. Need for the study was in frozen shoulder patients, usually traditional therapy including various shoulder exercises, heating modalities, and mobilizations were used. But in this study, virtual reality in addition to traditional therapy was used to assess the effectiveness of treatment, as there were no researchers as available on frozen shoulder patients with virtual reality. So aim and objective of the present study was to compare the efficacy of virtual reality headset assisted physical therapy with traditional physical therapy in frozen shoulder patients. Hypothesis, null hypothesis: after 2 weeks of traditional and Oculus guided physical therapy, individuals with frozen shoulder show no noticeable progress in range of motion. Alternate hypothesis was after 2 weeks of traditional and Oculus guided physical therapy, there is considerable improvement in joint movement of shoulder and discomfort. The methodology, the study was conducted in the musculoskeletal OPD of ABBR Hospital in Varda after receiving permission from the Institutional Ethical Committee. Study design was comparative study. Total 50 samples were included between the age group of 40 to 16 years, and they were divided into two groups, each of 25 participants with frozen shoulder condition. Inclusion criteria was a patient between age group of 40 to 60 years involving having stage 2 or 3 primary or idiopathic frozen shoulder. Exclusion criteria was patient with any other post-operative condition, having subluxation, shoulder subluxation or dislocation, or any other conditions like rheumatoid arthritis. Materials used were assessment pro forma, numerical pain rating scale as an outcome measure, numerical pain rating scale, shoulder pain disability index scale, that is PADI, and range of motion were used. Then these are the results which shows the ranges of shoulder, like shoulder flexion, extension, abduction, reduction, internal and external rotation were improved with both the therapies like conventional and Oculus guided physical therapy. Oculus Rift is a modern PC based VR gaming headset which is used in this present study, which shows a significant improvement in both the groups. But when comparing with the conventional therapy, Oculus guided physical therapy in addition to conventional therapy shows more effective. The result of the study is there is a reduction in pain when assessed with the numerical pain rating scales and improvement in shoulder pain and disability index. Also, there is an increase in range of motion. In this study, one group of patients had received conventional physical therapy consisting of Maitland's mobilization grade 3 and grade 4, and other group had received physical therapy using Oculus with Maitland mobilization. Conclusion, it shows that after comparing the results of the two study groups, patient treated with the interventions of Oculus guided physical therapy, that is virtual reality, shows more remarkable improvement in reducing pain and improving movement of shoulder and activities of daily living. These are the references, and these are the pictures, which is there is a Oculus Rift, which is wearing that woman patient was wearing Oculus Rift in picture 1 A and B, and C and D picture shows the Maitland's performance of Maitland's mobilization. Thank you. Any questions?
Thank you, Dr. Shrutika, for your presentation. I just have two questions, quick one. It's not related to exactly what you do. Is it an industry-sponsored research or is it your own
No, sir.
expenditure?
It's a institutional sponsor research. Yeah,
Oh,
it's from
so
college.
you got the instrument, the
From
Oculus, or
institution only.
oh, okay. So they have given you for a specific period of time, or you purchase the instrument. If you can
No,
speak,
sir. They
okay. If
have
you
given us.
want to
Yeah, sir.
avoid the question, it's okay.
It was a 2 week interventional protocol. They have given me for a 2 week, and I have used that.
Oh, and you found it's more interactive, interesting, or what?
Yes, sir. It was very interesting.
So you advise if you have your own clinic, you will have this one.
Yes, sir. But
So what
it's
was the two drawback? That's my last question. What do you think is not right if you use not specific this company, any other? What can be the improvement area of improvement?
Sir, there is a observation, and observation is perform these things under observation, and there is a quite knowledge of that thing is required while performing.
Anything on acclimatization, not acclimat, any habituation? The day when you start, or you will give some period to the participant and then you'll do the study?
Day one, it required some time for understanding and that performance. Day one is required. That is day one. 1 day is required for understanding. After that, patient also enjoys that intervention or treatment protocol. Patient actively participate in that, and patient eagerly waited for next session also.
Okay. Okay. Thank you. That's all on my side. Thank you for your presentation.
Yeah. Thank you, sir.
Thank you. There are no specific questions from my end, Shrutika. It is a nice topic. Maybe it can be explored more.
Thank you, ma'am.
Thank you, Dr. Shrutika, for your presentation. And the next presenter would be Dr. Ritika Mudaliar. Dr. Ritika?
Yes, ma'am.
Yeah.
Is my screen visible?
Yeah. Not yet, ma'am. Yes, it is visible now. Please go ahead, ma'am.
So, hello everyone. Myself, Dr. Ritika Mudliar. I'm a student of VSPM College of Physiotherapy, Nagpur. So, the title for my study is Resistance Exercises with Conventional Physiotherapy on Glycemic Control in Patients with Type 2 Diabetes mellitus. It's an experimental study. Diabetes mellitus is a metabolic disorder which is characterized by pancreatic dysfunctions and leads to glycemic control being affected. Also, it's very common globally. Diabetes poses a significant risk of renal disease, eye disease, and cardiovascular disease. Also alters glucose and insulin metabolism, which leads to inactivity. The American Diabetes Association advises people with type 2 diabetes to exercise for at least 150 minutes per week at a moderate intensity or 90 minutes at a vigorous intensity. Resistance exercises helps to enhance glucose control and can be recommended in patients with type 2 diabetes mellitus. In view of this, 30 minutes of resistance exercises for 5 times per week was incorporated in the study.
Ritika, would you mind sharing your title of the topic, because something is on my side. I say it's a different
Yeah,
name.
even in my list, yeah, it's not there.
I think my screen is hanged up.
Ritika Mudliar. Ritika Mudliar,
Yes,
is
yes.
that the name of the participant? Okay, so I have a very different topic, Ritika. I think it has been repeated. I think Yashasvi's topic has been mentioned in place of Ritika's topic.
Maybe you
Yes, it
can.
was a mistake which I have
Sorry
corrected.
for the
Just go back to
inconvenience,
your
ma'am.
topic now. We'll just correct it.
Yes, ma'am. Sorry for
And
the
let-
inconvenience. I'll be sharing the topic in the inbox, ma'am. Please check into
yes.
that. Yes,
Please
ma'am.
share, put in the chat box. Thank you.
Yes, ma'am. Yes, sir. Thank you. Yes, sir.
Is my second slide visible? Because I am not able to see my second slide.
Yes, visible. But you're on the slide 1.
Please put it on the presentation mode, ma'am, so that it will be visible.
Okay. So need for the study is resistance exercises has more impact on diabetic patients with a significant reduction of blood sugar levels. Therefore, resistance exercises were administered for quadriceps femoris, hamstrings, gluteus maximus, gastrocnemius, abdominals, and lumbar spine extensors, along with
अच्छा है
walking
टॉपिक देयर नाइस
and
इंटरेस्टिंग टॉपिक्स बट स्टिल कितना सुन सकता है कोई इंसान? मैं सुबह से सुन रही हूँ ना.
Hello. Am I audible?
Yes, ma'am. You are audible. Please go ahead.
Okay. To see and its effects on HbA1c and blood sugar levels were assessed. Aim and objective of the study is to find out the effect of resistance exercises with conventional physiotherapy on glycemic control in patients with type 2 diabetes mellitus after 12 weeks of exercise intervention. Hypothesis is resistance exercises with conventional physiotherapy is effective to improve glycemic control. Methodology, it's an experimental study conducted with 35 individuals who were pre-diagnosed cases for type 2 diabetic patients, was carried out in physiotherapy and medicine OPD of tertiary healthcare for 12 weeks of exercise intervention. Inclusion criteria are diagnosed cases of type 2 diabetes by the physician, fasting blood sugar level more than 126 and post-meal sugar more than 200, patients referred to the physiotherapy OPD, patients who are willing to participate, both genders, age grouped of 31 to 60 years. Exclusion criteria are secondary complications of diabetes, cardiac dysfunctions and congenital cardiac anomalies, patients undergone for recent surgery for heart, lung, and abdomen, any recent musculoskeletal injury interfering in performing the exercises. patients with neurological dysfunctions. So these are the exercises which I have performed with TheraBand: half jackknife exercises, pelvic bridging, abdominal crunches, Superman exercises in quadruped position, hamstring curls, dynamic quadricep exercises. So results. Graph 1 shows demographic data which was collected. Age, height, weight was collected and BMI was calculated. Graph 2 indicates gender distribution, in which 14 were females and 17 were males. Graph 3 shows the comparison of pre to post mean changes in HbA1c values. So the mean of day 1 was 9.72, whereas the mean value for week 12 was 8.68. Similarly, in graph 4, the comparison between pre to post mean changes in blood sugar level was significant, with mean value of 188.52 day 1, followed by 173.1 after week 12. Discussion: regular exercises shows an impact on glycemic index. Exercising regularly shows an impact on glycemic index. Resistance exercises helps to improve glycemic control in diabetic patients. So, following is the flow chart on right side. Physiological changes. It shows that resistance exercise, when performed, increases muscle contraction, which release muscle-derived factors and protein glucose transporter 4, which ultimately stimulates glucose intake in in muscles, increases insulin secretions, and thus reduces blood sugar level. Therefore, resistance exercises along with conventional physiotherapy should be implemented in type 2 diabetic patients for 12 weeks of exercise intervention. Conclusion for the study was resistance exercises with conventional physiotherapy was better in improving the glycemic control in patients with type 2 diabetes mellitus after 12 weeks of exercise intervention in terms of HbA1c and blood sugar levels when analyzed with paired t-test with p-value of 0.0001. So these are the references which I have used for my study. Thank you.
Dr. Ajita, I will take just only 2 questions there. First, sorry for that. Thank you for your presentation. Just wanted to know, Dr. Ritika, what
Yes.
about this one? Like, who conducted this blood test, sample and all? Who collected?
It was collected by the pathologist.
Okay, so you had some person who is in that field. Fine.
Yes.
And is it industry sponsored research or is it like?
Yes, it was.
Okay, so you can mention that in the study at the end or disclaimer. So it's more better so we can find out. Okay, and then one more thing, what is the rationale behind why the patient has improved that index? What do you think is the reason they have shown improvement?
So as the muscle protein decreases and also the glucose level decreases in skeletal muscles. So when we exercise regularly, according to the guidelines of American Diabetes Association, resistance training is helpful in improving the glycemic index and reducing HbA1c and blood sugar levels. So it's basically like you have to exercise or you have to strengthen your muscles to get the results. Strengthening plays an important role in the study.
Okay, so maybe just it's not my expert area, but I think peripheral utilization of the glucose increases. That's not the reason the exercise, but resistance means something new. So maybe you can get more on the discussion on that side later. That's okay, good, because diabetes is a prevailing problem. Okay, good. All the best. Thank you. Thank you for your presentation.
Dr. Ritika, I just have one question on this. What was your age criteria?
31 to 60.
Please come again. Hello, am I audible, Dr. Ritika?
Yes. 31 to
Yeah,
60 years.
31 to 60. And they were all like controlled diabetic patients?
Yes.
No
Yes.
fluctuation in sugar and all?
Yes. Uncontrolled patients were excluded.
Okay, they were excluded. Nice, Ritika. Thank you. And the conventional part of physiotherapy, what were they getting as conventional physiotherapy?
Was walking for 30 minutes.
Okay. Every day, 30 minutes once?
Yes.
That's all? There were no
For
other
5.
exercises?
Pardon me?
There were no other exercises, just one 30 minutes walk every day. That's all?
Yes. Yes, ma'am.
Okay. Thank you.
Thank you, ma'am.
Thank you, Dr. Ritika, for your presentation. And the next presenter would be Dr. Yashashri Rathod. Dr. Yashashri?
Yes, ma'am.
Ma'am, please go ahead with your presentation.
Good afternoon, everyone. Is my screen visible?
Yes, ma'am. It is visible. Please put it on the presentation mode.
Good afternoon, everyone. Myself, Yashasvi, is going to present a study. The title is Effect of Breathing Exercises and Thoracic Expansion Exercises on Respiratory Parameters in Restrictive Lung Disease, an experimental study. Restrictive lung diseases are a set of pulmonary disorders which are defined by restrictive patterns on the spirometry. That is, they are characterized by reduced distensibility of the lungs, impaired lung expansion, which leads to the reduced lung volumes, particularly the total lung capacity and the forced vital capacity. Now, physiotherapists use various techniques such as positioning, mobilization, percussions, vibrations, suction, and breathing exercises, and they treat in combination of these techniques with the aim of improving the patient's condition and preventing the complications. Need for the study is restrictive lung diseases reduces the lung expansion and the total lung capacity. These patients also experience dyspnea, which increases the work of breathing. Therefore, breathing exercises in the form of diaphragmatic breathing, segmental expansion exercise, along with thoracic expansion exercise were implemented, and its effects on the respiratory parameters were assessed. Aim and objective was to find out the effect of breathing exercise along with thoracic expansion exercise on respiratory rate and chest expansion in patients with restrictive lung disease after 1 week of exercise intervention. Hypothesis: breathing exercise along with thoracic expansion is effective in improving respiratory rate and chest expansion in patients with restrictive lung disease. Methodology: it was an experimental study in a the study setting was tertiary healthcare hospital. Study duration was 1 week. Study population was restrictive lung disease patients who were admitted in the hospital during the course of the study. Sample size was 30. The inclusion criteria was patients who were admitted in the ICUs and wards with restrictive lung disease of patients of both the genders, and the age was 18 to 60 years. Exclusion criteria was any unstable vitals, patients with active tuberculosis infection, patients who have undergone recent surgery for the heart, lung, or abdomen, and patients with any neurological dysfunction. So the results, the demographic characteristics of the participants. So the mean age was 45. The mean height was 1.62 meters. Mean weight was 62.83 kgs. And the mean BMI was 23.62. So gender distribution, out of 30, 18 were males and 12 were females. So this is the comparison of respiratory rate from day 1 to day 7. So the mean respiratory rate on day 1 was 27.1 breaths per minute, which reduced to 23.62 breaths per minute. And the analysis was done by paired t-test. So this is the comparison of the chest expansion from day 1 to day 7. So chest expansion was measured at 3 levels: the axillary level, the nipple level, and the xiphisternum level. So yeah, on axillary level, the day 1 mean was 0.36, which increased to 1.24.
At the nipple level, it was 0.34, which increased to 0.84. And at the xiphisternum level, it was 0.3, which increased to 0.91. It was also analyzed by paired t-test. Now, the breathing exercises along with thoracic expansion exercises reduces the work of breathing by involving the slow and controlled inhalation and exhalation, which lowers the effort required to breathe and hence helps to reduce the respiratory rate. These exercises also increases the inspiratory capacity and the mobility of the rib cage, which led to increase in the chest expansion. So this study concluded that breathing exercises along with thoracic expansion exercises were helpful in improving the respiratory rate and chest expansion in restrictive lung disease patients after 1 week of exercise intervention. Yeah, these are the references and thank you.
Yashasvi, your topic is really nice. The only problem is that these are two very established treatment protocols for restrictive lung disease. So what was new in your research is the only question I have.
Ma'am, the literature which, as far the literature I viewed, I didn't found the comparison these exercises clubbed together for the restrictive lung disease patient. Like these exercises we give to the patients of COPD, asthma, and like pneumonia, pleural effusion, all. But I didn't find in the generalized restrictive lung disease patient.
Okay, and how many cases of restrictive lung disease did you get?
Ma'am, I got
no. What is the prevalence of restrictive lung?
Sorry, ma'am, you're not audible.
Is 40?
Sorry.
Okay, I'm asking you how many patients of restrictive lung disease did you get for? Hello, am I audible now?
Yes, ma'am.
Okay, so I'm asking you how many patients of restrictive lung disease did you get for this particular research?
Ma'am, I got around 42 patients, and then according to my inclusion criteria, then I got 30 patients. I included 30 patients in my study.
Okay, and this was like 30 patients. How many months? How many? What was the duration in which you got these patients?
Pardon, ma'am?
How many months or how many did you take to find these?
Ma'am, that was not considered. Like the level of restriction was not considered in the study. Like there were some patients who were having mild restrictions, some were having moderate, and some were having moderate to severe restrictions also.
I think I can't hear, so maybe we can go next. So maybe can't hear.
I don't know. I lost connectivity, I guess.
Sir, is it audible now? Hello, am I audible?
Yes, yes, you are audible.
Yes, ma'am. Can you please repeat the question you said? Actually, I answered, but
yes, what I was asking you is how time कितना time लगा कितना आपको इस restrictive lung disease के patients ढूंढने because see restrictive lung disease consists of diseases, right? It is not just one disease. It is like you can have idiopathic lung fibrosis, even some types of sarcoidosis and all comes under restrictive lung disease when it starts giving you fibrosis of the lung. So there are like 5 or 6 common causes of restrictive lung disease.
Yes,
now, what I'm asking you is that how did you find 30 patients of restrictive lung disease? for your research?
Okay, ma'am, the study duration was for 18 months. So, like, it took me almost 18 months to find out these 30 patients.
Okay, because let me tell you one thing. The prevalence of restrictive lung disease is only 2.7 cases per almost 1 lakh persons in India between the age group of 35 and 44.
Yes, ma'am.
So that is the reason why I'm asking you that how did you get 30 patients of pure restrictive lung disease in such a short duration and you treated them and you got a result? That is the only question that I have in mind. Rest, the topic is something that has been researched a number of times. So yeah, the topic is good. Anyways, thank you. Thank you, Yashasvi.
Thank you, ma'am.
Thanks, Dr. Yashasvi, for your presentation. And the next presenter would be Dr. Simran. Dr. Simran, are you there?
Yes, ma'am.
Ma'am, please go ahead with your presentation now.
Yeah. Ma'am, is my screen visible?
Yes, ma'am, it is visible. Please go ahead.
Yeah. Good afternoon, everyone. I am Simran from VSPM's College of Physiotherapy. The title for my study is Effect of 5 Weeks Oculomotor Exercise Protocol on Dizziness, Handicap Inventory Score in Cervicogenic Dizziness patients aged 30 to 45 years. It is a pre and post study. Introduction. A clinical illness called cervicogenic dizziness is characterized by neck pain and dizziness. According to a prospective multi-center investigation, the prevalence of cervicogenic dizziness was 6.4%. Sensory motor control may be associated to the measurable changes in oculomotor function. The functional impact of dizziness can be measured using Dizziness Handicap Inventory Score, short form. Several research have focused on the efficacy of oculomotor exercises which help in decreasing the dizziness symptoms, but a graded protocol is needed. Need for study. A clinical illness called cervicogenic dizziness is characterized by neck pain and vertigo. Nearly 5% of all dizziness is caused by it. Available literature is lacking a stage-wise oculomotor exercise protocol to treat cervicogenic dizziness. Hence, the purpose of the study is to focus on a tailored progressive oculomotor exercise protocol, which will be well supervised as it is needed to overcome the dizziness and the disabilities occurring with it. Aim and objective to see the effect of oculomotor exercise protocol on dizziness handicap inventory score in cervicogenic dizziness patients aged 30 to 45 years. Hypothesis: there is statistically significant effect of tailored progressive oculomotor exercise protocol on dizziness handicap inventory score in cervicogenic dizziness patients aged 30 to 45 years. The methodology involved study design, pre and post intervention study setting, physiotherapy OPD of tertiary healthcare center. Study population was cervicogenic dizziness patients aged 30 to 45 years. Duration of the study 18 months. Sample size 42. Materials used pencil. Inclusion criteria: diagnosed cervicogenic dizziness patients. Patients scoring between 34 to 100, graded as moderate and severe handicap on the dizziness handicap inventory. 30 to 45 years of age, both genders, patients who are willing to participate. The exclusion criteria were patients graded as mild handicap on the dizziness handicap inventory, dizziness due to any other cause such as vertigo or BPPV, patients with a history of trauma to the cervical spine. The results of the study, age-wise, the first graph shows age-wise distribution in years for the patients involved. The second graph shows distribution of subjects according to the gender. So in the study, for age-wise distribution, 11 out of 44 patients were in the age group of 31 to 35, 20 were in the age group of 36 to 40, and 13 were in the age group of 41 to 45. For distribution of gender, 70% were females and 30% were males. Grade-wise distribution of participants according to dizziness handicap inventory. Here, 17% patients belong to moderate handicap category and 83% belong to severe handicap category. The next graph shows Comparison of pre to post test mean dizziness handicap inventory score. The pre-dizziness handicap inventory score was 60 and the post mean score was 28.09. Discussion. A pre and post test intervention study was conducted to assess the effect of 5 weeks tailored progressive oculomotor exercise protocol on cervicogenic dizziness patients using dizziness handicap inventory. The mean age group of the study population was found to be 38.090 with a standard deviation of 4.263. 50 participants out of 65 had cervicogenic origin of dizziness and were moderate to severe handicap on the evaluation scale. 8 patients were graded as moderate handicap and 36 were graded as severe handicap on the evaluation scale. Mild handicap patients were excluded from the study. Statistically significant of dizziness handicap inventory score confirmed the highly effective nature of oculomotor exercise protocol in treating cervicogenic dizziness as the pre-score of dizziness handicap inventory of 60 reduced to 28 post-intervention. Statistically significant difference in disability grades was seen with a decreased percentage of 55.04. Thus, the result of the study accepts the hypothesis. According to the flowchart, oculomotor exercises improved cervical afferent input with repeated and targeted muscle spindles contraction of the craniocervical muscles, further improved cervical proprioception, and hence leading to reduction in dizziness and neck symptoms. Conclusion: a pre and post intervention study design was carried out to find out the effectiveness of oculomotor exercise on dizziness and cervicogenic dizziness patients. Reduction in disability grades was seen as a result of the study. Thus, the study concludes that tailored progressive oculomotor exercise protocol was effective in reducing dizziness symptoms. These were the references of the study. Thank you.
Thank you, Simran.
Thank you for your presentation, Dr. Simran. Just I do have one question. Where did you learn this exercise? Did you took some special training for this? Or like how did you do? Because it can be quite strenuous for the patient participant. Did your patient or anyone among them told that after doing exercise they were having severe headache or something?
Dr. Simran, you are not audible. Can you please check your audio?
Or maybe if you have technical difficulty, no issues. We can go with the next presenter.
Okay, sir, no
And
problem.
maybe she can answer in the chat box. Maybe it's fine then.
Okay, sir. So, Dr. Simran, we request you to answer the question in the chat box. And the next presenter would be Dr. Rashi Budraja.
Yes, ma'am.
Yes, Dr. Rashi, please take over the session.
Is my screen visible?
Yes, it's visible.
Yes, ma'am. Please go ahead.
Awareness, attitude, and practice of home-based exercise therapy in diagnosed ankylosing spondylitis patients, a descriptive questionnaire-based study. Introduction. Ankylosing spondylitis is a chronic inflammatory polyarthritis common among the age group of 20 to 40 years with male predominance. HLA-B27 shows a major role in diagnosing ankylosing spondylitis. Common symptoms are joint pain, stiffness, and functional limitations, which are common, which needs multidisciplinary approach, including exercise therapy. Home-based exercise therapy allows adjuvant rehabilitation program to clinic-based protocol. Home-based exercise therapy program can be defined as exercises performed by the patient in a self-regulated home environment, including stretching, strengthening exercises, aerobics, breathing exercises, walking, etc., with the use of workout videos, exercise training materials, and exercise protocol notebooks. Awareness, attitude, and practice of home-based exercise therapy needs to be assessed in order to gain sustained effect of clinic-based rehabilitation. Need for the study. Regular exercises are recommended for ankylosing spondylitis patients to avoid further complications and deterioration of quality of life. Research has suggested that the physical activity is an efficacious strategy to improve disease control and elevate symptoms in rheumatoid diseases. Home-based exercise therapy helps to improve quality of life and functional capacity, thereby decreasing the disease activity and pain in ankylosing spondylitis patients. It has been suggested that home-based exercise program is an effective as center-based program covering all the aspects of the exercise. Home-based exercise therapy can mainly be used as an aid for ankylosing spondylitis patients to restore physical functions whenever the patient doesn't have an access to a proper clinic or center for physiotherapy. Therefore, a descriptive questionnaire study was conducted to understand the awareness, attitude, and practice of home-based exercise therapy in diagnosed ankylosing spondylitis patient to promote home-based exercise program in ankylosing spondylitis patients. Aim of the study was to study about the awareness, attitude, and practice of home-based exercise in diagnosed ankylosing spondylitis patients. Objective was to understand about the awareness, attitude, and practice of home-based exercise therapy in diagnosed ankylosing spondylitis patients by the results obtained from the questionnaire. Methodology: research design, descriptive questionnaire-based design setting, VSPM College of Physiotherapy in association with Ankylosing Spondylitis Welfare Society, India. Diagnosed cases of ankylosing spondylitis were a part of this, and who were a part of the society were included in the study. Sample size for the study was 100, but 266 patients were included in the study. The material which was required was VSPM's COP, Awareness, Attitude and Practice Questionnaire. Inclusion and exclusion criteria. Inclusion criteria: ankylosing spondylitis patients diagnosed according to modified New York criteria. Both the genders were included, age group varying from 15 years to more than 40. Exclusion criteria: individuals who have not registered or are part of the society, individuals who are not diagnosed with ankylosing spondylitis, any other arthritis than ankylosing spondylitis, or any other neurological disease or disorder. Results of the study: in the present study, ankylosing spondylitis, 48.9% were aware about home-based exercise therapy. 55.3% were found that home-based exercise therapy is helpful, and 69.9% practiced home-based therapy for more than 6 months. In the present study, the occurrence of male is to female is 13:7 ratio, which shows that 39.2% were male and 6.8 were females. Conclusion: the home-based exercise therapy needs more awareness, positive attitude towards exercise, and guidance exercise therapy program for practice under supervision of exercise professionals, which may be beneficial and helpful for improving physical, mental, and psychological well-being among patients with ankylosing spondylitis. These were the references. Thank you.
Thanks, Dr. Rashi, for your presentation. Session chairs, you have any questions for this presenter? Ma'am? Sir, you have any question?
No specific, maybe you just can share the methodology one time. You got a big number of participants, isn't it? Like you
Yes,
told.
ma'am.
Okay, so the participants are all based on one specific location, is it? Like
No, ma'am. No, ma'am.
Then like how is the criteria? What because it's a big number. Because
Ma'am,
ankylosing.
actually, there is a society, Ankylosing
Yeah,
Spondylitis Welfare Society of India,
Mhm.
where I have contacted the coordinator, and accordingly, the Google Form link was shared among the participants.
Oh, then you can include that all detail here, right? Because it's an extra effort, but not easy to get the number.
Yes, ma'am.
This can add up in the slides, so that's easy. There no questions arise there. Because very
Yes,
big
ma'am.
number you got. I
Yes,
think
ma'am.
more than what you got. I think maybe can do maybe regression analysis and all something more you can also analyze.
Yes,
Yeah,
ma'am.
because we couldn't judge in 10 minutes of time. You can do regression, you can do some further analysis of this. You know, regression analysis, like if you can find, then maybe it's more because you have questionnaire,
Yes,
you have
ma'am.
data. You can run more on that. You can
Yes,
come
ma'am.
something more broader than this. Okay, thank you for your presentation. That's all is on my
Thank you.
side.
Thank you, Dr. Rashi, for your presentation.
Thank you, Rashi.
Ma'am, you have any questions for this presenter?
No. I don't have any specific question for Rashi. Thank you, Rashi.
Okay, ma'am. Thank you.
Thank you, ma'am.
And the next presenter would be Dr. Mahek Koja.
Yes, ma'am.
Yeah, ma'am, please go ahead with your presentation, ma'am.
Is it visible?
Yes, it is visible, ma'am.
Okay. Good afternoon, everyone. My title for today's topic is Effect of 2 weeks of retrowalking using work balance scale in total knee replacement patients and experimental study. Total knee replacement patients surgery requires replace parts of injured or worn out tissue. The surgery can help ease out the pain and make the knee work better. Retrowalking reduces pain and improvement in function, quadriceps muscle strength, stability, and performance, which is regarded as an excellent closed kinetic chain exercises. The biomechanics of the muscles around the knee and ankle changes during retrowalking, as plantar flexors serve as shock absorbers, with the quadriceps and hamstrings contracting simultaneously. It also reduces eccentric quadricep activity while maintaining isometric and concentric quadriceps activity, which results in less compressive force at the knee joint, which significantly reduces pain and improves balance during walking. The need for the study is total knee replacement patients is available for severe persistent pain and decreased function for people with severe osteoarthritis. It is characterized by the reduction in pain and balance. Therefore, retrowalking exercises were implemented and its effect on balance were assessed. The aim of the study is to evaluate the effect of the retrowalking using work balance scale in total knee replacement patients. And the hypothesis was that retrowalking is effective to improve balance in total knee replacement patients. The study design was an experimental study which was conducted in the physiotherapy department of tertiary care hospital with the patient of knee replacement age 50 to 65 years. Duration of the study was 18 months, which was done on 40 patients. Materials used were Berg balance scale. The inclusion criteria were age between 50 to 60 years, including both male and female genders, and the patients be unilateral or bilateral total knee replacements. And it was done from the 30 days from the date of the surgery. The exclusion criteria was osteoporotic grade 3 and 4, joint infections, bone tumors, any neurological or cardiovascular disease, uncontrolled hypertension, collateral or any crucial ligament injuries. The results obtained were the graph 1 showing the age distribution and graph 2 showing the pre and post values of the Berg balance scale. The retrowalking showed great increase in work balance score. This indicated that retrowalking can be performed in patients with TCAR for increasing the score. This improvement showed reduction in the risk fall, which enhances functional independence, thus making the intervention beneficial for the population with impaired balance. Therefore, this exercise should be implemented in total knee replacement patients. It was concluded from the study that retrowalking was better in improving the balance in patients after 2 weeks of exercise intervention. These are my references for the study. Thank you.
Thank you for your presentation. It is relatively a new topic, and I think we do it for other neuro patients also this, and also for geriatric. For TKR, it's relatively okay. I would say it's quite new for me. How did you define that your participants understood what is expected from them, and you didn't anticipate any apprehension or they were scared? How did you train them in the initial days?
Initial days, I used the parallel bars for the training. In 1 to 2 session practice sessions were given to the patient so that they would understand what the exercise they have to perform. And then after that, when they get a better understanding of the exercise to be performed, they did it on their own, and I was assisting by the side if they face any difficulty.
Any specific footwear, or did you focus on specific group of muscle?
Basic group of muscles were focused like quadriceps, hamstrings, ankle plantar flexors, hip extensors.
Just my only thinking, like you have include your outcome measure as the Burke, right? Burke balance.
Yeah.
So if you go on all those 14 component, it will not be applicable for all. This is my understanding of the topic. Okay, I'm not saying it's wrong, but this is maybe you could have done some muscle strength assessment before and after. So you would have got like, okay, this retro walking will facilitate the what you say, eccentric contract control, right? So you could have done the eccentric control strength assessment before and after, or maybe something on the volume, muscle mass. So objectively quantifying would have been more, or maybe very specific some component of the Berg balance scale. A whole means is getting very general topic, is very general idea. Topic is good because there are so many components. If you explore example, I give 1 or 2 point there. So example, 1 second. So if you say that picking up the thing from the ground, or from the object from the ground, that how it will be impacted with retro walking or like walking behind. That's something like is my question. You understood what I'm trying to say?
Yeah, I got the question.
Yeah, like say for you have third component, third item, right? Sitting with back unsupported but feet supported on the floor, or maybe standing or stand to sitting, right? Standing to sitting, sorry. Then it is something like no, maybe yes, I go down if I standing unsupported with feet together, or maybe on 1 feet, picking an object. Some of the component, maybe those things, if you have evaluated, you can get like very specific objective, very specific things. Okay, I strengthen that. I ask him to walk. Yeah, I hope understood, right? But maybe we have restriction of time. Maybe we discuss. Yeah. Yeah.
Thank you.
Okay, thank you. All the best. Thank you for your presentation.
Thank you, sir.
Retro we also have explored something, but we don't have time. So good. All the best.
Thank you, sir.
Dr. Ajita, you have any questions for this presenter? Ma'am?
Okay. In the meantime, next presenter can share the slide.
Sure, sir. So the next presenter would be Dr. Bhavna Gopichan Chandni. Dr. Bhavna? Dr. Bhavna, are you there? Okay, sir. So with your permission, we are moving on to the next presenter. And Dr. Shukrit Kaur is not available today. So she mentioned she had an emergency, so she is leaving. And apart from that, the next presenter would be Dr. Amisha Modkare. Dr. Amisha?
Yeah, Ayush.
Yes, ma'am. Can I get 2 minutes?
Sure, Dr. Amisha. Do you need any preparation time for your presentation?
Just, ma'am, 2 minutes.
Oh.
We would
If
like
it
to
is
request.
taking time for the next presenter, with your respect, we can start with another one and then can come back on.
Sure, sir. Sure. So the next presenter would be Dr. Darshana Motilal Bole. Dr. Darshana? Dr. Darshana, are you online? Okay. So, Dr. Kasturi Kadilkar.
Yes, ma'am. Hello.
Oh, Dr. Darshana, are you online?
Hello.
Hello, ma'am. Yes, ma'am. We can hear you. So please go ahead with your presentation, ma'am, so that we could move on with your session.
Hello.
Hello, ma'am. Yes, ma'am. We can hear you, ma'am.
Hello. Hello. Yes.
Yes, ma'am, we can hear you.
I need some time. I need some 5 minutes. I can't screen it.
Oh, okay, ma'am. Okay. Dr. Kasturi, are you available? Dr. Kasturi? Okay. Dr. Anuradha Subhash Sutar?
I'm available.
Yes. Yes, ma'am. Please go ahead with your presentation, ma'am.
Yes.
Yes,
1 minute. I'm sharing the screen.
Okay, ma'am.
Is it visible, ma'am?
Yes, it's visible.
Yes, ma'am. It's visible. Please go ahead, ma'am.
Yes. Good evening, everybody. Myself, Dr. Anuradha Sutar, professor in Mind Physiotherapy College, Talegaon, Dabade, Pune. My topic is correlation of physical fitness index with body mass index using modified Haber step test in postmenopausal women. Introduction. Age-related variations, body build and physical activity determines the fitness level of an individual. The decrease in the estrogen at menopause is associated with increased abdominal and visceral fat if no concomitant change in the physical activity or the total body weight occurs, which results in a transition to an android pattern of fat distribution and increase in total body fat in women. Physical inactivity and hence the obesity are the major risk factors for ill health. The present study is done to assess the relation of physical fitness index with the body mass index using modified Haber step test in postmenopausal women. So need for study is the menopause, which brings in a whole lot of changes in the body of a woman, and in most of them leads to troublesome symptoms, namely the vasomotor, sleep disturbances, fatigue, aches and pains, alter cognitive functions, genitourinary problems, and weakness of connective tissue supporting the pelvic viscera. All these short and medium-term effects influence the quality of life of these women adversely. This puts these women an equal risk of coronary heart disease as their male counterparts. Women who pass menopause face many changes that may lead to loss of health-related fitness, especially if sedentary. So postmenopausal women are the increased risk factors of various health issues, including the cardiovascular disease, obesity, and the osteoporosis. So understanding how the fitness level relate to BMI can help to identify the risk population. So my alternative hypothesis, there is a correlation of physical fitness index with BMI in postmenopausal women. None, there is a no correlation. My aim of the study is to find out the correlation of PFI with BMI by using the modified Haber step test in postmenopausal women. Objective to determine the PFI by using modified Haber step test, to assess the BMI by Asian classification of BMI, and to correlate both of them. So my inclusion criteria was the postmenopausal woman more than or equal to the 12 month of amenorrhea, and age group was the 45 to 55 years. And exclusion criteria was with known cases of lower limb pain and dysfunction, which who have undergone any major surgery of lower extremity, chest and spine last 6 months. Women with systemic diseases like asthma, ischemic heart disease, COPD. So materials which are used, the standard weighing machine to measure the weight, stadiometer to measure height, modified Haber step test to measure the PFI, stopwatch and metronome. Methodology study design was the correlational study. Study type was the observational. Study setting in and around the Talegaon area. Study population was the post-menopausal women and sample size was the 64. So total 64 female were selected by purposive sampling. The body mass index was calculated by weight and the height. The physical fitness index was calculated by the modified Haber step test, measuring the pulse rate thrice during the step test, which is a valid and reliable tool. So preparation was done. The participants wear the loose, comfortable and light clothing and were given a 5 minutes of rest before the test. The pre-exercise pulse was measured. A 41-centimeter wooden stepper was used and the participants performed the test without footwear. The stepping rate was the 30 steps per minute, sustained for up to 5 minutes, that is 150 steps before starting. A demonstration of alternating stepping cadence was given and the metronome was set to signal every 2 seconds to guide the participants. The participants was required to lead with the same foot each time following a rhythm adjusted by the observer. Participants were encouraged to continue for as long as possible, but not exceeding the 5 minutes. If they experienced breathlessness, chest pain, or leg pain, they were instructed to stop. After completing the test, the participants sat quietly for recovery. The pulse rate was measured at different intervals, that is the 1 minute of rest, and at the following intervals 1 to 1.5, 2 to 2.5, and 3 to 3.5. If the participants couldn't maintain the stepping rate of the 30 steps per minute for 20 consecutive seconds, the rest was terminated. The duration of the effort was recorded to the nearest second using the stopwatch. This step test protocol evaluated both the endurance and the post-exercise recovery with careful monitoring for the participants' safety. And the physical fitness index was calculated using this formula. The total duration of exercises in seconds into 100 divided by 2 into sum of the pulse count during the recovery. So pulse 1, we have taken 1 to 1.5 minutes, pulse 2 to 2.5 minutes, and pulse 3, 3 to 3.5. So PFI rating, which is given according to the literature, if the steps were more than 91, then it is an excellent PFI. If it is in between the 84 to 91, it is a good. 77 to 83, fair, and below the 77, the poor PFI. So body mass index were calculated according to weight in kgs and height in meters square. So according to the Asian classification, who are less than 18.5 underweight, normal range was 18 to 18.5 to 22.9, overweight 23 to 24.9, obese 1 25 to 29.9, and obese 2 more than 30. This is according to the Asian BMI class, WHO Asian BMI classification. So approval was obtained from the institution head and the ethics committee before starting this procedure. Participants were selected according to the inclusion and exclusion criteria. The written informed consent was taken from the individual. Demographic data was taken and height and weight were checked using the weighing machine and the stadiometer. Physical fitness was assessed and statistical analysis was done during the Spearman using the Spearman correlation test. So the mean, whenever the study was done, the mean age was found to be a 51.65 plus or minus 3.46. Out of 64 participants, 24 belongs to the age group of 45 to 50 years and the 40 belongs to the age group of 51 to 55. And the mean BMI which was found to be the 24.8 plus or minus 3.36. Out of 64 participants, the 20 had a normal BMI, 19 were the overweight, and 21 belongs to the grade 1 obesity, and 4 where belongs to the grade 2 obesity category. Then mean physical, when we have done the analysis, the mean of the physical fitness index was found to be a 81.62, that is a plus or minus 5.08. Out of 64 participants, none of them showed the excellent physical fitness index. 21 showed the good physical fitness index. 21 showed the fair physical fitness index. And the 21 shows the poor physical fitness index in our study. So when we have done the correlation between these two parameters, the Spearman correlation coefficient was computed to assess this relationship. So there was a negative significant correlation between the two variables, that is the R is equal to minus 0.862, which indicates that as the BMI increases, the PFI decreases and vice versa. So t-test showed the statistical significant correlation between the physical fitness index, that is the T is equal to minus 13.5. So discussion. So this study showed a statistical significant negative correlation between the PF and BMI of the postmenopausal women, which indicating the higher BMI is associated with the lower physical fitness level.
due to reduce the estrogen level during menopause. There is a shift towards the abdominal and the visceral fat accumulation, which leading to the android, that is the male-like fat distribution pattern in the postmenopausal women. This may overall affect the physical fitness and the health. Additionally, another study which is highlighted that the postmenopausal women experience reduced exercise tolerance and the impairment in the maximum aerobic function when compared to the age-matched premenopausal women. These findings suggest that the menopause may lead to both the reduction in a muscle mass and decline in the aerobic capacity. So both of which negatively affect the physical fitness in this population. So the findings which align with the previous research by the Newsent, Yeoman and et al., who also find a negative correlation between the physical fitness and the quality of life in postmenopausal women. Exercise can potentially improve both the physical fitness and the quality of life in this population. So estrogen is a vital for maintaining the skeletal muscle function. So studies such as those by W. Dimitri Boulder
I can't hear you.
Dr. Anuradha, your voice is not audible. Please check your audio. Ma'am? Dr. Anuradha, you are not audible, ma'am. Dear session chairs, Dr. Anuradha is facing the technical issue, it seems. So, with your permission, can we move on to the next presenter? And when she get back, you can ask the questions in the text box.
Okay, noted. No issues.
Thank you, sir.
Ma'am, excuse me, ma'am. Hello.
Yes, ma'am. Please tell me.
Ma'am, Bhavna Chandani here, ma'am.
Yes,
I
ma'am.
was
The
not
next
able to
presentation
connect
is there.
because of network issue. Can I give my presentation now?
Yes, ma'am. Yes, ma'am. So,
Ma'am, I'm sharing my screen.
yeah, sure. So the next presenter would be Dr. Bhavana Gopichand, and we are getting back to her, sir.
Miss Bhavana, is it okay? Miss Gopika, can we take 2 minutes break? Miss
Yes, ma'am. Yes, ma'am. Sure.
Sure. Yes.
Dr.
Yes,
Ajita?
sir. Sure.
Okay,
Yes, ma'am. Sure.
Yes, sir. Sure.
thank you.
Thank you, sir.
Yeah, thank you for waiting. Please, you can start now. Appreciate it. Thank you.
Yes, ma'am.
sir. Yes, sir. We can start now. And the next presenter would be Dr. Bhavana Gopichan Chandni. Yes, ma'am. Please go ahead with your presentation.
Ma'am, is my screen visible?
Yes, it is visible.
Okay. Yes, ma'am. So today my topic of presentation is effect of textile particles on peak expiratory flow rate, PEFR, and observational study. Introduction: peak expiratory flow rate is the maximum rate at which the air can be expired after a deep inspiration. Peak expiratory flow rate is a measurable, reproducible ventilatory lung function test. Cotton dust exposed workers show various changes in lung parameters. To analyze the effect of cotton dust on peak expiratory flow rate in textile factory workers, this study was undertaken. Need for the study: to analyze the effect of cotton dust on peak expiratory flow rate in textile factory workers and to create awareness regarding the safety measures to be taken. Objective: to calculate peak expiratory flow rate in textile factory workers with Wright's peak flow meter. Aim: to measure peak expiratory flow rate among textile factory workers. Hypothesis: higher exposure to textile particles is associated with a significant reduction in peak expiratory flow rate among individuals working in textile manufacturing. Methodology: study settings, textile factory in BSPM's College of Physiotherapy. Materials: Wright's peak flow meter, pen stadiometer. Duration of study was 18 months. Sample size n is equals to 60. Sampling technique was convenient sampling method with inclusion criteria: minimum 1 year of work experience in cotton industry. Exclusion criteria was known cases of respiratory system disorder such as tuberculosis, asthma, COPD, lung abscess, cystic fibrosis. These were the results. The mean age in years of exposed and unexposed group was 30 years, which was estimated to 31.87 years. The mean age in years of cotton dust exposure in exposed and unexposed group was approximately 3.5 years, which was estimated to 3.467 years. The mean peak expiratory flow rate value of exposed group was 343 liter per minute, and for unexposed group, it was 383.67 liter per minute. Discussion: peak expiratory flow rate is a reliable indicator of ventilation adequacy as well as airflow obstruction. Peak expiratory flow rate shows significant decrease in textile factory workers. PEFR is the simplest estimate for lung functions and which indicates the severity of airflow limitation. The prevalence of respiratory symptoms was higher in the exposed group than in the control group, probably due to the inhalation of cotton dust in textile factory. The contributory factor was industrial pollution, occupational exposure to raw materials, cotton dust, byproducts, and products of several chemicals. Conclusion: peak expiratory flow rate was significantly reduced among spinning workers. Preventive measures are indicated to maintain peak expiratory flow rate values. Maintenance and marketing workers showed PFR values well within the limits. These were the references. Thank you.
Okay, thank you for your presentation, Dr. Bhavna. May I know like how you approach and where is your study done? I mean, need not
Ma'am,
to
it
say
was
the name of the place, but like how did you approach?
Ma'am, it was my factory only. So I approached there. It was in nearby in the Hingna premises. It
Sorry, I
was a
can hear
cotton
you, but not
factory.
loud enough. Maybe my background is not nice. Can you speak loudly a bit? Sorry. Yeah.
Ma'am, that cotton factory it was of me only. It was mine only. So I visited there only to collect the samples for my study.
Oh, is your home ground. So,
Yes, ma'am.
how about approaching to the workers? Like your total sample size is?
Ma'am, my total sample size was 60, in which 30 were directly exposed to cotton, directly exposed to cotton dust, and 30 were like unexposed type, means maintenance and marketing workers or workers which were working for transportation or in the which were exposed to premises dust, but not particularly to that cotton dust.
Oh, so you kept a criteria for an year of minimum exposure, is it?
Minimum 1 year of work exposure.
Oh, that one just maybe you have an operational definition why you kept 1 year?
Ma'am, because to significantly see the effect of it on PFR value, because if it is less than 1 year, so maybe the value can differ also.
You have some reference for it, is it?
Yes, ma'am, because it was minimum 1 year to show the effect on the lung function, that is the PEFR value.
Okay, okay. Appreciate. So how the workers have taken this?
Ma'am, I have explained the whole
No, no,
procedure for
no,
what.
no, I'm not asking the procedure. I'm asking how workers were reciprocated. I mean, like how they responded to it. Like, were they happy?
Ma'am,
were
they responded
confused?
very nicely. They were doing with various curiosity they were doing. So I have
So what's
taken
the
3
benefit of
readings.
the participant? That's my personal question. Like, I
Yes,
feel.
yes. Ma'am, it was beneficial because safety measures were explained to them, and preventive measures like they were not wearing the mask and all. So it was explained to them that wearing of mask is essential for their health.
Okay, good. So okay, you should go further about it and maybe try to publish, including all the presenter. But this one is going on the social context. So you are reaching out to the different strata of participants. So I think you can consider this later. Publish
Yes,
this
ma'am.
because if you have all the permissions, your own home ground, then fine and continue. This is a good. Is a maybe reaching out to the ground level. Good. All the
Yes,
best.
ma'am.
Everyone.
Thank
Good.
you.
Okay. Thank you. Thank you for your presentation.
Thank you, ma'am.
Dr. Bhavna, can you please go back to the inclusion slide?
Yes, ma'am.
I am sorry, it's not moving. Is it only my screen? Yeah,
Ma'am, it has
got it.
been.
Yes, yes, got it. Okay, minimum 1 year exposure. These are respiratory systems such as. Okay. Bhavna, did you think about excluding the ones who were smokers?
Ma'am, yes, I thought to exclude them, but in factory workers, most of them were smokers also. So I have taken their smoking history, but
Okay.
it was not of that much. If it was too much, if they were too much addicted to smoking, so I have not taken their readings because it would be definitely affected them. So I have taken
So
those
what
workers.
was the minimum? Yeah, what was the minimum criteria? Like how many packs were you considering to be like, okay, fine, I
Ma'am,
can
most of
include
them
them?
were telling that we are 1 or 2 cigarettes they were taking just a day, and that also occasionally. And that also occasionally, but some were like they were too much addicted, so I have not taken their readings.
Okay, now for all the interstitial occupational lung diseases, I mean, any kind of occupation where interstitial lung disease is common, there is a government guideline for taking up some safety measures. For
Yes, ma'am.
example, a mask, a complete kit is given to them where they wear a mask along with a cap and apron kind of a thing and all that. So, is that guideline followed in your factory as well?
Ma'am, previously it was not followed, but now it is it is being followed. It is being followed now.
Okay. So now if it is being followed, then I'm sure that most of your workers who are being exposed to textile particles are wearing masks.
Ma'am,
At least, I mean, that is the minimum criteria.
yes, ma'am, they are now wearing.
So how did you take the readings when they are wearing masks?
Ma'am,
Are they, yes.
Means recently they have started wearing, not means recently only they have started wearing.
Okay, so recently, like, your study is also recent, right?
Yes, ma'am, it is from December to February I have taken the readings.
Okay, and when did they start wearing the mask? Before this, they were
It
not
is
wearing
1
masks?
month, near about 1 month only, not more than that.
Okay, so why so like anyways, and that's a personal thing. But yes, that's the minimum guideline that usually the factories follow. So that is the reason that incidences of interstitial lung disease have reduced a lot. But anyways,
Yes,
the
ma'am.
topic is really good, and as sir said that you can actually try for a good publication out of this, and you can even consider vastening this research by probably communicating with other textile factories and mills.
Yes,
Even that
ma'am.
can be done.
Yes, ma'am.
It's a good topic, Bhavna. Thank you. Thank you for presenting
Thank you,
it.
ma'am.
Thank you, Dr. Bhavna. And the next presenter would be Dr. Amisha Mudgare. Dr. Amisha, are you here?
Yes, ma'am. Yes, ma'am.
Please go ahead with your presentation.
Yes, ma'am. Let me share my screen.
Sure. Dr. Amisha?
1 second.
Sure, ma'am.
Good afternoon, everyone. Myself, Dr. Amisha Modghare, presenting from VSPM College of Physiotherapy, Nagpur. Today, I'm going to present my study on effect on hamstring tightness using active hamstring stretching and post-isometric relaxation technique in young healthy females. So the hamstring muscle plays a major role in body mechanics. Being a biarticular muscle, it controls movement of hip and knee joint, thus controlling the alignment of pelvis and spine, and also dynamic posture, gait, and locomotion. For example, if one wants to fully flex his or her hip, it is only possible when knee joint is flexed, as well as due to relatively short length of hamstring muscle. The prevalence of hamstring muscle tightness is fairly high and appears to be increasing among the young adults, thus playing an important role in orthopedic conditions like hamstring strains, plantar fasciitis, low back pain. Hamstring flexibility is necessary for the optimum performance of major activities of daily life. Stretching is one of the many ways of treating hamstring tightness and improve muscle extensibility with other musculoskeletal structures which help to restore range of motion. Therefore, the current study aimed to investigate the impact of active stretching and post-isometric relaxation technique on enhancing range of motion and flexibility in health individuals experiencing hamstring tightness. Need of the study: hamstring muscle. Hamstring muscle is it is very common have tightness among young and health individuals. The hamstring muscles are especially prone of tightness, which can lead to musculoskeletal issues.
I can't hear actually. Sorry.
Ramisha? Yes, ma'am. There is some network issue.
Yeah.
One second.
Please go ahead.
Here come. Actually, I'm not able to share my screen. One second. I'm trying to share it again.
Yes, ma'am. Your screen is visible. Please put it on the presentation mode and continue.
Yes. Okay. So, which can lead to musculoskeletal issues. It is important to determine which method is most effective in clinical settings. That would help the physical therapist to choose the most effective hamstring stretching technique to improve general mobility of an individual and to prevent hamstring strain injuries. A main objective of this study is to compare acute effect on hamstring flexibility using non-ballistic active hamstring stretching and post-isometric relaxation technique in young healthy females. Hypothesis: null hypothesis, there is no significant acute effect on hamstring flexibility using this technique, these both techniques. Alternate hypothesis, there is significant acute effect of hamstring flexibility using non-ballistic active hamstring stretching and post-isometric relaxation technique in young healthy females. Method and methodology: study design, an experimental study, sample size 60 females from 20 to 30 years of age. Sampling method: simple random sampling. Study setting in medical college. Study duration 2 weeks. Inclusion criteria: females of age group 20 to 30 years of age, individuals with bilateral tightness of 20 degree or more. Exclusion criteria: any lower extremity, low back pathology, any neurological disorder, history of hamstring tear, hypermobility of knee joint, history of any recent lower limb fracture or surgery. Material used: plinth or couch. I used couch. Universal half circle metal goniometer, stabilizing belt, sketch pen, stopwatch. Methodology: the outcome measure of my study was active knee extension test. Hamstring muscle tightness is assessed by active knee extension test. The range of active extension of knee in the hip flexion position and hamstring muscle length are evaluated using the extension test. The more limited the knee extension, the tighter the hamstring. It states. Group A, I divided my whole sample size in two groups, Group A and Group B. Group A, the subject performed a dynamic stretch by swinging their leg forward into hip flexion with straight knee and pointed foot, that is, dorsiflexed foot, creating a stretch in the back of thigh. Then they swung the leg back into slight hip extension, repeating the cycle for 30 seconds. Group B, the post-isometric relaxation technique group, involved the subject lying supine while the therapist flexed the hip and extend the leg until the structural barrier was felt. The subject was then the subject pressed their ankle against the therapist's shoulder in a moderate isometric contraction for 7 to 10 seconds, approximately 25% of maximal contraction. After a brief relaxation, the therapist passively stretched the leg to the barrier for 30 seconds, followed by 10 seconds of rest. The sequence was repeated 2 more times. These are the results. This is a Group A, pre and post intervention active knee extension score. It is of Group A where we can see the knee extension angle is decreasing over the period of time. Pre-stretch gives mean of 25.43 and post-stretch gave 15.2. Here we can clearly see a knee extension angle is decreased over here. Then this is Group B, pre and post intervention, where the mean is again there is decrease in the knee extension angle in the Group B. This is Group A and Group B post-intervention mean differences. Here we can see the actual difference between Group A and Group B, and it is giving us a result of 0.001. It states that both groups are giving you hamstring flexibility, hamstring tightness is decreasing, but the Group B is actually giving you good results. A discussion. The hamstring muscle is crucial for ADLs, ADLs like sit to stand, forward bending, dynamic posture, and reach forward task. Tightness in the hamstring can lead to musculoskeletal issues and limit daily tasks. Non-ballistic active hamstring stretches increases the flexibility of tight muscles while concomitantly antagonist muscles. Post-isometric relaxation technique it is effective in many different manual therapy and effective for a variety of purposes, including lengthening or shortened or contracted muscle. It is also as a lymphatic or venous pump to aid a drainage of fluid or blood, increasing the range of motion. It takes advantage of the principle, which is relaxation of muscle following its isometric contraction. Post-isometric relaxation technique showed effective results in increasing active knee extension angle and decreasing hamstring tightness in young healthy individuals. Thus, this states that post-isometric relaxation technique is better than non-ballistic active stretching for improving hamstring flexibility. Conclusion, this study concludes that both non-ballistic active stretching and post-isometric relaxation technique improves hamstring flexibility. But when compared between both the groups, there was significantly more improvement in active knee extension test score by post-isometric relaxation technique in subjects. Clinical application of post-isometric relaxation technique can be used to achieve effective muscle lengthening in young healthy patients. For further recommendation, stretching other two joint muscles with this method can be evaluated. These were my references. Thank you.
Thank you for your presentation, Dr. Amisha. Dear session chairs, you have any questions for this presenter?
Dr. Ajita, if you have any questions specific. Thank you for your presentation.
No, sir, I don't have any specific questions on this.
Okay, fine. Something I learned from it. So all the best from my side, and thank you for the presentation. I have no specific question.
Hello.
Okay,
This
sir.
is hello, ma'am.
Hello.
This is
Hello.
Dr. Kasturi. I would
Yes,
like to present.
Yes, ma'am. So the thing is like we have a presentation scheduled before your presentation, ma'am. So please wait. After this presentation will be yours. Okay.
Okay.
Okay, ma'am. Thank you. And the next presenter would be Dr. Darshana Motilal Boli. Dr. Darshana? Dr. Darshana, are you available?
For the previous presenter, can we request her to send the title, because I find difficulty in locating that.
Yes, sir. Yes, sir. I'll be sharing the title, sir. Dr. Amisha's title. Yes, sir. I'll be sharing it.
The previous one, yeah. Okay, the relaxation hamstring one, yeah. I don't have
Yes,
that.
sir. I'll be sharing it right away.
Thank you.
So it seems Dr. Darshana Darshana is not available in this call. With your permission, session chairs, can we move on to the next presenter, Dr. Kasturi?
Sure, sure.
Yes.
Sure,
Dr.
ma'am.
Kasturi?
Yes, ma'am.
Ma'am, please go ahead with your presentation, ma'am. Please
Yes,
take the
ma'am.
session.
Yes, ma'am. I'm sharing my screen.
Yes, yes, ma'am. It is not visible yet.
Is
Yes, ma'am,
it
it is
visible?
visible now. Please go ahead with your presentation.
Yes.
Ma'am, please start your presentation, ma'am.
Yes, ma'am. Is it visible?
Yes, it is. Yes, it is.
Good evening, everyone. I'm Dr. Kasturi from VSPM College of Physiotherapy. Uh, the title is Immediate Effect of Respiratory Exercises in Chronic Smokers on Respiratory Parameters. It is a pilot study. Introduction. Smoking cigarettes continue to be the primary cause of avoidable illness, death, and disability. Globally, more than 1 in 3 men aged 15 or older in 2020 used tobacco in some form, compared with about 1 in 12 women, according to the WHO. Chronic smoking can weaken the muscles required for breathing, which can lead to dyspnea and impair exercise capacity. Therefore, therapeutic interventions are required to strengthen respiratory muscle functioning and improve breathing. Need for the study. Smoking can harm the lungs and cause cells to become oxygen deficient due to increased blood level of carbon monoxide and decreased hemoglobin, which carries oxygen. Respiratory exercises in the form of pursed-lip breathing, diaphragmatic breathing, and segmental breathing help to maintain coordination among muscles involved in breathing, thereby increasing air influx into lungs and discharging air via relaxation of respiratory muscles during expiration. Aim to study the immediate effect of respiratory exercises in chronic smokers on respiratory parameters. Objective studying the immediate effect of respiratory exercises in chronic smokers on respiratory parameters. Methodology, study design, pilot study, study setting, community-based study population, chronic smokers, duration of study 1 week, sample size 5. Eligibility criteria, inclusion criteria, patient should be conscious and oriented, males 20 to 40 years. Exclusion criteria, unstable vitals such as temperature, blood pressure, heart rate, and respiratory rate. Active tuberculosis infection, patients or subjects who have undergone recent surgery for heart, lung, or abdomen, subjects with neurological dysfunction. Result, the peak expiratory flow rate mean value before exercise intervention was 430 liter per minute, and after 1 week of exercise intervention was 516 liter per minute. These are the tables. Conclusion, respiratory exercises in the form of diaphragmatic breathing, pursed-lip breathing, segmental breathing are helpful in improving PFR in chronic smokers after 1 week of exercise intervention. These are the references, ma'am.
Okay. May I know your name? Yeah, Kasturi. Dr.
Yes,
Kasturi,
Dr.
do you define how do you define chronic smokers?
Chronic smokers, I have defined here, like the ones I have taken here are the people who have been smoking at least 3 to 4 cigarettes per day for 5 or more than 5 years.
Only cigarettes?
Yes, ma'am. Only cigarettes. No people with smoking BD.
Okay, no unfiltered, only filtered
Yes.
since they are smoking.
Yes.
Okay. Now, Kasturi, why did you take PER as the outcome measure?
Peak expiratory flow rate, because ma'am, it has been seen and it has been quite evident that PEFR, it is decreased in the people who are smokers and who have been smoking as compared to the individuals who are not smoking or non-smokers.
Okay, but do you think that FEV1 or FVC ratio, FEV1 FVC ratio better? Uh, I mean, it would
Yes,
be a
ma'am.
better marker for anything that's obstructive. Because smoking gives you an obstructive disease. Chronic bronchitis is what a chronic smoker would
Yes.
suffer from, right?
Yes, ma'am.
So if the person is suffering from chronic bronchitis, in that case, FEV1 and FEV1 FVC ratio is something which is diagnostic of this condition. And when you treat these patients, again, the post-treatment parameter should be FEV1 and FEV1 FVC ratio. That will give you a better prediction of whether your exercises are working or not.
Yes,
Why
ma'am.
just PEFR?
Ma'am, I thought PEFR would be evident, but I
Okay.
would
Now
pay attention to
yes.
this ratio as well, because since smoking affects the chronic obstructive pulmonary disease, it has a major role in that. So if FPV1 by FPC ratio, I would I would like to take that into consideration as well.
Okay, and the other thing is, what was the occupation of these people whom you have included?
I have only included 5 people who are aged between 20 to 40 years. All are male, and the occupation wasn't like they were not industrial workers, or mostly they were from the IT company, IT sectors.
Okay, so have you thought about this that probably in IT company workers, because they are living a sedentary lifestyle, even if like smoking, no smoking, anyhow their PEFR is low?
That might be the case, ma'am, but when we compare it with smoking cigarettes, particularly with those who are not smoking, their PFR would be evidently low.
Okay, so then you had two groups?
No, ma'am. I didn't have 2 groups. I just had
Then
1 group.
okay, then how did you compare it? You did not compare it, right?
Ma'am, I compared it with the normal value, the general normal value of PEFR of
But
young
quite
adults.
possible that an IT worker who is into a sedentary lifestyle, even their normal PEFR values are reduced. There are researches that suggest that if a person is uh, into a very sedentary kind of lifestyle, even they can have a reduced PEFR.
Okay, ma'am.
So if we don't compare it with the normal population, how do we know? Maybe from the same office, you could have taken 5 more people who were non-smokers, and you could have
Yes,
checked
ma'am.
them as control group, and then compared the
Yeah.
values. That could have a better comparison.
Yes, ma'am. I would
Because see,
reconsider it, ma'am.
and what were the exercises that you gave? One was diaphragmatic breathing and
A pursed lip breathing and segmental breathing. All of
okay,
them
why
are
pursed lip
active.
breathing? Why pursed lip breathing?
Ma'am, pursed lip breathing also decreases our respiratory rate. It is useful in decreasing the respiratory rate, and the people who are working in IT sector, they are under stress and pressure. So I thought that this exercise might be beneficial for them. Since this
Okay,
exercise is
so Kasturi, what I want you to do is, what are you doing right now? You're like working somewhere, you're teaching somewhere, or you're a student?
ma'am, I am master student.
You're a master student. Okay.
Yes,
So
ma'am.
Kasturi, what is your area of specialization in masters?
Cardiorespiratory.
Fine. So since you belong to my stream of specialization, I'll just suggest one thing, Kasturi. Go and read about the indications of pursed lip breathing. ठीक है
Okay,
बच्चा?
ma'am.
See,
Pursed lip
Yes,
breathing
yes.
is something that, if used inappropriately, can actually lead to reduction in PEFR.
Okay.
You're getting my point?
Yes,
See, I
ma'am.
am a certified Buteco practitioner. So in Buteco, we do not let a person breathe in or out through mouth. Pursed lip breathing is a kind of exhalation through mouth, and there are very specific indications to it. If used other than for what it has been indicated, if you use it for anything else, it can actually give you very detrimental effects when it comes to breathing. It can give you bronchoconstriction, it can give you vasoconstriction. So pursed lip breathing is a dangerous exercise. Just go and try searching literature on pursed lip breathing.
Yes,
Right?
ma'am.
Do that. And then you can
Yes, ma'am.
probably repeat this study. This was a pilot study, right? So instead of a
Yes, ma'am.
pilot study, you can
Yes, ma'am.
Ma'am, we couldn't hear you, ma'am.
a little the exercise to the person should be
Yes,
more
ma'am.
well researched,
Okay,
right?
ma'am.
Just search what can you do for a smoker. Okay.
Yes, ma'am. Thank you so
Okay. It
much
was a
for
good
the insight, ma'am.
try, Kasturi. And even though you're just a student in MPT right now, you have done something good. So don't worry about that. Okay. It's a good presentation.
Thank you, ma'am.
Sir, anything from your end?
No, nothing. Thank you. Thank you for your presentation. It's something new.
Thank you, sir.
Thank you, Dr. Kasturi. And
Yes, ma'am.
the next presenter would be Dr. Prerna Kale. Dr. Prerna? Dr. Prerna, are you here?
Yes, ma'am.
Yes, ma'am. Please go ahead with your presentation and the screen is visible.
Yes, ma'am. Good evening, ma'am. May I audible?
Good evening, Dr. Prerna, and your presentation is also visible. Please go ahead.
Okay. Good evening, everyone. My title is Peak Expiratory Flow Rate and Respiratory Rate in School Teachers Exposed to Chalk Dust, a pilot study. Teachers who use chalk and chalkboard run the risk of developing occupationally linked pulmonary function impairment because chalk is large source of fine particles.
Thanks. You can let again play it. Pretty, just gonna keep it here. Go bring it, mommy. I cannot do. I cannot play it. No, you go. No, you bring it. Play with mommy. Please excuse me. You play with mommy. I cannot be.
Just for 1 second.
Sorry.
Dr. Prerna, are you facing any technical issues?
Hello.
Yeah, I cannot hear from last
Hello.
2 minutes. You can go that side.
Hello?
Yes, ma'am.
Yes, ma'am.
Yeah, I am Dr. Anuradha. Can I present now?
Ma'am.
Hello.
You can go that side.
Ma'am, currently a presentation is going on. So it would be so great if you could wait.
You bring that and just consider that.
Ma'am, screen is.
Video, not here. Listening right now.
Dr. Prerna?
One more time, okay?
Yes, ma'am. Screen is visible.
Yes, it is visible, and please resume your presentation, ma'am.
Maybe around 30 minutes will be done. Okay. Thank you. Thank you.
Teachers who use chalk and chalkboard run the risk of developing occupationally linked pulmonary function impairment
because chalk is large source of fine particles matter in classroom and chalk dust may be detrimental to those with allergies, resulting in laryngitis and breathing problems. Epidemiological research indicate that school teachers' health may suffer and lead to allergic, respiratory, or nasal condition due to exposure to chalk dust. Therefore, the study was undertaken. Need for study occupationally at this group, like school teachers, are more likely to develop respiratory disorder and that affect the lung, making breathing difficult. Dust can enter lung at any time and cause discomfort or damage to airways. Therefore, this study was conducted to find out the peak expiratory flow rate and respiratory rate in school teachers exposed to chalk dust. Next is aim. To find out the peak expiratory flow rate and respiratory rate in school teachers exposed to chalk dust. Objective is
Sorry,
studying.
sorry, presenter. Thank you for presenting. Can you zoom in because I cannot see very clearly. Can you zoom in, or maybe you can share the full screen?
Please put it in on the presentation mode so that it will be more visible.
Presentation mode, yeah. Okay, thank you. It's okay. I will zoom on my side. No problem. Continue. Continue.
Okay, ma'am. Next, objective studying the peak expiratory flow rate and respiratory rate in school teacher exposed to chalk dust. Methodology, study design, pilot study, study setting, government school, study population, government school teacher, study duration, 1 week, sample size is 5. Eligibility criteria, inclusion criteria, drawing, maths, and science teacher, both gender, male and female. Exclusion. Exclusion criteria, teacher with less than 10 years of teaching experience with the blackboard and smokers. Result, a pilot study was carried out on 5 school teachers in which 3 were females and 2 were males. The mean peak expiratory flow rate was found to be 356 liter per minute and the mean respiratory rate was found to be 21 breaths per minute. Conclusion, school teacher exposed to chalk dust for 10 or more years had higher respiratory rate and low peak expiratory flow rate than the normal values. These are the references. Thank you.
So just I have one question, Dr. Hajita. I just take up question first here. What is your implication? What you suggest to the school or policymaker or something on a larger goal? This is just still a one specific area. What do you think in the larger goal we should be aiming towards? What should be the implications or where you can suggest? What you can suggest? Because it's an occupational hazard. They cannot avoid it if they are teaching.
Yes, ma'am.
Dr. Prerna?
Ma'am, can you please repeat?
Sorry, I couldn't hear you.
Are you on mute? We cannot hear. Or else you can answer in the chat also.
Yes, sir. Dr. Prarena, we request you to answer the question in the chat box. And with your permission, session chairs, we are moving on to the next presenter. And one more presentation is pending priorly. It is Dr. Darshana. Okay, she is not available, it seems. And Dr. Anuradha's presentation was in pending. Sir, she only presented her 4 slides only. So after that, she got her network issue, so she couldn't present. With your permission, session chairs, can we resume her presentation first?
Sure, ma'am. But who's going to present now? Dr. Anuradha or
Dr.
Vishnath ma'am?
Anuradha. Dr. Anuradha, ma'am.
Okay.
Dr. Anuradha.
Sir, can we go with that? Can we continue with Anuradha, Dr. Anuradha's
Yes, ma'am.
presentation?
Yes, ma'am. She actually got technical issues. Now she is online, it seems, and she wanted to present from the fourth slide, ma'am. She mentioned that.
Okay. Sir, are we okay with that?
Sir?
Sir?
Yeah, okay, but maybe
I don't have
I
any problem
kind
in
of,
that, ma'am. If
no,
sir
I'm
is
okay.
okay, I have absolutely no
Well,
issues.
maybe you can just glance again with the first four slides. Kind of so many, so maybe you can just show.
Yeah, we can just go through it once more.
Just maybe click on the first
it is
four.
visible.
From the starting.
It is visible, ma'am.
Yes, ma'am, it is visible. Can you please give a gist of the first four slides so the session chairs have an idea about your presentation, and you can move on with your presentation afterwards.
So I have
Please
done
give a gist.
study. Yeah. Hello. Good evening, everybody. So my topic presentation is correlation between the physical fitness test and the physical fitness index and the body mass index using modified Harvard step test in postmenopausal women. So I have already introduced this. The need for study is the postmenopausal women are at increased risk of various health issues, including cardiovascular disease, obesity, osteoporosis. Understanding how the fitness level relate to BMI can help to identify at-risk population. The alternative hypothesis, there is a correlation of physical fitness index with BMI in postmenopausal women. Null hypothesis, there is a no correlation of physical fitness index with BMI in postmenopausal women. So to find out the correlation of physical fitness index with BMI, you using modified Harvard step test in postmenopausal women. Objectives were to determine PFI by using modified Harvard step test and to assess body mass index by Asian classification of BMI, and third one is to correlate them. Inclusion criteria was the postmenopausal woman more than equal to 12 months of amenorrhea and age group of 45 to 55 years. And exclusion criteria was women with known cases of lower limb pain and dysfunction, women who have undergone any major surgery of lower extremity, chest and spine for last 6 months, women with systemic disease like asthma, IHD and COPD. The materials which are used in this study was the weighing machine, stadiometer, modified Harvard step test with the height of 16.5 inches, that is the 41 centimeter, metronome beat, 30 steps per minute, stopwatch, pen and paper. Methodology, the study design was the correlational study. Study type was the observational. Study setting in and around the Talegaon area. The study population was the postmenopausal women and the sample size was 64. So BMI was calculated after measuring the body weight and height. The PFI was calculated by using the Harvard step test and measuring the pulse rate thrice during the step test, which is valid and reliable tool. So how to do should I explain the modified Harvard step, how to do it?
No need, I think.
So, not needed, na? So the 41 centimeter wooden step was used. So particularly 30 steps per minute sustained for 5 minutes. That is up to the 150 steps. So before starting, we have demonstrated the metronome was used to set signal for every 2 seconds, and the participants were encouraged to continue for as long as possible, but not exceeding the 5 minutes. And the pulse rate was calculated 1 to 1.5 to 2.5 and 3 to 3.5 minutes post exercises. And the physical fitness index was calculated by using this formula. The total duration of exercises in second into 100 divided by 2 into sum of the pulse count during the recovery. So PFI rating for the females, so we have calculated if it is a more than 91, then the PFI was the excellent. If it is in between the 84 to 91, then it is a good. And if it is in between 77 to 83, it is a fair. And if it is less than 77, the poor. And the body mass index, we have calculated according to the Asian BMI classification. If it is less than 18.5, underweight, normal range 18.5 to 22.9, overweight 23 to 24.9, obese 1, 25 to 29 point, and more than 30 is grade 2 obesity. So approval was taken from the Institutional Ethics committee before starting this procedure. Participants were selected according to the inclusion and exclusion criteria. Written informed consent was taken from the individuals. Height and weight was measured. Physical fitness was index was determined by the modified Harvard step test, and analysis was done during the with the Spearman correlation coefficient. So in this study, the mean age was found to be of 51.65 plus or minus 3.46. Out of 64 participants, 24 were belongs to the age group of 45 to 50, and the 40 were belongs to the age group of 51 to 55. And the mean BMI was found to be at 24.8 plus or minus 3.36.
Anuradha, sorry to interrupt, and you are exceeding your presentation timing. It would be great if you could wind up really soon.
Okay, okay.
Yeah,
okay.
thank you.
So 21 belongs to grade 1 obesity, 4 belongs to the grade 2 obesity. And the mean PFI was the 81.62, and in which the PFI which showed 21 showed the excellent PFI, 21 showed the good PFI, and 22 showed the poor PFI. So Spearman correlation coefficient was computed to assess the relationship between the PFI and BMI. So there was a negative significant correlation between the two variables. So R is equal to minus 0.862, which indicates as the BMI increases, the PFI decreases and vice versa. And t-test also showed the statistical significant correlation, that is minus 13.5. So discussion, this study showed the statistical significant negative correlation between the PFI and BMI. So due to reduced estrogen level during the menopause, there is a shift towards the abdominal and visceral fat accumulation, leading to an android. There is a male-like fat distribution pattern in postmenopausal women. This may affect overall the physical fitness and the health. Additionally, there is a reduced exercise tolerance and impairment in the maximal aerobic function when compared to the age-matched premenopausal women. This finding suggests that the menopause may lead to both the reduction in the muscle mass and decline in the aerobic capacity, both of which negatively affects the physical fitness in this population. And the findings also align with the previous research by Nielsen, which have also found the negative correlation between the physical fitness and the quality of life in postmenopausal women. And exercise can potentially improve both the physical fitness and the quality of life in this population. Again, in the menopausal woman, estrogen is a vital for maintaining the skeletal muscle function. So estrogen level is going to get decreased in this population. So the study which have done the Bonder wave, which suggests that the postmenopausal women experience decline in the muscle
Dr.
mass.
Anuradha, we request you to stop your presentation since the time limit has been done.
Yes, yes, these are my references. Thank you.
Okay, Anuradha,
Yes.
you have verified Harvard step test, right?
Yes, yes.
And it is, if I'm not wrong, an endurance test?
Yes.
It is an endurance test, right? Okay. So now my simple question is that in postmenopausal females, you could have used a more eased out endurance test. Why modified Harvard? Because modified Harvard is even difficult for normal healthy young adults. So why are we using something of this sort for a postmenopausal female who is probably, her age is like more than 45 years, I guess?
Yes, 45 years, yes. 45 to 55.
So why?
Because
why are
this
we
test,
using such a test for?
because
Yes.
this test gives the cardiovascular endurance also, and even the muscular strength endurance also. So we have taken this test, and it is a valid and reliable for the physical fitness index we are going to find out. So that we have
What was
chosen
the
this
maximum step? What was the maximum number of step that you got for this category of females in your
So
modified
81,
Harvard
we
test?
have got the 81. So which is the
81.
most higher. Yes, ma'am.
So if we look at the modified Harvard test and a score of 81, that is not even average for a female. Like, the average also goes above 90. Sir, I would like to take sir's help in this because I don't remember the entire
valid values for Harvard test, but this is what I feel, that the Harvard test average values are like 90 for females.
No, ma'am.
Sir, can you please help?
If it is a more than 91, then it is an excellent PFI. Excellent PFI we didn't get, but poor and fair PFI we got, which is the 70.
So in all the females you got like, yeah.
Yeah. Yes,
okay,
ma'am.
so for all the females you received poor, or like
no,
there was somebody in average score as
yes,
well?
19 we have got the fair PFI. Excellent we didn't got any woman, but fair we have got. The 19 women we have got the fair, and 21 we have got the poor PFI, and average we have got the 40 females. Yeah.
Okay, brother, thank you.
Yeah,
Sir,
thank
please,
you.
in case you have any questions.
No, I think you brought it point. I was also going through that. There's no specific concept there discussed by us. Maybe you can look into what Dr. Ajita has suggested. And thank you for your presentation. Excuse me.
Thank you.
Thank you for your presentation, Dr. Anuradha. And we are moving on to the next presenter. So it is Dr. Shambho Sangabi. Dr. Shambho.
Hello. Yeah, hello. Good evening, ma'am.
Hi, sir. Good evening. And please proceed with your presentation, sir.
I'm not able to share the document. Would you please assess me through that?
Sure, sir. Sure.
I'm actually sharing the same, but it's not able to.
So please share your presentation with us so that we could present also. And you can share it from your side also, sir. Do you have any technical issues?
Yeah, it's just a technical issue. If you can continue with the next one, I will just be getting back to it within a 5 minutes time.
Sure, sir. It can be done. And if you could share your presentation, we can help you with that also. Dear session chairs, with your permission, can we move on to the next presenter?
Sure, please go ahead from my side. No issues.
Yes. The next presenter would be Dr. Rishab Sarana.
Hello, everyone.
Hello, Dr. Rishab. Please go ahead with your presentation.
Yes.
Dr. Rishabh, are you present?
Ma'am, is it visible?
No, not yet, sir. Yes, sir. Your screen is visible now. Please start your presentation immediately.
Hello, ma'am. Is it visible?
Yes, sir. Yes, sir. It is visible. Please go ahead with your presentation, sir.
Good evening, everyone. So, my title for today's presentation is Assessment of Validity of Smartwatch as a Tool for Assessing Oxygen Saturation at Rest and with Activity. Introduction. SpO2 is a measure of amount of oxygen carrying hemoglobin in the blood. Body maintains its healthy SpO2 level through breathing. The lungs takes the oxygen and binds it to the hemoglobin. Normal SpO2 percentage should be between 94 to 100%. The principle which the watch and pulse oximeter use is spectrophotometry to assess the SpO2. Spectrophotometry basically uses light sensors to record the blood carrying hemoglobin. Light at two separate wavelengths illuminates oxygenated and deoxygenated hemoglobin in the blood. Pulse oximeter and smartwatch both works on the same principle. I'll move to the next one. So the need of study was After COVID, there was an increased trend towards the awareness related to fitness and self-monitoring, which has led to increased use of gadgets. However, inappropriate use of wrong monitoring system can be misleading and sometimes can be proven hazardous. There are no studies for the validation of a cost-effective Android watch despite its widespread use. Most of the other measures are expensive and cannot be easily accessible to people uh, of all socioeconomic strata. Hence, the current study has been designed to evaluate its validity as a monitoring device for SpO2. If found valid, people can have an assessment on its own. So, the aim was to establish the validity of smartwatch as a tool for monitoring SpO2 at rest and with activity in healthy asymptomatic subjects between age group of 18 to 25 years. The objectives are to assess the SpO2 using finger pulse oximeter and the watch at rest. And the second objective is to assess the SpO2 using finger pulse oximeter and the watch after activity. The methodology or the study type is, so study population is healthy individuals between the age group of 18 to 25 years. Sample size was 191. The type of study was cross sectional. The inclusion criteria for my study was healthy asymptomatic individuals between age group of 18 to 25 year. Hello, yes sir.
Yeah, we can hear you. We can hear you.
Okay. Both male and female. Exclusion criteria: individuals with any history of cardiac conditions like congenital heart disease, arrhythmias, heart block, ischemia, etc. Individuals with any respiratory illness, or individual with any recent musculoskeletal impairment. I'll explain the procedure in short. The consent was taken. The population was decided according to the inclusion and exclusion criteria. In this, we have used 6-minute walk test as a submaximal test, which is the activity to be performed. So we allowed the participant to sit on the chair and relax for 2 minutes. The SpO2 was calculated with both the devices, and then after 6-minute walk test, the SpO2 was again calculated immediately to check if there is any significant difference noticed. The results were calculated using Pearson's formula, and the graphical representation also shows the age-wise distribution of the respondents, the gender-wise distribution, cross-tabulation of both age and gender. The table one shows cross-tabulation of both age and gender levels. So it was 45% female in our study and 55% male population was taken into consideration. Descriptive statistics. So at rest, the normal measurement should be minimum 94. So at rest, pulse oximeter and smartwatch, both readings were taken. The maximum reading obtained for pulse oximeter was 100. The maximum reading obtained for smartwatch was 99. The mean reading recorded was 97.72, and for smartwatch it was 97.53. After activity, pulse oximeter reading was recorded maximum was 100 and smartwatch was again 99. The mean reading after activity was 97.91, and for smartwatch it was 97.17. It is also shown in a graphical view in graph number 3. So now moving towards the analysis. So in analysis, we have found out that at rest, the pulse oximeter and the smartwatch correlation, that is the Pearson's correlation, was around 0.53. The p-value, significant p-value, which we got for pulse oximeter and smartwatch at rest was 0.001, and the normal value was 94. Uh, After activity, the values changes. The Pearson's correlation was 0.017 and the significant p-value noticeable was 0.869. There is a graphical representation of positive Pearson's correlation in rest. Moving to the discussion, as I have mentioned, the graph 1 shows the age-wise distribution, graph 2 shows the gender-wise distribution, graph 3 shows the standard deviation from the SpO2 level. The thing that is important, just a minute, I skipped one thing, was table 3, which shows pulse oximeter and watch value at rest. So at rest, a significant positive difference is found between the pulse oximeter and a smartwatch. The correlation between them is close to 54.3% at 95% of confidence level. So, and after activity, which we have seen in table 4, no significant difference is found between the pulse oximeter and smartwatch. That is why there is no correlation is also not effective at a 95% confidence level. Graph 5 and 6 indicate that the divergence in the reading from the pulse oximeter. I'll show you the graphs 5 and 6. The bottom one, both the at rest and at activity. So pulse oximeter and water is not constant. It might be affected by the skin type, speed of walking. Also, I would like to mention the usual level of physical activity of the participant was not taken into consideration initially. To find out the validity comparison between the SpO2 reading on pulse oximeter and smartwatch, it was found that the p-value at pre-activity reading of pulse oximeter and smartwatch is less than 0.05, which is proved to be significant positively. And after activity, it was more than 0.05, which is considered to be a non-significant value. The conclusion after this study concludes that the smartwatch validity is valid for assessing SpO2 at rest, but not after submaximal activity. I am mentioning submaximal activity because 6-minute walk test is a submaximal level test. These are the references. Thank you, everyone.
Okay,
Thank you, ma'am.
Dr.
Thank you,
Ajit,
sir.
I'll go first. Sorry, just maybe I'm a bit inquisitive because we also something explored quite long back. But in the respect of time, okay, thank you for your presentation. Let me get back the name here. Okay,
Yes,
thank you,
sir.
Rishabh. Yeah,
Yes,
thank you,
sir.
Rishabh. Yeah, Rishabh Surana, I can read that. So I got engrossed in your study. So you feel that this study like this was not done on the normative population earlier, is it?
Sir, when I started, so there were study which were relating the pulse oximeter significance,
Mhm.
which should be done. So pulse oximeter was taken as a standard in this study because there were many studies that were done on pulse oximeter. But the daily in our daily living, we are using either the pulse oximeter, which is also rare, and smartwatch are providing this function nowadays. So after COVID, people were very interested in no maintaining this SpO2 levels. They were checking again and again their SpO2 level, but there were no significant result for this watches to be proven that the value should be considered. It was initially started because when uh, I have came across an article in which they were using a smartwatch. So in a when the person's SpO2 levels are very fluctuating, the watch was showing no result. There were no result found in the watch. So I was therefore interested in doing this.
Fine. So I just have only one thing. Not actually, I got a couple of questions because we also conducted 4 years back, but I'm not going there because it will take your time. Then it was a sponsored research, or like how many watches you used? I'm not asking you to name the company of the
No,
watch, but
no,
like
no.
can you tell a little bit about
I
how you
have
create the
maintained.
cohort. Yeah.
So I have used only a single device. I have for all my participants because when we were going across, so which should be we have when I started, I tried using 2 watches, but I have not found any what would I say that it would be a better. So if it will be better if I go for one single device. I thought that. So
So
I
you
have
have used
conducted the whole
different.
study.
You have used
No,
different watches.
single study, single watch through for all
Single watch.
participants.
And total
Yes,
participants were
191.
191. Single watch you use. So you created cohorts, is it? I'm trying to learn the concept. How did you do that? I'm learning from you. I'm
Uh,
not listening right now. Yeah.
so it started. I have taken both the readings. I have gone through articles. So there are articles.
I'm sorry. I think I will stop here. Maybe you can text me in the chat box later because
Yes,
it
sir.
take good. All the best. It's data is a bit difficult to interpret and to follow to get the watch back. I understand the difficulty somewhat. Okay. All the best. Thank you for your presentation.
Thank you.
Thank you, Dr.
Rishabh,
Rishabh. Yes,
I
ma'am.
have
very small question. Gopika ma'am, you were saying something?
Yes, ma'am. You have any questions for this presenter?
Yeah, I just want to know one thing, Rishabh. Like you said, you have used only one watch,
Yes,
right?
ma'am. You are not
Launch
audible.
their watches. Okay, just 1 second. Okay, now am I audible?
Yes, ma'am.
Hello? Yeah, okay.
Yes, ma'am.
So, Rishabh, when good company watches are being launched in the market, they usually give you an approximate value that up to what level the accuracy is present in their parameters that they're measuring. So, the watch that you used did not have any such accuracy reports or something like what did they report? How much accuracy did they report in their SpO2 levels?
Yes, ma'am. Good question. Ma'am, so the watch I was using for this participant, in market, the watches which are available, the maximum was 94% of accuracy.
Okay.
Compared to the standards of the spectrophotometry, and the pulse oximeter which we are using is at 98% of accuracy according to the articles.
Oh, okay. So both of
But
them do not really, yeah, both of them do not really have a reported accuracy level of the same power. Like one is 94% and the other is 98%.
98. So there was a significant difference between the values, and the ideal considered value for measuring pulse oximeter is considered to be 94. So these watches were able to launch with an SpO2 feature, but they were not as significant as pulse oximeter. So my project started from there only to find out the correlation, how much significant it is in daily life.
Okay, and what was your result? Was it the same that the market has quoted?
No, ma'am. So I have found that at rest it is around 97% accurate, but
Yeah. Yes.
after activity it is not that significant, because the correlation which I was getting was varying too much.
Okay. So
After
Rishabh, let us talk after the presentation. Let's file a complaint in the consumer court against this company now, because this is what I'm trying to say here is that there are so many products in the market, and what you have done is an amazing job. If you can actually get through such kind of devices, they're literally fooling people. I have seen so many people wearing smart watches and thinking that this is the ultimate tool to measure their fitness.
Yes.
Whereas it is not true, especially for people who actually need to get their SpO2 levels checked, especially while they're working out. The cardiac cases, the pulmonary cases, for whom the SpO2 level during workout is really important. And these companies tell them that we have a nice high accuracy rate while you're working out, which is not true. So what you have done is actually a good job. Why don't you just prolong this and just go through some more such devices, not just smartwatches?
Yes, ma'am. Yes, ma'am. I'll try.
It was a good topic. Thank you for presenting this, Rishabh.
Yes. Thank you, ma'am.
Thank you, Dr. Rishabh, for your presentation. And we would like to circle back to the presenter, Dr. Shambhav Singhavi. So, sir, are you online?
Yeah, hello. Good evening. Can you hear me, ma'am?
Hello, sir. Yes, sir. Please go ahead with your presentation.
Is my presentation visible, ma'am?
Not yet, sir.
Share it. How, ma'am?
I think yes, can see.
Yes, sir. It is presenting, and please go ahead with your presentation.
Okay. Good evening, everyone. Today I'm going to present the topic that is effectiveness of 3 weeks of PNF, that is proprioceptive neuromuscular facilitation pattern, along with neural mobilization versus neural mobilization using cervical radiculopathy impact scale in cervical radiculopathy patient age 40 to 60 years. That is a randomized control trial. As we already know that the cervical radiculopathy is a common condition in which the pain and the symptoms usually get through the arm, chest, upper back, as well as shoulder. The nerve involvement can result into different kind of symptoms leading to an tendon reflex, reduce in the tendon reflex, along with there could be a progressive decrease in the performing activities of daily living, in which we have found that the epidemiology was about 83%, 83 individual in about 10 lakh individual, in which the highest population for cervical radiculopathy was found in between age group of 40 to 50 years of an age group, in which cervical radiculopathy, the most common nerve area that is getting impinged is about in C7 area, which has been followed by about C8, in which the need for the study was already there was various different technique used along with PNF to find out whether which technique is best being used for treating cervical radiculopathy. So the main aim of the study is to compare that PNF along with neural mobilization is better or neural mobilization given alone given better for treating cervical radiculopathy patient. The objective of the treatment is to assess the similar thing that whether PNF is better along with neural mobilization or neural mobilization is better. The study was been a randomized control trial in which the patient were being collected from physiotherapy department. The study was being conducted for about 18 months, in which the age group was being taken from 40 to 60 years of age group. A total of 42 patients were being selected and they were being classified into two groups. That is group A containing of 21 patients, group B containing of 21 patients, in which the inclusion criteria include age group of 40 to 60 years, in which pain intensity score was more than 3 on NPRS, in which upper limb tension test positive for median nerve tingling numbness in subacute or chronic patient. The patient who have been excluded were thoracic outlet syndrome, any nerve injury, any previous history of cervical or thoracic spine surgery, and any use of current steroidal index. The result usually shown, the comparison was being done intragroup and intergroup. The intergroup comparison of group A, in which PNF pattern D2 flexion extension was being given along with NDS, in which the result showed significant improvement. Similarly, in group B, in which only neural mobilization alone was been given, which is been already proven that it has been helpful in treating cervical radiculopathy. It was also showing the same result, that it is significantly improved. Whereas intergroup, in which we have compared group A along with group B, which shown that the group A has better result, slightly better result as compared to group B. So PNF when given along with neural mobilization, PNF D2 flexion extension pattern when given along with NDS has shown to be more statistically significant as compared to when NDS has been given alone in cervical radiculopathy patient. That means D2 flexion extension pattern are effective in addressing the functional limitation associated with cervical radiculopathy, particularly for improving range of motion, strength, neuromuscular control in upper extremity. Incorporating D2 flexion extension pattern, patient can restore normal scapulothoracic and glenohumeral mechanism, leading to a cervical alignment. Thus, D2 flexion extension pattern combined with neural mobilization is more effective than neural mobilization alone in treating cervical radiculopathic patient. The study concluded that when we are trying to give D2 flexion extension pattern along with PNF, the outcome measure that we use were CIRS, that is cervical radiculopathy impact scale, NPRS, and elbow range of motion, in which all the three outcome measures usually showed there was slightly better improvement in PNF when given along with neural mobilization. These are the references. Thank you.
Thank you, Dr. Shambhav, for your presentation. Dear session chairs, you have any questions for this presenter?
Okay, thank you for your presentation, Sambhav. Dr. Sambhav, maybe just can tell me the rationale and the reason why the improvement has been observed? Just only that question.
Yeah, sir, as we know that D2 flexion extension pattern has been helpful in improving the neural control as well as helps in improving strength, neuromuscular coordination. The defect when there is cervical radiculopathic patient and severe patients are there, they usually have an affect the upper kinematic chain. Basically, the scapulothoracic humeral rhythm is affected. The upper limb has been usually affected because the nerve root has been impinged, and that particular nerve root supplies the muscles. Therefore, there has been weak muscle as well. So the D2 flexion extension pattern that we usually use in the neurological condition is helpful improving the strength, the neuromuscular coordination, the upper kinematic chain. Therefore, the study has not been ever conducted in which D2 flexion extension pattern is being used in cervical radiculopathy. So this is why the reason. Along with that, one more reason, rationale for using D2 flexion extension pattern particularly because the ULTT test we usually do, the compression, the swirling, the ULTT1 test that resembles the combination and the components of testing the ULTT1 are similar to those of performing D2 flexion extension pattern. So this is the reason why I've taken D2 flexion extension pattern.
Okay, thank you from my side, Dr. Rajita. If you have any question, you can ask.
Yeah.
Thank you. Thank you.
No, I do not have any specific questions for you. Thank you so much for presenting.
Thank you so much.
Thank you, Dr. Shamba, for your presentation. And here we are for a last presentation. It is Dr. Nazia Ali on the topic Social Pragmatic Communication Disorder and Occupational Therapy Approach. Dr. Nazia?
Yes, ma'am, I'm there. I'll be presenting.
Yeah, please go ahead, ma'am. Dr. Nazia? Dr. Nazia, are you online?
Yes, ma'am.
We couldn't see your presentation, ma'am. It would be great if you could present as soon as possible.
Just a ma'am, I'm sharing the screen.
Yes, please.
Yes, we can see your slides. Dr. Nazia, we can see your slides. You can start now. Thank you.
Yeah, is it visible? Yeah. A very good evening to one and all present here. Today, I, Muskan Bamral, a student of Jamia Hamdard, will be presenting on the topic Social Pragmatic Communication Disorder and Occupational Therapy Approach. Talking about what exactly is social pragmatic communication disorder, it is basically a neurodevelopmental disorder that is categorized by persistent difficulties in the use of verbal and non-verbal communication for social purposes, which has no underlying cognitive deficits. The symptoms of such disorder include difficulty in the acquisition and the use of spoken and written language, as well as problems with inappropriate responses in a particular conversation. For example, the person would not have the initiating cues, or he would not be able to continue a particular conversation for a longer period of time. The disorder also shows its effect in communication, the social relationships, the academic achievements, and ultimately the occupational performance of an individual. The symptoms must be present in the early developmental phase of a child, wherein he learns to speak and knows about the language. The emphasis will be led on the interplay between linguistic, cognitive, social domains, which are going to contribute to these difficulties. The main rationale of this study is that SCD is a recently recognized condition with its profound impact on the daily life, academic performance, and social integration, and has been given a special mention in the DSM-5 recently. The occupational therapy intervention will help these patients so that they can participate in their activities of daily living by improving their social communication and their pragmatic communication. So the current study is going to address the need for improved diagnostic tools as well as effective and tailored OT interventions for SCD. The aim of the study is to enhance the diagnostic precision and to provide an effective occupational therapy intervention for such individuals, and also to explore the impact, like to what extent this particular disorder could impact the various arenas of life, be it social, academic, and daily functioning. It also focuses to highlight the intervention, which is going to take a holistic approach, considering the sensory integration, the social skill training, and the pragmatic language development. Now, the common misconception which is there is what is the difference between social pragmatic communication disorder and other communication disorder? And the most common thing is ASD, which is autism spectrum disorder. Both of them shares the communication difficulties, but the key difference lies in the fact that autism spectrum disorder consists of RRBs, which is repetitive restricted behavior patterns, which is generally seen in such individuals, whereas SCD focuses on just the communication, wherein it talks about the pragmatics and the verbal and non-verbal cues of a particular communication setting. Moreover, the developmental onset of ASD is typically recognized in the early childhood before the age of 3 years, with an exception to virtual autism, whereas social pragmatic disorder is identified later in the school-age children, wherein they learn to talk about language and they start speaking. For assessment and evaluation, the standardized tools which are used are the children's communication checklists and the social communication questionnaire. These two focuses on the communication behavior and the social interaction deficits that people face. And in the occupational therapy, we are going to focus on the sensory integration aspect, the social skill training, development of the pragmatic language skills so that the social functioning can be improved. Talking about the role of occupational therapy, so it is going to contribute significantly in improving the interaction skills and enhancing their participation in activities of daily living, from workplace to school, etc. OT intervention often focus on sensory integration, social skill training, and the development of pragmatic language skills to help such individuals. And the primary goal is to enhance their participation in everyday activities by addressing whatever deficits they are having in their social interaction and the related areas. The various domains that we need to focus on is the social problem solving, wherein a therapist is going to guide the individual in understanding and managing a particular social situations, wherein they might lack some certain cues in initiating, and it also involves resolving the conflicts which happen because of misunderstanding. So handling of misunderstanding in a particular social interaction is very important. The second thing is pragmatic language skills. So the therapists are going to work on teaching the rules of conversations. How are you supposed to start a particular conversation, which involves initiating and maintaining a conversation, turn taking in a particular conversation, and maintaining the conversational cues and also the non-verbal cues, the body language, the maintenance of eye contact, etc. It also focuses on role play and simulated social scenarios, wherein a particular simulated social environment is being created that helps a particular client in order to express them better and be more confident in a particular social situations. It also uses the acquisitional frame of reference so that the person is able to know their role in a particular social settings and make them easy to communicate in a real life situation. It also focuses on building relationships, wherein we focus in helping individuals to understand their own social roles, maintain a particular relationship, and engage appropriately with their peers, their family members, and others in the community. In conclusion, I'd like to say that now SPCD has the distinct features and characteristics, highlighting its clinical importance as being outlined in the Diagnostic Statistical Manual, 5th edition. So by fostering greater awareness and understanding this disorder better, this study aims to contribute to improved diagnostic precision and tailored intervention using occupational therapy, which is going to address the unique needs of individuals, ultimately enhancing their quality of life and their social functioning so that they can better contribute in the particular life. These are my references that I've used. With this, I'd like to conclude. Thank you.
Thank you, Dr. Nazia, for your presentation. And your session chairs, you have any questions for this presenter?
Ms. Nazia, Dr. Nazia, thank you for your presentation. Maybe can you talk about the interventions a little bit more in detail from occupational therapy perspective? Would like to know more.
Dr. Nazia?
Yeah, so basically in the occupational therapy interventions, we are typically going to focus on developing like the basic difference between occupational therapy, because communication is something which also falls under the speech therapists. So the basic difference is that they are going to focus just on the formation of words in the language, but occupational therapy will help individuals to start their particular conversation and also help them to maintain a particular conversation. For example, people certain times lose eye contact while they're doing that. And also, like, we are going to focus in a holistic manner so that we can address each and every problem that they're having. They might have certain conflicts regarding a conversation, they might misunderstand. Also, in a conversation, it is important that both verbal and non-verbal cues are taken care of. So all these things have to be maintained. And we also use certain frame of references like social frame of reference and acquisitional frame of reference, which helps an individual in order to understand what exactly are they supposed to do in a particular social setting. Where do they have to be a sister, or where do they have to be a daughter, or how do they have to act in a particular school setting? So what is exactly their role in a particular social setting? So explaining them this in a particular simulated environment where they're better able to understand their particular role.
Okay, fine. So just in that regard, maybe you can show me again the intervention. That's the last question, maybe from my side.
Yes, ma'am. Sure, I'll show you.
Yeah, sure.
Just a second.
Because you keep on using one term, pragmatic is one of the practical part. I understand. Maybe just would like to know how is done in the pragmatic approach, that concept, pragmatic one. For a common man, how you'll explain this pragmatic language skill and so it's all about the gestures, body language, and how they hold up the conversation if it's going up and down, out of the blue, how like it's non-verbal.
Yeah, basically. Yeah,
Yeah.
ma'am. Basically, pragmatic language is their ability so that they can use their language in a way which is appropriate in a particular situation. Like when they are supposed to say, how they are supposed to say, and what they are supposed to say. And in pragmatic language, we also include the non-verbal communication, which involves the facial expressions, the eye contact, and their body language.
These are also measured in the outcome measures. You mentioned that?
Yes, ma'am. I've mentioned that. Pragmatic language skills. Yes.
Okay, it's a very practical word there. Okay, fine. So what's your implication? Apart from the study population you have studied, do you think this is good for those who have the issue in social circumstances?
Yes, ma'am. Actually, it is important to differentiate this particular disorder because nowadays this disorder falls under the communication disorder, or certain people misunderstand it as autism because they are not able to speak. So that goes into that particular disorder. But it is important to address that this is a specific issue wherein people might not have problem with speech. They know how to speak, but they're not able to express themselves. They don't know what to say, when to say, how to say. So it has to be differentiated from that. And as a recent mention in the DSM-5, it is important to, mention this particular disorder so that we can have a tailor-made intervention for each individual to help them better adapt in their life.
So it has been recently adopted in DSM.
Yes, ma'am.
I think they're coming with DSM-7. Okay, fine. Thank you. Something new learned and approach. Okay, good. Thank you, Rapnazia.
Thank you so much, ma'am. Thank you.
Okay.
Thank you, Dr. Nasia. And Dr. Ajita, you have any questions for this presenter?
Nazia, this is a very new topic for me, and right now I have absolutely no questions, but you have given me a lot of food for thought, and probably I'll just go and read about it now because this is something which I have been facing when I treat children with Buteco, but then I never tried exploring this aspect of communication. I'll definitely go and search about it and read a bit about it. It's a very good topic. Thank you for presenting it. And I have no questions as of now. Thank you.
Thank you so much, ma'am.
Thank you, Dr. Nazia, for your presentation. And it has been a wonderful day. And we just wanted to call Dr. Darshana. Are you available? Dr. Darshana? This is your last call. Okay, she might be having some technical issues and she is not present here. And here we are at the end of the day one of Rehab Conclave 2024. And it has been our pleasure having you here, attendees. And on behalf of BioLeaks, we would like to thank our honorable keynote speakers from this morning and our sweetest session chairs of this session. Thank you, Dr. Tarun, and thank you, Dr. Ajita, for your presence. And it has been our great pleasure to have you here. And thank you, everyone, once again. And we will be continuing this session tomorrow again. And please be present there. And thank you, one and all, who have been honoring our BioLeaks here. Thank you, everyone. Have a good day again.
I'll just take 2 words here, Ms. Dr.
Sure, sir, sure.
Yeah, thank you for having this presentation. Quite a lot of number of things. I mean, like quite a lot of things we learned, observed. Quite the students have, not students, all the professionals have tried their best. They were prepared. Of course, there are some questions, suggestions. So please take those questions and suggestions just to improve some things. With the 10 minutes of time, we have to ask. There are so many questions for sure we have, especially if the topic is quite relevant, new, and those. But we have to respect the time, cannot take. So fine, well organized. Maybe those who couldn't present, maybe they can present tomorrow, or can answer those who couldn't answer because of technical difficulty in the chat box. Or that's all is on my side. Thank you for organizing this.
Yes, thank you, sir. It has been our pleasure. And Dr. Ajita, you have any it would be great if you could share a few words with us regarding this session.
Gopika ma'am, first of all, thank you so much for having us here as the chairs. And frankly speaking, seeing so many students as well as professionals getting into research, thinking so hard, bringing up such new and innovative, novel topics, this is just amazing. Like it isn't something like we are not trying to judge them. We are not trying to we are not at a superior place sitting and watching them. It is more like that we are sharing each other's knowledge. They have literally given us so many new things to think about, to search about, and all these speakers were amazing. They have tried their level best. I wish them all the best. A few suggestions, as sir said, just take them positively. It is just our view that can actually, you can do something better with what you're already doing. But frankly speaking, the efforts are really appreciable. These people who have just presented their topics have done a wonderful job. It's good to see so much research in our field. Thank you so much for having us, and looking forward for tomorrow's session.
Yes, ma'am. So let's meet again tomorrow, participants and dear session chairs. Thank you for your feedback. And please be present on time tomorrow, and you will be notified accordingly through your email and WhatsApp. Please stay tuned in that, and we will be notifying you there. And thank you once again. Have a great day ahead. Bye.